past president of Pune Ophthalmological Society. His area of interest is on stem cell transplant. Dr. Saroj Bande ma'am, she is a senior consultant in anesthesia at KEM Hospital and NIO Pune. Her area of interest is high-risk obstetric anesthesia, pediatric anesthesia, and liver transplant. Dr. Jignesh Tashwala, he is Vice President of Maharashtra Ophthalmological Society, past President of...
Ma'am, we cannot see the screen.
No, it is very much there. It is very much there.
No, we can't see your slides.
We can't see.
We can't see, but we can't see.
Okay, I'll
None
stop.
of us is able to see.
I'll stop share and maybe I'll share it again. Now, can you see my slides?
Yeah, now we can.
Yes.
Now it's visible.
Okay. Dr. Jignesh Tashwala, he is a Vice President of MOS, past President of POS, and he is practicing at Darshana Eye Care Center. Dr. Pradeep Damle, he is a Director of Lions Eye Hospital, consultant at Mahatma Gandhi Hospital and Symbiosis. His area of interest is low vision aid. Dr. Vishali Varat, myself, practicing at Sai Eye Allergy Hospital, Sahkar Nagar, and area of interest is ocular allergy. So, with permission of Chairman and Co-Chairman, may I request Dr. Gitanjali Sharma ma'am to present her talk?
Yes, Rishali, you would have to stop.
Yes.
Is it visible?
Yes, ma'am.
Yes.
Okay. We have just now listened to Dr. Raman Gangakhedkar sir. My talk is about precautions and positivity. That's the way to beat COVID. As he said, all over the world, scientists are working for the proper drug for cure of COVID. We are not yet successful. Even about the vaccine, there is efficacy, but to some extent. So we are not 100% successful. So how we can beat COVID? From Jan to March 2020, I go back to those days when I was just about to take the presidency of Pune Ophthalmological Society. In Jan, the news came of COVID cases in China, and we had to cancel POS trip to China to attend APAO conference. On 9th of March 2020, the first positive case of Pune was detected. There were reduction in the cases by Jan 2021. And today, if you see, again, the cases have increased more than 3,000. So my presidency and pandemic started together. There were challenges before taking up presidency because handing over was a problem. APO cancellation with refunding everyone's money was a problem, but I could do it. All the new team that was formed, we were not knowing each other. We were not able to meet each other physically because in March, third week, lockdown was detected. 144 was implemented. So we were not able to meet each other. And then there were some phone calls telling me, Gitanjali, your destiny is bad. You are not able to do anything. And somewhere it struck me. Destiny, I have to make. I have to remain positive in this. So what if it is COVID? April 2020, there was this fear factor due to lockdown. There were no maids, no helping hand, no servants at home. Everything we had to do ourselves. Government made a policy for doctors to open their clinics, especially the private doctors. So I was working. And then I was thinking again and again, what should be the role of POS now? I have to think because I'm the president. Will it be a 0 year, doing nothing for the year and just blaming the COVID? No, we have to accept, we have to change, and we have to innovate. And that's how our first webinar on 11th April 2020 we did. Remember, friends, handing over occurred just on 5th of April was the AGM date. So within a week's time, we tried to organize a webinar just forgetting all the planning done before that. We didn't know anything about Zoom. We didn't know anything about online meetings. We practiced and did a successful webinar on 11th April. That gave us confidence. That gave us the positivity. Life is the series of natural and spontaneous changes. Don't restrict them. Let reality be reality. Let things flow naturally forward in whichever way they like. The world as we have created, it is the process of thinking. It cannot be changed without changing thinking. That's what Albert Einstein said. And we changed our thinking. If the members cannot come for our seminars to some venue, we have to reach their places. So we started reaching house of every member of POS. We meet, we laugh, we cook, we dance. We reach each other with our videos on. These were the lines created by Dr. Mukesh, our secretary, in a poetic way. I do take credit that I influenced him write poetry in this year. So what if it is COVID pandemic? What lies behind us and what lies ahead of us are tiny matters to what lies within us. Positivity and the fighting spirit I had in me. As you all know, I had won the election also to take this post. So I was to live up to my role. लहरों से डरकर नौका पार नहीं होती, कोशिश करने वालों की हार नहीं होती. That's what we decided, three of us, myself, Dr. Mukesh and Dr. Sachin, and we started working positively for POS. So this was an historical year for us. We did everything first. It was the first virtual installation of us, first national or international competitions organized, first time all academic, non-academic activities on virtual platform, first time a daily blog was started for POS, keeping peace, mind and body. We did a very, very successful first virtual surgeon. That was an acid test for us. Right since morning 8 o'clock till 5:30 in the evening, 60 surgical cases were shown as videos, flawless, without any problem. And now we are organizing the first virtual annual conference for POS yesterday and today with a very successful first virtual skill transfer course, which we did yesterday evening. There were musical programs, there was Deepa Stamba, there were painting exhibitions, you name it, and we did everything virtually. So this was our installation. It was nothing less than a film award show, I would believe. In fact, whenever I watch that YouTube link again, it gives a great pleasure. It may not have the ambience of a 5-star venue, I feel, or 5-star hotel, but this was more close to my heart. So there were various ideas, positive ideas, and we tried to implement them. So it was ideas to impact. So whether it was MasterChef, whether it was Deepa Stamba musical show, and this program, World Sight Day program, I believe you all remember this. I'm going to show the next photo. See the first row. You are seeing Dr. Sangeeta, Dr. Namrita from AIOS, myself and Dr. Mukesh. We are the eye surgeons over here. And rest of them are partially blind people. But in this program, these people gave us the vision. We realized we are just cribbing about small things. They are the people. They have lack of vision. Still, they are doing so much positive in life. Let's have that positivity with us. And we fight back. This was Deepa Stamba of Deshpande, sir. I told him, sir, your work in the field of eye surgery, in the field of vision, in the field of blindness, I know. I want you to speak about your army life, because that's how we'll get the fighting spirit against COVID. That's how we'll get that positivity of mind. Sir explained about his paratrooper life, and I think that was the most inspirational thing for us. Jeevan se bhari teri aankhein. This was another innovative idea of musical show for people to fill their eye donation pledge forms. We didn't want to stop the eye donation drive. We did a lot of things for eye donation. These songs were all related to Aankhein, and it was seen by people from US, Australia, Dubai, everywhere. And people have filled up the eye donation pledge from there. Deepa Stamba with Dr. Kelkar sir was another inspirational story. So this was the eye donation thing. Poetry competition we organized, slogan competitions we organized. We spoke from Radio Mirchi. Everything we tried, because this year we could not do the physical cycle rally or physical walk. But I think we reached more people through these activities and we got more response. The ultimate measure of a man is not where he stands in moments of comfort and convenience, but where he stands at the time of challenge, said Martin Luther King. And I totally believe. We organized an innovation video competition because we ourselves wanted to learn how innovative way we can protect ourselves in OPD and in OT. We received 70 videos from all over India. All those OPD and OT innovations we are utilizing now. So this is how to protect ourselves, to take precautions. These were the new normals, and as Dr. Ganga Khedkar sir said, maybe we'll have to continue till 2023. We don't know. More than 40 programs were organized in this year. Academic webinars, PPE, that is PG activities. Mainly our government college PGs were given the COVID duties. How would they prepare for their exams, for their PGs? We organized PG activities for them. They could attend those, or they could watch even the YouTube link. So that was provided.
Last one
Was the
minute,
precaution taken for them? Yes. So this was attended by 500 PGs all over India. We recognized the problems and we tried to solve them. Problems should be taken as challenges and not as problems. There were many people in economic distress. We took precautions for that as well. So POS was here to find solutions throughout the year. For doctors, especially for surgeons, when the cases are less, when the OT is not, the empty mind is the devil's workshop. But the same doctors are really, really creative. So we started our programs to have creative ideas from doctors, like this block of keeping peace, mind and body, for awareness programs for people, for COVID awareness programs. And I always encouraged people to have their passion to remain positive. Finally, I would like to say, Bhagavad Gita is my strength and my faith. It gives you positivity, knowledge, action, love, and peace. So friends, we have to fight against COVID with the same rule, karmanyavadhikaraste. Keep on doing your work. Follow the precautions. COVID is here to stay, but we are also here to stay. So we'll have to find new ways. When I say in my poem, असा मार्ग माझा अनोख्या सुखाचा, नव्या शोधध्यासात नवश्वास घ्यावा, जुन्या पावलांचा धुराळा नसावा, असा मार्ग माझा निराळा असावा. So with that note, after taking 2 doses of vaccine, I say thank you, and our fight continues against COVID. COVID is here to stay, but we are here to fight against him. Thank you very much.
Very inspiring talk, ma'am. Dr. Khedkar sir, just would you like to add something?
अनम्यूट करा केळकर सर आपल्याला. Yes.
This was the most exemplary year because in spite of any person who becomes the president, naturally would like to meet the people personally, talk to them, exchange the ideas. But here, because of COVID, it was just impossible. And yet, we never felt the absence that physical meetings were not there. The way it was conducted every year, it was just superb. I think this must be one of the rare example in other societies also, gynec, pediatric and other things also. I think what Pune Ophthalmic Society has done here this year, credit goes to the Pune Ophthalmic Society members, the committee and the president. Thank you so much.
Dr. Marathi sir.
येस, मला वाटतं मी मराठीत भावना व्यक्त करतो. आपल्या पुणे नेतृत्वज्ञ संघटनेमध्ये अनेक पर्सनॅलिटीज आहेत ज्यांनी त्यांच्या क्षेत्रामध्ये चांगल्या पद्धतीने नाव कमावलंय. पण मला वाटतं गीतांजलीची जी पर्सनॅलिटी आहे आणि गीतांजली योगायोगाने प्रेसिडेंट त्यावर्षी होणं, मला वाटतं कोरोना आणि गीतांजली हे जे कॉम्बिनेशन आहे, म्हणजे कोविड पॅन्डेमिकचा आपला म्हणजे न भेटण्याचा जो कालावधी होता वर्षभराचा, तो गीतांजलीच्या इतका चांगला कोणीच भरून काढू शकलं नसतं असं मला म्हणायचंय. कारण ज्या पद्धतीने तिने सगळ्यांना 365 डेज ऑन देअर टोज, म्हणजे व्हॉट्सअपवर दररोजचा असलेला ब्लॉग असो, वेगवेगळ्या ऍक्टिव्हिटीज असो, मला वाटतं कोविड या पॅन्डेमिकला न्याय देणं POS प्रेसिडेंट म्हणून हे जे तिनं साध्य केलं ते कोणी करू शकलं असतं असं मला वाटत नाही. आणि हा चॅलेंज स्वीकारणं वॉज व्हेरी डिफिकल्ट. कारण जेव्हा गीतांजली प्रेसिडेंट झाले तेव्हा लोक म्हणायचे की तू आता काय करणार आहे घरात बसून. पण घरात बसून काय करता येऊ शकतं त्याचं मूर्तिमंत उदाहरण म्हणजे डॉक्टर गीतांजली शर्मा. सो फॅन्टास्टिक, हॅट्स ऑफ टू यू. वंडरफुल year of your tenure as president. To your team also. Thank you so much. Bye.
Thank you, sir, and very true what you said. Now I'll invite Dr. Sanjay Shah, sir, for his talk.
Mukesh,
Sir, you give me a minute, sir.
yeah. I'll start.
Yes, sir.
Respected Chairman, Co-Chairman, sir. At the outset, I would like to thank Dr. Geetanjali, President POS and Team POS for giving me this opportunity to talk on OPD management strategies during COVID pandemic. As we know, a year back when the lockdown was there, everywhere there was a fear and people were worried to work in the OPDs with the fear of getting infected. So at that time, also the OPD management strategies were discussed and were thought of to prevent infection in ourselves. And at that time also I presented this, but now what the situation is that we were, as the numbers had gone down, we were become complacent. And as Gangakar Khadkar sir said rightly that we were not following the COVID norms, and that has resulted into a second surge of the pandemic. And we are now facing the more and more number of cases with the same fear that now we have to again buckle up our shoes and take the precautions and serve the community by not spreading infection to others, not getting infected ourselves, and continue our work the way we are doing it. With this background, I'll start my presentation. What is important is consider what is safety. Safety first. Consider all patients as positive unless proven otherwise, as we are in the second wave of pandemic. And as you know that there are 3,000 plus cases in Pune just reported last year. And that is most important for us. Safety for us, for our staff, for us, and even for our patients. Next. What are the general protocols that we are going to follow? They are same what we are going to follow. I'm just going to narrate again and refresh our memory so that we continue to do that and prevent spread of infection. Open door protocols, keep your doors open, everything room well ventilated. You can use air conditioning, but air conditioning at a temperature between 24 to 30 degree with humidity of relative 40 to 70%, which decreases the problem from the pathogen. As everyone is saying that hand sanitation is very important. Hand sanitizers at multiple places to be kept. Next. What are the general measures that we are going to take? Personal measures, educate yourself about the disease, educate your staff, educate your patients so that the chance of spread of infection is reduced. Put posters, information protocols on display so that whoever patients is coming, they will read, they will try to understand and try to behave and follow the COVID protocols to prevent spread. In clinics or hospitals, you can avoid finger attendance and convert to a face recognition attendance. You can change street clothes to a clinic clothes when you come into the clinic and ask your staff to change to the clinic clothes, and when you go out, you can change to your street clothes and go out, so that you don't carry any infection which is there on your clothes into the clinic. Avoid cell phone use. Sanitize the cell phone when you bring it. Use the lift for the patients mainly. Cleaning of waiting room, floor and waiting place with 1% sodium hypochlorite solution. Reduce and channelize the floor. Try to avoid all walk-in patients except emergency. Start appointment system. If you are not still, you start doing the appointment system. And people are very well accepting the appointments in the current scenario. Give appointments at every 15 minutes interval and explain to the patient what to expect when you reach to the clinic. Reduce follow-up visits, make use of teleconsultation for follow-up patients, make soft copies of appointments and send it to the patients, which can be shown on arrival to reduce the paperwork. Avoid cash, because cash, the notes are one of the most potent spread of infection. So avoid taking cash. Payment, try and take the payment by card, Paytm and Google Pay. Next. What are the OPD arrangement that you can do? Create a barrier at the entrance itself. Triage area before entrance with thermal screening. Now the situation has changed. Before we used to ask the travel history and all that. Now the travel history has no meaning because there is already a spread of infection in the community. So what you are required to do is to take a temperature checkup and ask the patient about the COVID symptoms. If there are any COVID symptoms, ask them to come after 2 weeks and take the appropriate measures and the treatment for that purpose. Keep your main door entrance open so that there is a lot of ventilation in the room. If you have a small clinic and a triage area is not possible, then screening can be done at the reception itself when all the patients are coming in. COVID screening questions before sending the patient in the waiting room. Maintain all the records of patients and relatives. That may not be applicable now because already there is a community spread and contact tracing might be difficult at this juncture of time. Only one relative is allowed. I think we should continue to do that still, and so that there is no overcrowding of the waiting room. Arrangement for washing the hands with soap water. If not, then sanitization with sanitizer into the clinic at multiple places. And once you see that the sanitizers are kept, people are now getting used to it and they use hand sanitizer and try to sanitize their hands. Ensure that everyone is wearing a mask. That is a must. And you ensure that if the patient is not wearing the mask, you give yourself a mask to the patient. It is in the interest of the patient's safety and your doctor's safety also. So provide them a free of charge a 3-ply mask so that they wear it before they enter the clinic. Create social distancing in the clinic. As you can see that you can put a tape on the waiting hall that patients will sit alternately, they'll not sit together. Reduce waiting time by primary examination on the first visit, and if you need to dilate the patients, ask them to get dilated and come to the clinic, or you can dilate in the clinic at a separate place so that there is no intermixing of the patients. Next. Mukesh, next. Use of non-contact thermometer, as I already said, self-declaration form, consent form from the patient and the staff that they are at a risk and they are still willing to work. Next. Online consultation links to be provided so that patients can, with minor problem, they can have online consultation and can get away with the problem and reduce the OPD work. Buy a platform in group which will reduce the cost and the data will be secured. Next.
Last 1 minute, sir.
OPD arrangement, self-training, mock drill, monitoring of the staff, teach staff for patients training, train about PP and get trained ourselves. There are multiple PP that you can use at different places. Next. Keep consulting room open, keep room ventilated, avoid use of AC, barrier shield for your slit lamp, indirect microscope. One patient in the room, avoid having relatives. You can see a slit lamp shield being applied, the OPD door is open and you are wearing a proper PP while examining the patient. Next. Cleaning of the lenses, slit lamp, chin race with 70% alcohol swabs, or you can use basil oil spray, which can be a good way of preventing spread and cleaning everything. Avoid paper prescription, give e-prescription whenever possible. If not, then give a separate prescription every time. Avoiding handling patients' files, discourage them to bring it, and they tell them to send it on WhatsApp so that you can see them. You can cover the main instruments with plastic foil so that cleaning will be easier for you. Examining all patients with red eye in a separate room so that there is no intermixing and dispose them off at the earliest. OPD and consultation room fitted with UVC lights can help to sanitize your surfaces and the air. Fogging of waiting room and consulting room once in a week is recommended and can be done on regular basis. Next. So take a massive screening at the entrance with COVID-19 symptom. Check temperature with IR thermometer, hand sanitation, maintain social distancing in the waiting room, use of appropriate PPE by all the doctor and the hospital staff, minimum patient chair time, hand equipment, trial frame and lenses sanitation at after every patient, online consultation whenever possible, and cashless payment. Thank you so much for patient hearing.
Thank you, sir. It was very informative talk. Any questions?
Only one. Do you still take declaration form?
Declaration form at the present moment, no. We are not taking any declaration unless and until it is any operative procedure or any procedure that we are doing. For OPD, we are not taking any declaration form now.
Thank you, sir.
Now,
may I add one thing? Yeah. Krushali, you
yes,
want to
sir.
say
Yes,
something?
sir. Yes, sir. Please. Go ahead.
Basically, in this change scenario of COVID-19, whenever you have treated these patients, probably the norms were changed, like online consultation, and there were a few changes in the treatment of the patients, and hence the medical legal aspects have also been changed. Like suppose you have done the online consultation, you have not seen the patient. So in the past, probably courts were not allowing the online consultation because there were few cases in the history. But afterwards, in this COVID era, probably they allowed this online consultation. But still, you have to be careful to whoever you're given the consultation online, you have to enter, keep your records clean so that in future, suppose something happens, it should be recorded at your place with proper documents. Just don't take it lightly that online consultation has been given and that WhatsApp communication has been deleted afterwards. So you may not be remembering to whom you have consulted, what type of treatment you have given, like that. Yes, Sanjay, you want to do something?
So no, so you can try and make use of some teleconsultation apps which really secure the data, the privacy policies, and they are useful for medical legal point of view also. So whenever patient is asking you on WhatsApp, tell him to go to the consultation link and go through that consultation link for consultation so that everything is secured. So that is fantastic. What can be done instead of doing it on WhatsApp. So as you rightly said, that it can be deleted and the data can be lost, so that it will be a problem for a medical legal purpose.
Yeah. One more thing, what most of us have been noting in this COVID era, like we have been following all these norms, whatever is there from our end, like at OPD and OT. But then when the patients come, most of the times they are not with the mask. Whenever there is a mask, it is not at proper place. It is not over the nose. It is not over the mouth. But then they are just talking. Whenever they are talking to you, they are taking the mask down and then they are trying to talk.
That is a
These
very
are the
common
things
problem.
when the patients are not following, society is not following. I think that is the problem. So problem is not at our end, it is the problem towards society's end. And to educate the public, to educate the patients, I think that is the most difficult thing from our point of view.
Rightly, sir said, whenever you ask the patient to put his chin on the slit lamp, he'll take out his mask immediately. Yeah. And then you have to tell him that you keep your mask on and then put your chin.
We can apply sticking to avoid the pulling, maybe.
Yeah, you can do that, but
they still pull it down.
They will still pull it down.
What they feel whenever examination is being done, probably the mask has to be taken out. That's what they feel in their mind.
So normally what I'll do, that I'll put a sticking when I'm going to do a 90D examination, because that the breath will come on my hand under lens. So that normally I'll put it when I'm doing a 90D examination, so that it is not coming on, and immediately sanitize the hand. That's what you can do and to prevent the problem.
And one question. You said that not to put on the AC. Easier said than done. How do you keep cool?
No. Nowadays the norms are changed. You can put on the AC and you can maintain the temperature between 24 to 26 degree with a humidity of 40 to 70%. So that is allowed now with the current trend. Yeah.
Okay. Only one thing is that there shouldn't be any lethargy, because over the period of 15 months, I think we have tried to follow everything. Probably day by day, people are forgetting all the norms and they are getting relaxed. So that shouldn't happen.
Because the numbers have started coming up in between, we had become complacent because we thought now Corona is gone. That's what the feeling was with everyone. And today also, if you move around and see, people feel that there is no Corona-like thing, and the people are moving the way they want it. But still, that is not right. So they have to follow the Corona norms and help the nation to prevent spread and reduce the second wave as early as possible.
One more thing from the experts here. I think for planned surgery, still are you asking the patient to do it on an emergency basis, or telling them to wait for another month?
No. We are doing it on regular basis with the COVID testing, and we are taking other patients on regular basis. There is no only emergency surgeries. Also routine surgeries are going on.
Are you asking also about the vaccination part?
No, I am not asking, because even if they are vaccinated, I am telling to do the COVID testing before.
Sir, can we move to the next talk? No?
Yes, sure, Dr.
Thank you, sir.
Yeah.
Thank you so much.
Now, thank you. Now, I invite Dr. Saroj Bande ma'am for deliver her talk.
Dr. Saroj Bande is an anesthetist. She is our guest speaker today. She has been specially invited to speak about if we face any emergency during COVID times, what precautions we should take. Some norms are changing now, and she'll be speaking about that. Yes, Dr. Saroj.
Hello.
Yes, ma'am.
Am I audible?
Yes, ma'am. Please go ahead.
Oh, can you see me? Because I can't see my screen.
No, you are not shared it, ma'am. Please share your slides.
Oh, hello.
Yes, ma'am.
Not yet.
Not yet.
We can see you.
We can see you, yeah, but not slides.
Can see me.
Yeah.
Okay.
I think you can bring your presentation to the desktop and
Yeah,
Click on share screen button.
yeah, I'm doing that, but I can't see that sharing screen right now.
This is the doubt.
Shall I do, ma'am, from my end?
Yeah, you can do, I think, but
Okay. I'll
I
just
can't
Have
see
you
anything.
forwarded the presentation to Dr. Vrushali or Dr. Mukesh?
I have.
Okay, then Dr. Mukesh or Dr.
I'll just
Vrushali, can you share the screen?
Yes.
Yeah. I can see my screen now, but is it visible to you?
Yeah, Madam Vrushali has shared the screen.
Yes.
Now you can see and you can speak.
Okay,
Yeah.
then I'll tell her. Okay.
Yeah, please.
Okay.
Yes, ma'am. You can
I
start.
can't see the slides, but
Dr. Vrushali, please do it again.
Okay, I'll just stop share and I'll do it again. Now, is it visible?
No, Dr. Mukesh, Dr. Saroj, you have to first stop sharing. You please stop share. Then only Vrishali will be able to do it.
Dr. Vrushali, ma'am, just a minute. I'll just finish this. Dr.
But
Vrushali, stop the share screen. Dr. Vrushali.
Yes, I have stopped it.
Yeah, just give me total 10 seconds.
And Mukesh, if it is not possible,
yes.
Yeah. Okay. Now it is shared. Yeah.
Dr. Mukesh, everything is possible.
That's true. Absolutely true.
Yeah. Okay. Good morning, everyone. At the outset, let me thank the organizers for calling me here to talk on this topic. Next one. First, I'll be talking about the medical emergencies that can occur in the ophthalmological setups mainly, and then I'll go to CPR. So the most common probably is the vasovagal shock. So it's very important when you are doing it, especially under local, all the procedures are done mostly. So keep on communicating with the patient, and the young patients and babies who have got strong vagal tone are most likely to have this. And also there are some hyper anxious patients, and the patients will give you a history of such episodes occurring. The management in short is raise legs, talk to the patient, reassure. If required, take an IV access, give atropine and vasopressors. Next one. Next one is hypoglycemia in a diabetic patient, especially if he comes fasting and has taken his medicine. The pointers are giddiness, sweating, hypotension, 3D pulse, and then conversion and coma. Management is either with oral or IV dextrose. Next one. The next one is bronchospasm. In known case of asthma or COPD, usually breathlessness, wheeze, tachypnea, hypoxia, and the management is with oxygen, and nebulization should be given with bronchodilators or steroids. But one must remember that nebulization is a highly aerosol generating procedure, so due precautions have to be taken. And the next one is convulsions. One must remember that it can occur because of intravascular injection of local anesthetic drug also, or in a case of known case of epilepsy or neurological disorder, and metabolic disturbances like hypoglycemia and hyponatremia. Management is mainly supportive. If required, IV midazolam is to be given. Otherwise, just to keep the airway patent. That's more important. Next one is anaphylaxis. The pointers are rash, pruritus, angioedema, hypotension, bronchospasm, and the test dose whenever it is given has to be observed. And management consists mainly of steroids, Avil, IV fluids, and adrenaline. Next one is stroke, acute myocardial infarction. The diagnosis can be by chest pain or tightness and hypotension, sweating, giddiness. ECG, just go to next slide, please. ECG will show ST elevation as shown here in the circle. Back again. The management consists of giving oxygen, aspirin, sorbitrate, and referral to a higher center. Next, please. Next.
Dr. Saroj, we cannot hear you.
Hear you. I think some internet.
You can put your video off. The internet, this thing is slow then. And speak.
There is a connectivity issue. Yeah, you can put your video off, madam.
Yes, put your video off.
Maybe we all can off our video.
No, not required.
It is not required. It is from her side.
Okay.
I am unable to stop her video also.
Ma'am, go to your video icon and just cross it.
It is on your left hand side down the screen. video icon.
I hope she is able to listen to us.
Yeah, she'll be able to listen.
I don't think so because she's not responding. Now her video went off. And she logged off, I think.
Wait, I'll just call her.
Call her otherwise. Not listening. Usually we can call her up.
Now she is in. Now she is in. Video is on.
Yeah, she's calling.
Ma'am?
Yes.
No, Dr. Saroj Bande, ma'am, can you hear me?
She's not responding. Maybe her net connection is
Mute.
gone.
Is she mute or something like that?
Can you hear me?
Yes, now
please.
now we
Yes,
can
ma'am.
hear you, ma'am.
Yeah.
Okay,
Please
so
go ahead.
now we will move forward now.
Yes, ma'am.
Yeah. Okay, next slide, please. Next slide. I can't see the slides clearly. You can see them?
Yes, ma'am, very well.
Okay, fine then. Now what is the basis for our changing concept? In the times of Hippocrates, it was the first, do no harm to the patient. That means primum non nocere. But now the concept had changed to primum non nocere adate. That means first, do no harm to yourself. Next, please. Now, why is it so? Because the healthcare workers getting transmitted with COVID-19 is absolutely undesirable because it becomes a triple threat to the healthcare system. It adds to the patient load, and also there is a loss of a trained healthcare worker from duty for at least 2 weeks from already overloaded facilities. And there's a potential chance of infection of many co-health workers and patients. So the key to the success in preventing this transmission is preparedness for any casualty. Next, please. So how can we be prepared? One thing is we have to keep a proper crash cart ready in whichever setup we are working in, with emergency drugs labeled, expiry checked periodically, then dosage guide, ampule cutter, syringes, IV access equipment, defibrillator, airway equipment like mask, endotracheal tube, laryngoscope, ambu bag, and any of the airway equipment, you must use HEPA filters on them. Next one. Next one. Okay. This is showing you a picture of a crash cart with a defibrillator on top and the drawers below, which are properly labeled. So it's very important that you all know which compartment has what in it. The other thing is we must also remember without fail about the disposal of biomedical waste with 1% hypochlorite solution. Next. Next. Okay. Also on the same cart, we must keep the PPE kits. The PPE kits, what it contains is shown in the diagram. And if the PPE kits are not available, at least you must have a plastic sheet to cover the patient and some adhesive tapes, because you might tear the plastic sheets for some manipulations like say airway manipulations or defibrillation, and they should be immediately taped so that there is no aerosol spread from those threads. Also, simulation-based training for donning and doffing of PPE kits is very, very important, the correct technique, because the biosafety breach can lead to hazardous consequences. Next, please. So knowing all the equipment and their arrangement on crash cart is very important, and a well-rehearsed team will need lesser number of persons to manage the situation, saving the workers and also saving some PPE kits. Next one. So one must remember that in a pandemic, there is no emergency. Treat all patients as COVID-19 positive unless proved otherwise. And CPR is not to be started without donning PPE, and also remember to cover patient's mouth and nose with a surgical mask or a tri-layered piece tried so that it doesn't slip unintentionally. Before starting compressions, call for help or call on 108. Next, please. The first component is cardiac compressions, which should be given at a rate of 100 to 120 per minute, 5 to 6 centimeter depression in the middle of chest, and allow full recoil. And this should be uninterrupted as far as possible. And this generates a very small tidal volume, and so can generate some aerosols. And so this is where the importance of mask on patient's face comes. If there is no mask, the aerosols will go in the direction of the rescuer. If there is a mask, the aerosols will go in the direction of the patient's own forehead. Next, please. Next, please. Okay. Just showing you the logic of the cardiac compressions. Next, please. Okay. The next component is airway manipulations, which has maximum risk of aerosol generations for obvious reasons. So HEPA filter must be used on any airway device, whether it is mask or endotracheal tube or LMA. Next one. The bag wall mask, one must remember that the mask should be held with two hands so that it fits well, because if it does not fit well, it will allow a lot of aerosols to travel around. The next one is LMA. A good fit is desirable again, and achieved most of the times without any efforts. Next one. Next one is the endotracheal tube, obviously. And the endotracheal intubation, one must remember that coughing during laryngoscopy is absolutely undesirable. So a muscle relaxant should be used, and video laryngoscopy and closed suction system is preferable. And intubation should be done by a most experienced person available, and the placement should be checked by ETCO2, as you can't hear with the PPE kit on with the stethoscope. Next one is the defibrillation. Defibrillation has got least risk of aerosol generation, and even lesser with use of AED or disposable adhesive pads. And as far as drugs are concerned, one must remember to avoid the use of amiodarone. Instead of that, use Zylocard, because amiodarone with hydroxyquinolone has a risk of QT interval prolongation, which can culminate into ventricular tachycardia and fibrillation. In short, the problems with PPE kits on during CPR are, it is much more tiring, challenging. So you need to change rescuers every minute. There is poor visibility, fogging, and communication is very, very difficult. You can't hear well, can't recognize the person sometimes, and the stethoscope hardly is of any use with your ears covered. The solution for these problems are, the instructions should be loud and clear, microphones can be used, the PPE should be labeled, and availability of devices like mechanical chest compression device and mechanical ventilators if are available. Definitely you can reduce the number of caregivers and also the number of PPE kits. And this is just a short list of reversible causes of cardiac arrest which you need to rule out. So this is all from my side, and thank you.
Thank you, ma'am, for an informative talk. Any questions, or shall we proceed to the next talk?
I think we should proceed to the next talk.
Yeah. So now
I think it was wonderful presentation from anesthesiologist, and it was useful for all of us. Thank you. Thank you so much.
Now may I request Dr. Jignesh Taswala sir to deliver his talk.
Can you see my screen, please?
No, sir. We can see you, not your screen.
Now, can you see the screen?
Sir, one blank slide we can see.
Okay, just one. Give me a minute. Huh? I just see, otherwise Mukesh can do it.
I think Dr. Mukesh, if you can.
Yeah, Mukesh, I think you can do it.
Yes, sir. Please unshare your.
Sir, I don't have a presentation here. Not sure.
Wait. I'll share with me.
Okay.
Sir, please unshare your screen.
Everything here?
Sir, whatever you have shared, please unshare it.
Okay. Stop share. Yeah.
Give me a minute. I'll just share his presentation.
she's sharing. Very good morning to all of you, respected chairman, sir, and the co-chairman. At the outset, I would like to thank Dr. Gitanjali and Team POS to have given me this platform to speak on a very...
Can you see my screen? I have shared it.
No,
Dr.
not yet.
Mukesh. It's coming. It is paused. Yeah.
Only screen sharing is seen, but the slide is not seen.
Dr. Mukesh, it is coming. Your screen sharing is paused. So is it? I am not a host.
Yeah, no. You have to stop and start again. Piyush, can you look into it, please?
Yeah, ma'am, just go ahead and share.
Now, can you see now? Now it is coming. Your screen sharing is paused.
I think whenever you have started sharing, even in the past, this particular session, your screen, the screen sharing done is seen, but not the slide.
But I can see here.
This is happening in case of Dr. Bhushali.
See, it is coming. Your screen sharing is paused. So by that time, can we move to the next talk? Dr. Pradeep Damle can deliver his talk, and maybe you can make me
we can
host
go for
Dr.
the next talk.
Piyush.
Yeah, next
Dr.
talk.
Piyush, you can make me a host by that time, so I can share Dr. Taswala's screen, please.
That
Could I
might
share?
not be possible. Sir, Dr. Pradeep, sir, you please go ahead. We'll see the
Okay.
issue on the back
Can
end.
you hear me?
We
Can
can
you
hear
hear
you
me?
very clearly. Yes,
Okay.
yes.
Okay, fine. I'll start. Can you see my screen?
Yes, sir.
Yes, it is seen now. Pradeep, wonderful.
Respected Chairman Dr. Kelkar sir, Co-Chairman Dr. Marathe sir, Dr. Brushali, and my dear friends. At the outset, I would like to thank the POS organizers and Gitanjali for giving me this opportunity to share my experience of iCamps in this period of COVID-19. Certainly, it has been a very difficult time for all of us, and the main challenges what we faced were to manage the crowd in the iCamps, to follow the government guidelines because they were changing from time to time, and also government was not keen enough in starting iCamps at the early stages. Transport of these patients to our hospital, admission of patients and relatives in the hospital, and protection of inmates. Why I'm telling this is, our hospital is a rural eye hospital, which is about 45 kilometers from Pune, and with very poor transport facilities. Second thing is, we have got an old age home where there are about 150 senior citizens residing. We also have a nursing school with about 50 students. So there are about 250 people staying in the hospital premises, and to protect all of them from corona was a huge task. So arrangements were made so that the patients do not mix with these inmates. We stopped admissions of patients in the hospital. Previously, we used to keep the patients for about 2 days in the hospital, but now after this COVID incident, we have started discharging the patients immediately after the operation. We are following the AIOS guidelines. In the first camp also we took was in the green zone area, but we took it in a green zone area. This camp was normally we send about 5 to 6 people of our staff to arrange this camp, but for this we expecting the rush, we sent about 15 staff people. The staff had reached half an hour early to make the necessary arrangements. The organizers were also told that only 100 patients will be checked in the camp. In the first half an hour, we had examined about 20 patients with hand sanitization, body temperature checking, SpO2, and social distancing. Next 20 patients were lined up, and about at 10 a.m., suddenly everything turned haywire. This is the video. This is not our video. This is the video of the people taking vaccine at BKC. But our incidence was not different from this. There are more than 100 people who just stormed inside the premises and demanded to be checked. Very few were with masks. Many elderly patients were brought by relatives, and social distancing went for a toss. We had to change our game plan. The place was small and the crowd was huge, and more were just pouring in. So we just lined them up, and with a torchlight, the optometrist just identified, we checked all of them patients, and we identified about 20 patients of cataract in them. Afterwards, we told the rest of them that we would be giving them the glasses at a later date, and we just closed the camp and returned with 20 patients. But now we had to change our plans because every time this was going to happen, because it was impossible to control the crowd who are going to come to the camp, because it was not our premises that we were holding these camps. So we looked into our database and we found we had about 10,000 patients, contact numbers and all. So we started contacting these patients in the last 2-3 years, those patients who we had operated. And we asked them the history of COVID-19 in these patients or their family members or their relatives. If there are any patients in their neighborhood, if patient was belonging to the quarantine zone, if there was any history of fever, cough in the last 15 days. If all those answers were negative, then we called these patients to the hospital with just one relative. Once these patients came, body temperature and SpO2 checking was done. Apart from all these patients underwent BP, ECG, BSL, urine, HIV test and a scan of all these patients was done, taking all precautions. Hand and feet hygiene, social distancing, all the wards, the trolleys, everything was, the surface were disinfected. Masks were, patients were asked to put on the mask at all times. Protective equipment like mask, face shields and gowns and gloves were provided to the staff members. The auto ref and slit lamp were with breath shields. Disinfection of all the instruments was done. Apart from other consent form, we started taking a COVID-19 consent form from these patients. Patients were provided gowns, caps and masks. Dilating drops, we used the non-touch technique. Povidone drops were also put just before surgery. All these surgeries were done SICS with block, and post-op instructions were also given to the relatives by our staff. Patients were discharged immediately with the discharge card and the medicines. We did not want these patients to buy the medicines, again go somewhere. So both the tablets and the drops were given to the patient. This was the consent form. The main part of this was that every hospital is a high-risk zone for COVID-19 transmission. High chance of patient relative contracting this infection. Anybody in the hospital can be an asymptomatic carrier. On symptoms, he may have to be shifted to a COVID hospital. Patients or relative may have COVID without any symptoms. So patients will not hold responsible the doctor, the hospital and the staff morally or legally responsible. Cleaning and decontamination was taken. We all sort of chemicals we had, microscopes, we cleaned with isopropyl alcohol, OT tables with trolleys and
last
chairs.
1 minute, please.
Chlorhexidine, Lysol. Floor was cleaned with sodium hypochlorite, AC with 2% bacillocid. Once a week, whole OT was cleaned with detergents and fumigation was done with formaldehyde and K104. Dilatation and eye marking was also done. Patients used to hold the lower lid and the sister used to put the drops. Patients used to apply the eye sticker to identify the right eye or the left eye to be operated. Social distancing was maintained till these patients were taken into the theater. This is the patient was been taken in we provided the cap mask and a sticking was applied over the nose so that a breath will not interfere. The OT table, we use disposable drapes, not even for the patient, also for the OT trolley, and everything was just disposed of once the surgery was done. Even in between also we started OT cleaning was done with the mopping and the OT table and the surgeon chair was also cleaned. Discharge card was given, printed instructions. Yeah, we have almost finished. Tablets were given. Disposable, we have these 3 containers, yellow, red and white containers, and we mentioned everything. Finally, we have in the past 5 months, we have operated around 736 patients. Unaided vision was more than 6/18 in 67% of the patients. Aided vision post-op 6/9 or more was in 98% of patients. 2% were with guarded prognosis. We have nil complications. End-off was also nil. COVID infections were nil. One point I would like to mention, I have been conducting ICAMs for the past 20 years, and we used to have occasional end-offs. I had a series of 7 end-offs in one setting also. And we tried changing all patterns, like increasing number of sets, changing from the drapes to the disposable drapes, and cleaning of the OT, but still we had few cases occasionally end off. Last 3 years now we are using intracameral moxifloxacin, and in the last 3 years, we have got a nil rate, absolutely no infections of no end of cases. These are all the happy patients whom I operated just 2 days back. Just Friday operated cases.
Sir, can you please
Thank
sum
you.
up?
Thank you all. Thank you for patient hearing.
Thank you, sir. As a time constraint, we will not take any question and answers. Now, Dr. Mukesh, can you share Dr. Taswala sir's slides, please? Yeah. Dr. Taswala sir? Dr. Taswala sir, can you hear me?
Dr.
Hello.
Jignesh, unmute yourself. Dr. Jignesh, unmute yourself.
Dr. Taswala sir, please unmute yourself.
Yeah, at the outset, I would like to thank Dr. Gitanjali, President POS, and the team POS for allowing me to use this platform for such an important topic. And a very good morning and a good afternoon to all of you, respected chairman, sir, and co-chairman. I would like to thank Dr. Gitanjali. The way she has done, भाई गीतांजलि तो काही करू शकत नाही, तो मी सब कुछ कर सकती हूँ. That 1 year has been really fantastic, very innovative and very inspiring. And she has done a fantastic work. She is going to inspire the future presidents also. Coming to my topic, financial impact of COVID times. Can I have the next slide, please? Yeah. Can you fit it a little bit? I can't see the headings. Hello, Mukesh?
Yes, sir.
He cannot see his headings.
Going up. Okay, anyway, as the pandemic was there last year, everybody has faced the worst of the year of the lifetime. Everybody got affected economically, financially, and socially also. Well, the lockdown was there from the 25th of March. What exactly did the lockdown do financially? How bad are we affected? That is the first slide. Lockdown safety protocols. Only emergencies were allowed to be attended to. And above 60 plus and comorbid doctors and patients were said to avoid to go to the clinic and hospital for fear of catching COVID. The screening protocols for entry of patients with social distancing, so lesser number of patients were there that could be accommodated. Because of the full curfew time, except for the essentials and medical teams, the overall flow of the patients grossly got curtailed. Elective surgeries were also not allowed, so overall volume of OPD and eye surgeries were dropped. Next slide. So, yeah. The pandemic had two types of shock. One is the health shock and the economic shock. The policy decisions like imposition of social distancing, self-isolation at home, closure of institutions and public facilities, and transport and restriction of mobility. Economic shock was worse. There was reduction in trade, disruptions in production supply chains, there was decline in demand, lower tourism, and the business travel. Loss of investor confidence, productivity losses from health impact on morbidity and mortality of the workforce. This was the effect of the global pandemic. Can we have the next slide? The demand side impact, tourism, hospitality, aviation were the worst affected. Closing down of cinema halls, there was a huge reduced footfall because shopping complexes had got affected. The sectors which got affected were both for essential and discretionary buying. Can we mute it? I can't see the side of this. Yeah. Consumption impacted to job losses and a decline in income levels, especially of daily wage earners, due to slowing or stopping of activity in retail, construction, and entertainment. And due to panic, confidence level dropped, leading to postponement of purchasing decisions. Next. The financial impact, because of the travel restrictions, the whole of the travel sectors were hugely affected. Hotels were seeing large-scale cancellation, not only for the leisure, but also for business travels, as conferences, seminars, and workshops got cancelled. Financial market was extremely volatile due to the uncertainty of the future course and its repercussions, leading to huge crashes and wealth erosion. On a single day on March 12th, 10 lakh crores got wiped out of the investor kitty. 2,919 points had gone down. There is disruption of demand and supply of non-essential commodities due to lockdown, and this will continue now till low key till the post-lockdown. Mainly consumption, investment, and exports are going to be subdued. This will affect the general population in all domestic industries due to unavailability of raw material. There will be mass exodus of migrant labor from urban areas. This will pull down the income, investment, and overall growth rate. Next slide. The informal sectors. 84% of them catered from both for the farm and the non-farm sector. Daily wage laborers were the worst hit with large-scale job and income losses. They were working from building, construction, road infrastructure, and factory production. All were badly hit and very difficult to stay afloat and may be forced to shut down. Micro, that is MSME, micro, small, and medium enterprises who provide large-scale employment and help the country exports, contribute to 30% of the GDP. They were very, very badly affected due to reduced cash flow and the lockdown guidelines. As a result, hundreds of thousands are jobless and with hardly any income. Next slide. Employment was grossly affected by the data of the consumer pyramid household level survey revealed unemployment shot to about 30%, about 3-5 times the normal. In the urban area and in the rural area, almost 21%. Next slide. The market, more and more firms were struggling to pay their loan dues due to non-performing assets of banks going up. Corporate delinquencies going up. Default will only rise in the banking, but also the NBFC, microfinance.
Sir, last 1 minute, please.
Yeah, lower income group will become insolvent as their revenues are taking a big hit. So already fragile finance system is going to get choked. Supply side, due to shutdown of factories and resulting delay in supply of goods from China, leading to raw material shortage. Most affected were automobile, pharma, electronics, and chemicals, hampering business sentiments and affecting investment in production schedule of companies, having a negative impact on imports. Slowdown of manufacturing activity in China, Europe, US. Lockdown effects on ophthalmology. That is what the survey to assess the psychological impact by POS showed 1/3 were in depression. Also affected were of training of postgraduates and fellows due to closure of eye camps and reduced elective surgeries, paying of salaries of staff, rentals of premises, EMI and AMC for medical equipment and clinic was an extra burden. Next slide.
So can you please sum up?
In the OPD. Sorry, yeah. Due to stringent rules of government and local body not allowing general public to visit the doctors unless there is an emergency. Timings of practice had to be curtailed. Cold cases dropped down to nil. Doctors themselves took precautions by closing down the clinics. Teleconsultation was a very poor alternative option. The risk with reduced changes was sometimes free or proper consultation. There was loss of surgical revenue because the eye procedures and surgeries could not be performed. Electives had to be put on the back burner. Patients had to be tested for COVID, plus wearing of full PPE kits, staff to avoid the COVID transmission. So extra expenses were incurred.
So
less
please,
number of surgeries were there in between the waiting time in clinic. Yeah, I am summing up. Thanks. So overall, even the ophthalmologists and the general public were affected. Financially, there was a big loss. And that is how there was a disproportionate effect. The healthcare system also took a huge beating because of the government guidelines. Thank you very much for allowing me to speak.
Thank you, sir. Thanks a lot. Now this will be last talk of this session about COVID vaccines. Last but not least, yeah, Dr. Mukesh, can you share my slides, please?
Visible?
Yes, thank you. First of all, I'd like to thank Gitanjali ma'am and all scientific committee, POS, for giving me this opportunity. I'll be talking on COVID vaccine. Next slide, please. See, we all are aware, at present, there are 2 vaccines available in India. One is Covishield and next one is Covaxin. I will be mostly talking about these 2 vaccines, whatever we have. Next slide. Now coming to Covishield, this is developed by AstraZeneca with Oxford University in United Kingdom and is being manufactured by Serum Institute of Pune in India. It has completed phase 3 trial in South Africa, Brazil and UK. And 90% of the subjects they enrolled were about under the age of 55 were old. and they took only healthy subjects for this study. They recommended. Please, I request everyone to mute everyone, please. I request everyone. Now, they have recommended 2 doses of intramuscular injections at the gap of 4 weeks. Now, efficacy, they have noted about 70% effective if we take it at an interval of 4 weeks, and it is effective 82.5% if we take it at a 12 weeks gap. In UK, they first dose they gave in half dose, followed by second dose, full dose at the interval of the 12 weeks, and they found more immunity with such type of interval in between 2 doses. Now, side effects, there are no major side effects noted in India, but yes, anaphylaxis and some blood clotting is noted out of the India. Now, coming to biological component of the Covishield, this is viral vector vaccine. So what is mean by viral vector vaccine? In viral vector vaccine, they insert a gene of a viral protein into another harmless virus. It could be replicating or non-replicating. And this delivers the viral protein to the vaccine recipient, and that triggers the immune response. So in case of Covishield, they have used weakened non-replicating strain of chimpanzee's cold virus, that is a adenovirus, to carry a genetic material of a spike protein of a SARS-CoV to human cell. Note here, they have not used a whole virus, they have used only a spike protein. Now, mechanism, how this works, portion of a DNA is coded within spike protein, that is a S protein. This, after entering the cell, it enters the nucleus and creates a mirror image, that is a complementary RNA. This RNA comes out of cytoplasm as a messenger and start making S protein through ribosomes. And this S protein, it provokes the immunity response. This is found effective against the first strain what we found, but data of efficacy against the other strain is under study. Now, Covaxin, it is developed by Bharat Biotech, Hyderabad company, along with ICMR and NIV Pune, recently completed phase 3 trial. And this study has enrolled the largest population, around 25,000 of the patients were involved. They included subjects between age of 18 to 98 years old, and also they have included the subjects with a comorbidity. They recommended 2 doses of the intramuscular injection at the interval of 4 weeks, and they have found that it is effective at it shows efficacy about 81% after completion of a 2 dose after 20 days of completion of the second dose. No major side effects were noted. This vaccine contains a full inactivated whole COVID-2 virus, which is disabled for replication, which develops the Th1 type immunity, and it produces the antibody against the virus. Next, please. These are the chemical ingredients of the 2 virus, and this polysorbate 80 chemical ingredient is responsible for causing an anaphylaxis in case of Covishield. Next, please. Now, these are the other vaccines available, not in India, but out of India. This is a Sinovac by China. Next. Next slide, please. This is an Sputnik V vaccine by Russia, and they have completed phase 1 and 2. Then Pfizer and Moderna. This is widely used in US and UK. Only one thing, it needs a maintenance. Moderna vaccine has to store at a negative 20 degrees centigrade, and Pfizer has to store at a negative 70 degrees centigrade, which we don't need for an Indian vaccines. Now, which are the upcoming vaccines coming with? This is an Zycovid by Zydus. They have completed a phase 2 trial, and they have got an approval for a phase 3 trial. This and biological e-novel COVID-19 vaccine trial is going on. Phase 2 trial is going on. Next is Sanofi is coming with an DNA vaccine. Trials are going on. Next one. Next, please. This is a Johnson & Johnson vaccine. This is again an viral vector vaccine, same like an Covishield. Next one. Next one, please. This is a Novavax. This is an subunit vaccine. It introduces a fragment of a virus into the body. This is important. Bharat Biotech of India is coming up with an intranasal adenovirus vector COVID-19 vaccine. So hopefully this vaccine can stimulate an immune response at the site of injection, that is the nasal mucosa, and that should help to not prevent not only the infection of a disease, but also to prevent the transmission of the disease. Whatever current vaccines available, they are not helpful to prevent the transmission of the disease. So in a conclusion about the Indian vaccine, preliminary data shows both Indian vaccines are effective against variant of a novel coronavirus first detected in the UK, but there is no data on an efficacy against mutation found in South Africa or Brazil. So thank you. Thanks very much. Take care and stay safe, all of you. Thank you.
Thank
I
you,
have a
Dr.
question?
Bhattacharya. Thank you,
Can I
Dr.
have a
Bhattacharya.
question?
Yeah, thank you, ma'am. Yes.
Yes. Yes,
I
Dr.
think in India both these vaccines were available, Covaxin and Covishield.
Yes.
In Pune, most of us have taken Covishield, apart
Yes.
from one center, that is Aunchest Hospital, where Covaxin is available.
Yes.
I've seen few patients, those had kidney transplant done, heart transplant done, and by choice they were asking for this Covaxin. Whereas in various medical colleges and corporation hospitals in Mumbai, they were distributing Covaxin. Even Prime Minister and President, they have taken Covaxin.
Covaxin,
So
yes.
what's your comment about comparison in between this Covaxin and Covishield?
Sir, Covishield is made up of only one strand, but Covaxin is made up of whole virus, whole inactivated virus. So probably this Covishield is can give a better immunity than the Covaxin. This is one thing. In a study, they have involved largest population in the study, and they have included the patients with comorbidities also. So it is found that this is quite safe. I'm talking with Covaxin. Covaxin is quite safe with patients with a comorbid condition. Whereas study done in a Covishield, they have included only healthy subjects, and they have included the subjects under the age of 55. So they have not included the patients over the age of 55.
Sir,
So
if Dr. Gangakherkar sir is
yes, I'd like to his opinion.
Can we have his opinion, please?
Is he available around?
Yes, and what Dr. Sangeeta ma'am is saying, this study has an Indian data, whereas this Covishield they have studied it outside. What I mentioned in my slides, in Brazil, UK, they have studied it, and Africa. And in between, you must have heard that they have returned the Covishield doses from the South Africa, and now they are preferring Johnson & Johnson more there because they found that this Covishield is not that effective against the African strain. So Dr. Gangakherkar sir is there? Is he available?
I don't think
for
he is
his
there.
input.
I don't think he is there.
I don't think he is there. Anyway, but Vishali has explained, I think, very well.
Okay, so,
whatever knowledge an ophthalmologist can speak about vaccines, but maybe we can have some experts' opinion later.
Yes. So may I
In the
conclude?
news, it was shown that Covishield is effective in 70 to 75%, and Covaxin is effective in 82 to 85%.
Yes, yes.
Both vaccines are almost same effective, and it is months away actually comparison.
Okay.
So both are almost same effective. That is the study from infective disease people.
Yeah.
Okay. So if there are no questions,
Dr. Vrushali, as
yes.
Chairman Dr. Kelkar sir, if he is around, he can comment.
Yes,
Otherwise,
yes.
I can speak.
Yes.
Dr. Kelkar sir, are you there? I think if Dr. Kelkar sir is not there, I'll take this opportunity. I think this session was in the memory of our past president, Dr. Ranade, who had just passed away due to COVID. And I think all these topics were also related to COVID. And this was alert to the society, alert to our medical fraternity, how to go ahead against this fight against, COVID pandemic. And all of us have to contribute from our side the same way, even society has to contribute. And this is, I think, sad way to remember the COVID for our past president, Dr. Ranade, who had just passed away. Thank you so much.
With all the positivity, knowing about the precautions to take in OPD, in OT, as well as how to manage your finance in this situation, and knowing about the vaccine, I conclude this session, and I request Dr. Mukesh to continue next session, please. Thank you.
Thank you. Thank you.
So it's time for our inaugural function, and I request everyone to please stay for the inauguration function. It's going to be a really good one. So to start the inauguration function, I would like to call upon our president, Dr. Gitanjali Sharma ma'am, to initiate. Ma'am, please.
Yes. Good afternoon to everyone. I welcome you all for this inaugural function of POS Spectrum 2020-21. As chief guest, we had invited Ms. Rubal Agarwal. She is the additional commissioner, municipal commissioner of Pune Municipal Corporation. She heads the health services. She is the chief executive officer of Sri Sai Baba Sansthan Trust. She has also been the CEO of Pune Smart City, and she has improved Pune and made 15th in position in India. Next, please. So we salute Ms. Rubal Agarwal for her untiring work done in last 1 year in COVID pandemic in Pune. She has done extraordinary work. She is also a mother, wife, and a family. But taking care of Pune city was more important for her. There is a famous saying which was published in many papers that her 7-year-old son said, "Mama, you are not a police. Mama, you are not a doctor. Then why are you going for your duty?" That shows us what is the role of administrative officer in COVID pandemic. She started flu clinics, mobile ambulances by municipal corporation. She started a COVID diagnostic bus for mass testing in slum areas. Robust contact tracing was done. Door-to-door survey was started. High-risk survey detected hotspot areas and comorbidity survey. So in various ways, in multiple ways, she tried to control COVID pandemic in Pune city. Next, please. So it was a multi-level work to manage COVID pandemic. Even the technical use was done. I would also like to welcome our next guest is Dr. Padma Shri Raman Gangakhedkar sir. I hope he is there. Next, please. And now I would like to welcome all the past presidents of POS, MOS, Dr. Khedkar sir, Dr. Jhamar sir, Dr. Jathar sir, past president of POS, Dr. Medha and Dr. Nitin Prabhu Desai, past president, Dr. Colonel Deshpande sir, Dr. Marathe, Dr. Parikshit Gokte, who is the president of MOS, Dr. Taswala, who is the vice president of MOS, and Dr. Santosh Bhide, again the second vice president of MOS, Dr. Ladi, past president of POS, MOS, Dr. Sanjay Patil from IMA, Dr. R.P. Gupta sir, Dean of Mymar Medical College, Talegaon, all other head of the departments of various medical colleges, and all the chairman, co-chairman, past presidents of POS who are present. I welcome you all for this inaugural function. I also welcome to all delegates who are faculty at various medical colleges, all the consultants, young ophthalmologists. This was felicitation done of Ms. Rubal Agarwal at PMC from POS, and she was requested to come for the inaugural function. But believe me, friends, she is busy because there is an emergency meeting going on at PMC because the cases have increased. And she has sent me the message saying, sorry, going for an emergency meeting with all officials, discussions on strict restrictions. My best wishes are always with you all. Just be responsible citizen of Pune. Take care of yourself, your family, and society. So she is on work now. She is on her duty now. So let's do the inauguration, lighting the lamp.
वक्रतुंड महाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा।
So yes, that's me, and it's been a wonderful journey till now. The scientific sessions have gone really well, and I'm sure it's after our inauguration function, the scientific session will go on really well. So I'm really happy that I've got this opportunity to serve as a secretary of Pune Ophthalmological Society in this COVID times. So we will straightforward move ahead I'll request Dr. Geetani Sharma ma'am to have a few words, please.
Yes. Thank you, Dr. Mukesh. You could have spoken much more because he has done tremendous work in last 1 year. So I thought Mukesh would speak a lot. So I kept my timing as 5 minutes and I wanted Mukesh to speak more. Anyway, so all the respected past presidents of POS, MOS, all my respected teachers, seniors, all the faculty, panelists who are contributing for this conference, all scientific committee members, all managing committee members, and all the delegates from different parts of India. It gives me immense pleasure speaking as President of Pune Ophthalmological Society at the inaugural function of POS Spectrum 2021. It is the rescheduled POS Spectrum 2020. As we all know, year 2020 was unique, where most of the parts of the world had come to a standstill. With changes happening all over and with challenges given, we had to organize a conference in a different way, on a virtual platform. A virtual conference may not have that shining glow of a 5-star hotel, but with excellent scientific content, we tried to give the true glow to this conference. COVID pandemic has made us introspect. The tagline of POS for this year is Vision 2020 and beyond, Vision Beyond Sight. Scientific meetings are for exchange of knowledge, discussions and debate, and getting updated with recent developments in the scientific field. This conference is different in many ways. As I mentioned in my presentation, it is the first virtual annual conference in history of POS, getting 4 MMC points, with first virtual skill transfer course as well. It is the first POS conference with international faculty from both sides of the world, East and West, coming on the same platform. Yesterday afternoon, we had this fantastic opportunity to speak with them. There was a first special oration by an expert in the field of COVID. In this era, I thought this would have been the best for our members. We tried to give platform in this conference to the young ophthalmologists of POS. If you have noticed all the sessions, my young brigade of POS was there in front. And now in the evening, we have a special session for women in ophthalmology. And I hope all men will also attend that women in ophthalmology, a special session we are doing in this conference. No conference is possible without the support and help of a strong team. I'm blessed. I'm really blessed to have a team of our enthusiastic, creative, and hardworking managing committee members. I have no words to appreciate and thank all of them. And my special thanks are to Dr. Mukesh, the Honorary Secretary of POS. His precision and perfection in planning and execution are beyond imagination. I have never seen him saying no to me. Whatever ideas I would say, the next moment he would say, yes, madam, we'll do it. You know, that kind of support and help and encouragement you need. And we had a very good rapport with both of us, and we could do all the programs as well as this conference. I thank all others, Dr. Sachin, Dr. Himashri, Devika, Seema, Rujuta, Pranjali, Vrishali, Yogesh, Sagar, Prabhuji, Anand, Dr. Ramesh Murthy. Just forgive me if I'm forgetting somebody's name, but I think I've taken everyone. and our conference coordinator, Dr. Salim Pathan. I once again thank everyone, all the seniors, for all the help and guidance given to us during these COVID times, and especially for this conference. At one time, we thought cases are less, we can do a physical conference. We planned everything, we worked hard. Physical was not possible. The cases started increasing. We thought of doing a hybrid one. We again worked hard, we changed the venue, we discussed. Again, we planned everything. Again, we had to change, and finally we had to do the complete virtual. But I am happy with the scientific content and with the attendance that I am seeing. It was a successful conference. I wish to thank the support of every senior, advisors, coordinators, and for the academic grant which we have received for this conference. There is a small song written by me. It's a small gesture from managing committee to all the members. And this is my gesture saying thank you to all of you. I have written the lyrics. The music composer and the singer is Dr. Mohika Damle. She is daughter of our member, Dr. Pradeep Damle. The music arranger and sound recording has been done by professional sound recordist, Mr. Mayur Kumar. The paintings used in this song are by Dr. Madhavi Mehendale and Dr. Suchismita Behre. I thank them. POS is grateful to them. And the photographs used are by Dr. Shrikant Kelkar sir, Dr. Santosh Bhide, Dr. Ladi, Dr. Chandorkar madam, Dr. Suvarna Gokhale madam. They were all from the morning pose. Here it goes. Thank you, everyone.
Brilliant song, ma'am. Brilliant song.
Beautiful song. Very nicely sung. Nice lyrics.
I think it is wonderfully written and wonderfully sung. Fantastic. POS.
And in a capsule, very nicely done up, Gitanjali. Fantastic.
Really fantastic.
So over to you, Dr. Mukesh now.
Yeah, so it was a wonderful video, and now we are in the award section. I think let's start this thing. And the first and the foremost, the biggest award POS confers is the Lifetime Achievement Award, and it's been that this award is presented to a senior member of the society for the contribution to the society in a scientific and an administrative capacity. And this is a huge award, and we are really fortunate that we have with us Dr. Vaijayanti Dedar ma'am. She is. Can I request Gitanjali ma'am to please come in, because such a huge personality. I would request you to please introduce.
What should I say? I don't know. Honestly telling you, I'm really overwhelmed, and I have so much feelings coming from inside while I talk about Devdar madam. If you all remember, she was the one who introduced me when I became president. So it's a huge honor, madam, for me to introduce you. She has been a great lady. She has received a lot of scholarships and awards. There are so many. How can I read everything? But the most important thing that I want to say is she is a great eye surgeon. She has been a great teacher. She has written a chapter in a book of SICS, which is useful for every one of us. She has always upgraded herself. When she started, must be an era of intracapsular cataract surgery, but she changed to ECC, then she changed to phaco, SICS, everything. Whatever new knowledge is coming, she upgrades herself. Next, please. She has got so many awards up till now. This is a family photo with her two daughters, well settled, two most intelligent girls. Both of them are PhD. One is an engineer, one is a biotechnical scientist, and they all are in US. So I wanted to talk about this photo. When the committee suggested her name, we were in Maldives, myself and madam. And this moment, madam, I'll remember all my life. This was the most beautiful moment. Piche pura sagar hai. There is no one, only she and me. And I gave this letter to her that she would be the Lifetime Achievement Award recipient this year for POS. Next, please.
This program was conducted at the IMA office.
We had to do a lot of changes due to COVID pandemic. So I would have loved to have this program on a proper platform, but whatever we could do, we did it in IMA. Yes. May I now request Himashri to speak the citation, to read the citation, please.
Thank you so much, ma'am. Pune Ophthalmological Society proudly confers Lifetime Achievement Award upon Dr. Vaijayanti Dedar for her exemplary contribution to society as an ophthalmologist and as an individual. Your untiring and selfless service to society for the last several years in the field of ophthalmology has had a positive impact and immensely benefited the community. Providing ethical and compassionate care to everyone has been the achievement of your life. This has earned you respect and popularity amongst all your peers. Helping the needy has been the hallmark of your career. You have given your free and charitable services from various platforms, not just in India, but also to underprivileged in Kenya. You have shown us what service above self is. Your determination to keep learning enabled you to adapt to the new technological advances in ophthalmology easily, and you have excelled into them. With your vast experience as a postgraduate teacher and practitioner, you have helped treat many challenging and difficult cases. You have trained many students under your wings, and today they are recognized as excellent eye surgeons. They have gained your vast knowledge, care, and the personal touch you have always offered and have inspired in others. The chapter written by you in book on SICS is very useful for all students of ophthalmology. Live surgical demonstrations by you at live surgical workshops have always been a treat for all eye surgeons. Your scientific paper presentations at international and national conferences are well appreciated. Ma'am, you are a complete woman, a loving mother of two intelligent and successful daughters, Dr. Meghna and Dr. Tejal, and a devoted and inspiring wife to late Dr. Jayanti Deodhar. With your all-round and pleasing personality, you have always been a winner. And as your name suggests, Vaijayanti is the name of Tulsi. Like Tulsi, you have always benefited others with your devotion and dedication. Pune Ophthalmological Society appreciates your contribution towards scientific and academic progress of ophthalmology and is honored to present this award to you. Thank you. Over to you, Gitanjali.
Respected Honorary President of Pune Ophthalmological Society, Dr. Gitanjali Sharma, respected office bearers, my adorable seniors, juniors, and all my dear friends, thank you very much. Today, I am really nervous and humble. I am thinking whether I really deserve this prestigious accolade of Life Achievement Award. I have spent full 36 practicing years in Pune with soulful contentment. My humble efforts have been in inspiring juniors, motivating my contemporaries, and respectfully acknowledging my torch-bearing seniors. With such intense satisfaction, I am having this wonderful opportunity to address you all. In these 36 years, I have witnessed the changing facades of medical practice along with updates in knowledge and updation in equipment. I have come a long way from knife section and intercapsular surgery to phacoemulsification and intraocular lens implantation. The line of progress shall never end. I must continue to remain humble and be a student for life. The motto of my life has been to make Herculean efforts in whatever I do and leave the rest to Almighty. Gifting vision to my patients will never lose its prime position for mankind. My little success has seen the light of the day due to teamwork and their hand-holding with me. I will fail in my duties if I do not mention a few names of those who guided me along my path. Actually, there have been numerous persons who have helped me all through my career ground. First and foremost, I have to acknowledge my father's role. Since my childhood, he had been telling everyone that माझी मुलगी मोठी झाली की डॉक्टर होणार. It was a driving force. I worked hard, wanted to live up to our expectations. After seeing my results of inter-science examination and 98th rank in Bombay University, I was sure to get admission for MBBS. During my residency in ophthalmology, my teachers and seniors helped me strengthen my foundation. Those days, our ophthalmology department was not very well equipped. I wanted to learn indirect ophthalmoscopy. We used to go to AFMC and there Colonel Madan Deshpande sir would willingly and patiently teach us. He would also take mock viva on slides and instruments. Thank you, sir. Also, in those days, a lot of innovations were happening, like FFA, fundus camera, OCT, CT scan, MRI. All these were not there in any of our textbooks, but these were described in a book called Your Book. It was expensive. I could not afford that book. But I came to know that one doctor named S.B. Kelkar had this book. I did not know him personally then, but I just called him up one day, and the next day he handed that book to me in our ophthalmology department. What a wonderful gesture that was. When I started practice, I was doing intracapsular catheter extraction with ACIO. One day, after a good surgery, I was taken aback when the next day patient came with a red eye and this patient came with a pupillary blocked glaucoma. I had forgotten to do PDI. Dr. Sudhir Kale, sir, he was God sent. He tackled the complication and taught me to be more careful. Thank you, sir. Dr. Asha Tekar was a friend, philosopher and guide. I would discuss all my professional and personal problems with her. And she would say, Kaji karu nakos, sab chhan hoye. I miss her a lot. I started doing manual SICS long back, but my late husband, Dr. Jain, encouraged me to progress to paper surgery and bought me my first paper machine. I posted my first paper surgery and requested Dr. Kelkar to stand beside me so that I could learn the proper steps. He came, but he just stood by my side and asked me to start. After every step, I would look at him expectantly to take over, but he did not. Nervously, I completed the case, but that boosted my confidence. Thank you, sir. I have been a PG teacher and taught many students, but soon it was the other way around. These very students became my teachers. Dr. Nilesh Uplechwar, I thank you for teaching me the final steps and sharpening my paper skills. I'm still not as perfect as him. I thank Dr. Aditya, Dr. Vidyadhar for bailing me out of my complications sometimes. Pardon me for omitting many more names. I thank all my patients for putting their faith in me and helping me to improve. When I just started climbing the ladder towards my goal, destiny played a horrible game. Threw me into a deep void. The sudden demise of my dear husband, Dr. Jain, left me shattered and devastated. He was like a solid rock, always encouraging. Thanks to my parents-in-law, my friends, my colleagues, and my daughters, they pulled me out of my depression. They put me back on track with unending support. It took me almost 2 years to restore my confidence. Then I told myself that I have to fight this lone battle. Thus I worked hard, sincerely. And it's time for me now to hang up my boots, rather my gloves. So let's see. My happiness and fulfillment are boundless today, while I'm being honored with this Lifetime Achievement Award by our prestigious Pune Ophthalmological Society. With folded hands and my head bowed down in humility and gratitude, I accept this honor bestowed upon me for my simple achievements. This moment is much bigger than me. This moment is for Jen. I thank God for whatever I am today, and I dedicate this award to my late husband, Dr. Jen. He would have been the happiest person on earth today. I would like to end my speech by offering my help to whoever needs it. Thank you.
Madam, thank you for that speech, but there was some technical issue and the voice was not clear. But Madam is here, so I would like her to say a few words. Devdhar, Madam, you are here, please.
Yes, I'm really overwhelmed and I don't know what to say because I really don't know whether I really deserve this much of accolades. But all the same, let me thank POS for conferring this award to me. I wish there was no technical issue in my speech because I had written it with real emotions. But anyways, I thank everyone who all helped me during.
Madam, you can read it again. No problem. We are here to listen to you. Please read it, madam.
Okay, but then just give me one moment. I'll get it.
Yes, yes, definitely.
On behalf of the Maharashtra Ophthalmological Society, we also congratulate Dr. Vaijayanti Devadhar for getting the lifetime award. And it's a big achievement. She has been a very dedicated person too. She has got involved totally in all the POS activities. At this age also, she is so enthusiastic. Say, let it be whether it is academic or non-academic, she's always in the forefront. So that is so nice of her to be involved at this age. Right, Gitanjali?
Yes, and one thing must be
Well deserved.
Yes, well deserved, definitely. In this COVID pandemic, she has not kept her clinic closed even for a day. She has been continuously working even during COVID pandemic for her patients. Okay, madam, please.
Absolutely.
Yeah, it's our pleasure and honor that you read your speech again. Okay.
I'll just read it. Respected Honorary President of Pune Ophthalmological Society, Dr. Gitanjali, respected office bearers and my adorable seniors, juniors, and my dear friends. I thank you a lot. Today, I'm really nervous and humbled. I'm thinking whether I really deserve this prestigious accolade of Lifetime Achievement Award. I have spent full 36 years practicing in Pune with soulful contentment. My humble efforts have been in inspiring juniors, motivating my contemporaries, and respectfully acknowledging my torch-bearing seniors. With such intense satisfaction, I'm having this wonderful opportunity to address you all. In these 36 years, I have witnessed the changing facades of medical practice, along with updates in knowledge and upgradation in equipment. I have come a long way from night section and intercapsular cataract surgery to phacoemulsification and IOL implantation. The line of progress shall never end. I must continue to remain humble and be a student for life. The motto of my life has been to make Herculean efforts in whatever I do and leave the rest to Almighty. Gifting vision to my patients will never lose its prime position for mankind. My little success has seen the light of the day due to teamwork and their hand-holding with me. I will fail in my duties if I do not mention a few names of those who guided me along the path. Actually, there have been many persons, numerous persons who have helped me all through my career graph. First and foremost, I have to acknowledge my father's role. Since my childhood, he had been telling everyone that माझी मुलगी मोठी झाली की doctor होणार. It was a driving force. I worked hard, wanted to live up to our expectations. After seeing my results of inter-science exam and 98th rank in Bombay University, I was sure to get admission for MBBS. Now, during my residency in ophthalmology, my teachers and seniors helped me strengthen my foundation. Those days, our ophthal department was not very well equipped. I wanted to learn indirect ophthalmoscopy. We used to go to AFMC, and there, Dr. Colonel Madan Deshpande would willingly, patiently teach us. He would also take mock viva on slides and instruments. Thank you very much, sir. Also, in those days, a lot of innovations were happening, like FFA, fundus camera, OCT, CT scan, and all these were not described in any of the books available in India. But I came to know that these were described in a book called Yearbook. It was very expensive, could not afford. So came to know that one doctor named F.D. Kerkar had this book. I did not know him personally then. I just called him up, and the next day he handed the book to me in the department. What a wonderful gesture. When I started practice, I was doing intercapsular cataract extraction with ACIOL. One day after a good surgery, I was horrified to see that the patient came with pain, watering, and a red eye. He came with a pupillary block glaucoma. I had forgotten to do PDI. Dr. Sudhir Kare sir, he was God sent. He came and tackled the complication and taught me to be more careful in my future surgeries. Thank you, sir. Dr. Asha Kekar was a friend, philosopher, and guide. I would discuss all my professional and personal problems with her. She would say, "काळजी करू नकोस, सगळं बरं होईल." I miss her a lot. I started doing manual SICS long back, but my late husband, Dr. Jayant, encouraged me to progress to phaco surgery, and he bought me my first phaco machine. I posted my first phaco surgery and requested Kekar sir to come and do it for me so that I could learn the proper steps. He came, but he just stood by my side and asked me to start. At every step, I would look up expectantly to him to take over, but he did not. Nervously, I completed the case, but that boosted my confidence. Thank you very much, sir. I have been a PG teacher throughout. I have been a PG teacher and taught many students, but soon it was the other way around. These very students became my teachers. Dr. Nilesh Uklenchwar, I thank you for teaching me the finer steps and sharpening my phaco skills. I am still not as perfect as him. I thank Dr. Aditya, Dr. Vidyadhar, and many others for bailing me out of my complications, and I learned at every step. Pardon me if I have omitted any names. I thank all my patients for putting their faith in me and helping me to improve. When I just started climbing the ladder towards my goal, destiny played a horrible game, threw me into a deep void. The sudden demise of my dear husband, Dr. Jayant, left me shattered and devastated. He was like a solid rock, always encouraging. But thanks to my parents-in-law, my friends, and my colleagues, and my daughters, they pulled me out of my depression. They put me back on track with unending support. It took me almost 2 years to restore my confidence. And I told myself that now I have to fight this lone battle. Thus, I worked hard and sincerely. I think some of us feel that it's time for me to hang up my boots, rather my gloves. So let's see when I take this decision. My happiness and fulfillment are boundless today while I'm being honored with Lifetime Achievement Award by our prestigious Pune Ophthalmological Society. With folded hands and my head bowed down in humility and gratitude, I accept this honor bestowed upon me for my simple achievements. This moment is much bigger than me. This moment is for Jay. I thank God for whatever I am today. I dedicate this award to my late husband, Dr. Jayant. He would have been the happiest person on earth today. But I would like to end my speech to offer my help to anybody who needs it. Thank you very much. Thank you once again. Thank you, POS, for conferring this award. Thank you.
Very nice.
Thank you, ma'am, for those kind words. Madam has been so loving, so caring, and many of the lady members here, they know. She has other hobbies as well. So whenever you meet her, she'll give you something. Eating is still there, food is always there. But she has knitted socks, she has knitted gloves for all of us. And त्यांचे ते जे प्रेमाचे अंश आहेत ते सगळे आमच्यामध्ये आहेत. And I wish you, madam, you continue work. Lifetime Achievement Award, you are saying की आता मी नाही काम करणार असं नाहीये. In fact, you are our inspiration. And you are there always to guide us. So it is my pleasure and honor that in my tenure, Lifetime Achievement Award is conferred on the Devdhar madam. Thank you very much, madam.
Congratulations.
We'll continue. Just for a notice, we have eaten away our lunch break. The Konya session will start at 2, but the lunch break is not there because of we are running a little bit behind the schedule. Our next award is another special award from POS, POS late Dr. Asha Kelkar Award. It's given to a person who has made enormous contribution to the POS in academic, social, community, and non-academic fields. And it is my honor to that this award has been conferred upon to Dr. Sanjay Shah sir. And we were fortunate enough to meet him in the IMA office last week, and this was the award that was given to him. Can I request Dr. Pranjali?
Yes, am I audible?
Yes, please.
Yes. For over about 2 decades, either in capacity of president or as office bearer or scientific committee member or even as an ordinary member, Dr. Sanjay Shah has shown a great efficiency and dedication to strive for the glory of Pune Ophthalmological Society. During his tenure as president in year 2015-16, he organized excellent academic and scientific programs and also an excellent annual conference. Later, in 2018-19, he played an important role as conference coordinator. He has been organizing committee member for many state, national, and international conferences organized by POS. He has played important role as committee member in filing a case against AB scan registration under PCPNDT Act at Bombay High Court. In recognition of his relentless efforts for betterment of Pune Ophthalmological Society, Managing Committee of POS 2020-21 takes immense pleasure to honor the most deserving individual, Dr. Sanjay V. Shah, with late Dr. Asha Kelkar Award for the year 2020. Dr. Sanjay Shah has been HOD at KEM Hospital and has a private practice since 1991. Sir became life member in 1991. Sir has received many awards. Among them were Best Video Award for MOST 2004, then Most Interesting Case Presentation Award by POS 2005 and 2008. Congratulations, sir.
May I invite Dr. Sanjay Shah himself to say a few words?
Yes, thank you, Pune Ophthalmology Society President Dr. Gitanjali, respected President Dr. Gitanjali, my teachers, seniors, my dear. I don't know whether I deserve this award, but I would like to thank the selection committee for proposing my name for this award. Kelkar Madam, Asha Kelkar Madam was a great lady who worked for the society selflessly with complete dedication and helped whenever needed for the upliftment of the society. She never held any official post in the society, but still she was working for betterment of the society. I know that she was very helpful and she solved all the problems of juniors whenever in need. I salute to such a great personality. I am happy to see the progress of the society in the hands of Young Brigade. I must appreciate the work done by Dr. Gitanjali, President POS and her team in such difficult times of COVID and kept members together by her innovative ideas and implementation of those programs in a novel way. And the novel program has really kept all the members together all throughout the year. I congratulate Dr. Gitanjali and her team for the same. I shall be available for any help, suggestions, whenever required in future for the society. Once again, I thank the selection committee and the managing committee of POS for bestowing this award on me, and I accept the same. Thank you very much.
Thank you, Dr. Shah. Thank you for your kind words. On behalf of POS as well, this award has been instituted by a few members of POS in name of late Dr. Asha Kelkar Madam. As Dr. Sanjay Shah said, Dr. Asha Kelkar Madam had contributed a lot for POS. but she was never president of POS or anything, but she was much more than that for POS. She has helped and she has touched upon many lives of POS members. Many of us have learned from her. Many of us learned from her private clinic as well. But even if I was not directly working with her, she had helped me, she had given me guidance. So that was her nature. So this was remembering Asha Kelkar madam, and thank you, Dr. Shah sir, for those kind words.
Thank you so much. Thank you.
Well, continuing award function, the next award is the POS Dr. Madhusudan Savar Netra Seva Award. And it's always given to a managing committee member who has contributed a lot to the POS activities, the POS conferences, the POS CMEs, and has to be young, less than 45 years of age, and has done a tremendous community work, also a good amount of scientific and research work. And to be very frank, I'm really happy that this award has been conferred to my partner in crime, my brother, Dr. Sachin Kabra sir, and he is here with us, and he is an alumnus of Shankara Netralaya, and we know he is an amazing VR surgeon and has presented papers at various national and international conferences, as well as published papers in peer-reviewed journals. He does a lot of philanthropic activities. We know his Facebook posts are very enlightening for many of us. And he is a recipient of several awards. Mrs. Swarnalata Punshi Award for the Best Research Fellow, Shankara Netralaya, Best Student of the Year. And he has received many more awards. So it's we are really happy that this award has been given to Dr. Sachin Kabra. And we know that he's been actively involved in the patient care even during the pandemic. And this was the award that we had given to him, conferred upon him on in the IMA office. I request Dr. Sachin sir to say a few words, please.
Thank you, everyone. Thank you, Mukesh, for the introduction. Well, a bit overwhelmed now. Thank you, Gitanjali ma'am, all managing committee members, all selection committee members, all my colleagues from POS, MOS. I humbly accept this award. I think there are many other people also can get this award, but I was initially a bit hesitant to get it because personally, I stay away from limelight and keep myself a low-profile person. But it was persistent by Gitanjali ma'am, and especially a strong phone call from Taswala sir, which we humbly accept this award. I wish to thank Dr. Zawar sir for this. It is just my journey started in social service with Zawar sir because I was a medicine student and never thought of doing ophthalmology. But I had just as a PG student, I attended one of his client camps in Saswad for the Warkari person, and that sometimes ignited a community sense in me also. And the journey started from there. I wish to thank my late father, who was an excellent human being, an excellent doctor, who also involved in community service. I thank my mother, who raised me despite all the difficulties. After the untimely death of my father, a special thanks to my wife, Dr. Aarti, who has been a strong support for me, my kids, Avni Atiti, sorry. My in-laws, Dr. Zawar and Mrs. Zawar, all my friends, colleagues, my patients, who allowed me to touch their eyes with a great faith. And above all, I thank Almighty God for giving me this life and serving you all. On the behalf of Punatnik Society, I thank all of you for bestowing me with this award. I hope I stay worth for it, and I'll continue the good work given by me, given by all of us. And as Mukesh said, this work has been done to all managing committee members. I know this because of this treasurer post. I got to know many great managing committee people, especially young people, young females. I got there are very few males in our managing committee, for a change. And all these girls are doing exemplary work, balancing both work and things. So I dedicate this award to them also. I also dedicate this award to all those people who are doing a lot of social service in private practice. I know there are many institutes in Pune doing a great social service. But like there is HUSI, there is Dinanath, there is NI also for that matter. But there are a lot of all those people, private practitioners, also doing good service. Because I personally believe that only a good human being can become a doctor. There are many people that who have money, who have talent, but God doesn't make them doctors. So all of us are blessed human beings to become a doctor. And it becomes a natural responsibility to carry on the God's work, the community work further. And I know every one of us who's a private practitioner is doing some community work in his or her capacity. Usually stays out of the glare of the social media, usually stays out of the social recognition. Many people don't mention it also. But I am aware every one of us is doing this work. And this award is for all of you. And on behalf of all of you, I'm accepting this. I hope this inspires all of us to continue good work we are doing. I thank once again POS, our President Gitanjali ma'am, our Secretary Mukesh, who has been as partner in crime, but my crime role has been very less, I guess. Main work has been done by him. All managing committee members of POS, and thank you one and all for allowing me this and accepting this award with great humility and humility. Thank you once again.
May I request Dr. Devika to read out the citation, please? Unmute yourself, please.
Yes, ma'am. Dr. Sachin Kabra, vitreoretinal specialist. He's a young, dynamic eye surgeon. He's an alumnus of Sankar Netralaya and has 12 peer-reviewed publications and many presentations at national and international conferences. He is actively involved in community service through Pune Netra Seva Pratishthan and was team member for Limca Book of Records and Asia Book of Records. Through his project Netra Mitra, he is giving services to underprivileged for diabetic retinopathy. We appreciate his organizational skills and his meticulous work as managing committee member and as honorary treasurer of Pune Ophthalmological Society. Managing Committee of POS 2020-21 feels happy to confer this award upon Dr. Sachin Kabra. Congratulations, sir.
Thank you so much.
So moving on, the further award, Dr. POS Mrs. Shubhada Kulkarni Memorial Award for the POS Annual Conference, and it's instituted by Dr. Medha Prabhudesai and Dr. Nitin Prabhudesai in the memory of Dr. Medha ma'am's mother. And the awardees, these were the last year's winners. And we congratulate Major Sumedha Awards and Surgeon Lieutenant Commander YVK Chaitanya for receiving this award. Many congratulations to both the awardees. So we had the free paper session also yesterday and today, and we are happy to announce that the free paper award, Dr. Vijay Jathar Award for the best free paper, Dr. Harshita Sharma, she has won for her paper on predictors of positive outcomes in re-external DCR in patients with a prior SAG surgery. So many congratulations, Dr. Harshita, for the winning the best paper award, Dr. Vijay Jathar Award for the best free paper. So congratulations to, yeah, yes, ma'am.
Yes, congratulations, Dr. Harshita. Is she here? If she is here, she can speak something. This is the best free paper award for POS Annual Conference 2020-21. Dr. Vijay Jathar Award for the best free paper goes to Harshita Sharma. Is Dr. Jathar sir here? Okay. I think we can go ahead.
Congratulations to all the awardees. It's been a wonderful journey, and we were really happy to actually meet at the IMA office. So, ma'am, can we call upon Dr. Ramesh Murthy sir now?
Yes, and I request Dr. Devdhar madam to release the new issue of poster, souvenir of this conference. Dr. Ramesh? Madam, you have to just click. Madam is there.
Thank you, Gitanjali madam. And
yeah, I have clicked or.
Yes, yes, madam. You have to just click the mouse and yes.
I should. It says my internet connection is unstable. I don't know why. Can you hear me?
Yes, sir. Dr. Ramesh Murthy, sir.
Thank you very much, Dr. Gitanjali Madam and Mukesh. And thank you, Devdar Madam, for releasing this issue of poster. This poster, the theme is again cataract, and it is also the souvenir for our annual conference. We've got a lot of interesting articles and a lot of interesting things which are both pertaining to cataract, that is ophthalmology, and beyond ophthalmology. I'm sure all of you will enjoy this particular issue of poster, and we'll send it out by email to all of you in a day or two. I also wish to congratulate Gitanjali Madam for being such an innovative and such a great leader, and Dr. Mukesh and the entire team of POS for wonderfully supporting everyone and helping me in creating these issues of poster. Thank you very much once again.
Thank you so much, sir. We continue our this thing. We had a very successful innovation video competition that we carried out during our tenure, and we know that the winner of that tenure of that award is Dr. Monica Naik Nimbalkar. Is Dr. Monica here? Okay, so so this was an award that was given to Dr. Monica for her Best Innovation Award during the COVID times, and also for POS Surgeona Videothon. We also had a videothon, and very proudly, Dr. Ridhima Bagli was the winner of the POS Surgeona Videothon that was conducted in the month of December. We also had a MasterChef competition, and we were really happy that that there were two winners, Dr. Shilpa Patel and Dr. Suni Ibrahim, and it was really nice that we got to eat the cake also baked by them on this particular event at the IMA office. So many congratulations to both the winners. And obviously, we also had done the Diwali Rangoli competition, and it was won by Dr. Sarika Sethia. And many congratulations to her too. So this is our team, and we thank you, ma'am. Would you like to say something?
I thank everyone. This was, you can see all the safety measures taken, managing committee with all masks. We had this small function. And I thank everyone from bottom of my heart, all the seniors, all past presidents. Your encouraging force and your guidance has helped me to have this conference and to have this whole year properly. I won't say successfully, but properly. We could do something. At least it was not a 0 year. We could do some programs. We could do the webinars. We could do academic, non-academic activities. When the government permitted us, we could have a physical trek as well. All members were helping. When the government allowed, we also keeping the social distancing. We did a cricket match as well. So whatever was possible, it was done. And again, thanks from bottom of my heart to the managing committee members. I would say they are my frontline warriors, 14. And again, thanks to Dr. Mukesh Pariyani for his all help throughout the year. This might be our last program of the year. With the conference, our tenure would end on 31st of March. So I may not get the chance to say this to Dr. Mukesh and Dr. Sachin and the whole team, that you have been wonderful throughout the year. And I thank God for giving me such an excellent team so that I could work. Nobody never said no to me. Whatever I said, whenever I called, that MC member was ready to help me. Even for keeping peace, mind and body, whenever in the night also, I wrote somebody, tomorrow is this date. Can you send some drawing? Can you send some painting? They used to send to me. So it was a great year for me. I learned a lot.
And the honor is all ours, ma'am. They were all your ideas. We were just executing them. The ideas were all yours. So we are actually privileged and fortunate to have you as a president, ma'am.
Thank you, Mukesh, for those words. But the untiring work that you people have done, maybe the ideas were mine, but you people worked hard so that those ideas became reality. The ideas got executed. So that is also was very, very important. And I cannot take everyone's name and मला जरा भरून पण आले, but I had expected this conference to be a physical one, which did not happen. But even on virtual platform, at least I say namaste to each and everyone. Dr. Marathe sir is here. The whole Constitution Committee is here. They all have also been very, very helpful. At 4 o'clock, we have a GBM, and you will all know how much work they have done. Dr. Mukesh and team has also done a fantastic work of membership cards, which was a Herculean task, I would say. It was not an easy task, but they did it in spite of lockdown, in spite of all problems. They contacted each one and they have made those cards. So all these things have been done in this year. It is amazing for me, and I thank God for giving me such beautiful team and such people. I've become really, really humble. Maybe COVID has taught me this, the reality of life. I'm introspecting myself, and I feel I'm very, very fortunate to be president in this year for POS. Definitely. Thank you very much. And last but not the least, I must thank my family, my son, my husband, my daughter, everyone who were also always encouraging for me. Thank you very much.
So I think we are getting back to science now. It's 1:40. I would request the Konya session I'll request Dr. Yogesh to take over from here. Dr. Wag ma'am is here and all the
Dr.
Konya
Mukesh,
faculties.
Dr.
Yes,
Mukesh, before we end the program, we'll have to rise for the national anthem. So
yeah.
Can I request everyone to rise for the national anthem? We will sing together. Let's try. Or
Just
you
a
have.
minute. Just a minute, ma'am.
Yes. I request everyone to stand, please.
बोल योगेश बोल हा स्वप्नीलचा हा लास्टच ठेव एपी रनचा कोणाला काय हा म्हणजे आपलं रेग्युलर टायमिंग सांगायचं ना 1 minute लेफ्ट लास्ट मिनिट लेफ्ट हा ओके ओके हा ठीक आहे युअर डिसिजन नो प्रॉब्लेम
Jai Hind.
Jai Hind.
This was Atharva Vaimbe, son of Dr. Tejaswini and Dr. Prasad Vaimbe. Dr. Mukesh, as you said, we should disperse for lunch, and Dr. Yogesh and Dr. Sangeeta madam, Konya session will start sharp at 2 o'clock. So we have 10 minutes to have lunch. Yeah. Thank you, everybody.
People don't leave.
Actually,
be here. People don't leave.
Yeah.
The Konya session will start in 10 minutes. I request people not to leave.
I would like to say something, Dr. Mukesh. I congratulate all the awardees, and I would like to congratulate Rubil Commissioner Madam. She has done a wonderful job during this COVID time. I wanted to share one story that I went to US on 19th of January, and I came to Pune on 17th of March. On 16th of March, we landed in Mumbai, और उसके 1 घंटे पहले हम लोगों को सबको एक फॉर्म दिया गया और उस फॉर्म में ये लिखा था कि मुंबई में तो आप उतरेंगे, बट व्हाट इज योर फाइनल डेस्टिनेशन, आप कहाँ जाएंगे, कहाँ पर आपका एड्रेस है, आपका फोन नंबर क्या है, और उसमें हम लोगों ने सब लिखा था। और उसके बाद मुझे याद नहीं है, पर 17 मार्च के बाद 8-10 दिन बाद मुझे फोन आया कॉर्पोरेशन से। और मुझे पहले समझ भी नहीं आया, उन्होंने पूछा मुझे कि आप कैसे हैं, मैंने कहा ठीक है। नहीं, आप कहाँ से आए हैं, आपके साथ में और कौन कौन था, आपको कोई तकलीफ तो नहीं है। और ऐसे मुझे हर 3-4 दिन बाद फोन आ रहे थे, मतलब कॉर्पोरेशन से। आई वॉज वेरी सरप्राइज एंड मुझे बहुत अच्छा लगा कि जो कुछ डायरेक्टिव्स दिए गए हैं, मतलब जो सेंट्रल गवर्नमेंट ने, वो सारे यहाँ पर आने के बाद में भी फॉलो हुए। हर बार तो मैंने उनसे नहीं कहा कि आई एम ए डॉक्टर और मुझे मालूम है क्या क्या देखना है, बट आई अप्रिशिएटेड देयर गेस्चर। और सब लोगों ने मतलब करीब करीब 1 महीने तक मुझे हर 2-3 दिन बाद फोन आते रहे कि मतलब ये ऐसा सभी के साथ में हुआ जो वहां से आए हैं। और सो आई रियली अप्रिशिएट कि इन लोगों ने बहुत अच्छा काम किया। अदरवाइज कारपोरेशन से इतना अच्छा काम करने की हम लोग एक्सपेक्ट नहीं करते हैं, बट आई रियली वांटेड टू कांग्रेचुलेट। आई वाज नॉट नोइंग दैट कमिश्नर मैडम इज कमिंग फॉर दिस, बट आई रियली अप्रिशिएट। थैंक यू।
Thank you, ma'am.
I would just like to say something about Mukesh. Mukesh, you worked so hard, but you're so humble. Really, hats off to you. And you don't take credit at all. That's really...
नहीं मैम।
Yeah.
मैडम, ये दोनों करण और अर्जुन है गीतांजलि के, सचिन
really
है ना? That is how they function, and they are strong pillars, and that is how Gitanjali could function in a full force. And
मुकेश थोड़ा बहुत क्रेडिट ले लो आज अभी।
इतना बहुत ले लो। Give a proper speech and उसने 4 words, 4 words बोले।
Gitanjali, we have 10 minutes before lunch. Let him talk.
Yes, I think Mukesh.
I'm actually I'm fortunate actually to have secretarieship during COVID times. I could actually do a lot of things. I could connect to many of you, and I can't believe we have done so many events. I actually can't believe वो तो गीतांजलि मैम ने जब बताया तो मुझे याद है कि हमने ये किया हुआ है. But then it was good. It was good. We have tried to make it as flawless as we can. But still always there are some mistakes from our sides as well. And still, I mean, it was a good year. That's it. I would say that.
मैं ये कहना चाहूंगी कि कार्यकर्ता की जो डेफिनेशन है ना, तो उसमें कार्य दिखना चाहिए, कर्ता कम दिखे तो चलेगा। तो ऐसा आपने काम किया है।
I must say he says whatever mistakes, but if there were any mistakes, I take the whole responsibility, because Mukesh or anybody else in the team, they didn't do any mistakes. They tried their level best. Maybe in execution from my side, there could be. Sometimes I must have forgotten somebody's name, but they have not forgotten anything while doing. They were just perfect. Right now also you must have seen till late night yesterday he was working, Dr. Mukesh, and everyone, all the moderators were working.
And all the managing committee members, all of them, they are always available on phone. I can't name all 8, but because all 8 are the main core team who has actually helped us. So without them, so it's not possible, na ma'am.
Word for Gitanjali, your team is one of the most cohesive teams which I have seen of your POS. Well, I've been working with POS from day one, and the way you people have taken the charge, and on the virtual platform, that too, hardly any physical. Kudos and 3 cheers to the whole team, to you and your whole team. As I just said, you have that Karan and Arjun beside you, so you could really perform more than what was expected from you. मुझे लगता है कि standing ovation, everybody stood for the national anthem. They deserve this. Please stand up and give a standing.
Dr. Taswala, on a slightly satirical note, maybe because it was virtual, it was more cohesive.
No.
So that's what I said, on a satirical note. But you know, but the thing is always both ways. It is always both ways.
Sure that because of COVID, everyone has introspected himself. Yes. Because of COVID, we got a chance to understand each other better. That is for sure. And we had started forgetting small things and cribbing about small things. We have stopped.
We have learned our values now.
Look at a larger picture. So I think COVID has taught us definitely that thing.
Yes. No, but that's precisely the role of the managing committee and the leader. It is always a mutual thing. It's always a symbiotic.
I would like to say something.
You can't have one without the other.
Gitanjali?
Yes,
I would like to say something. Yes. I owe all my paintings and sketches to only Gitanjali, because she was the one who motivated me to draw more and more sketches and paintings. I had literally took brush in my hands after 35 years. Thank you so much, Gitanjali.
Thanks, Rujita. But Rujita is also so helping. I remember the next day was 2nd of October. Gandhijin's painting.
Yeah, I remember.
And I phoned her at around 7 or 8 o'clock in the evening, and till 9:30 her OPD was there. 12:30 in the night she sent me the painting. So that was a kind of, like everyone worked like that.
Commitment from each and every member.
Every member. Now look at Vrishali for vaccine. She had to study everything to give this talk, but I wanted this talk to be in this COVID session because there were a lot of misunderstandings about vaccine among members. So I said, we'll give, and she studied everything and gave a talk on vaccine. So that is a kind of commitment.
I want to share one incident. Keeping the morning blog in mind, I sent Gitanjali a write-up about one of my patients who I'm very, very fond of. And, her vision is what I want to project. And she said, nahi, eudasa nako, we'll make it into a workshop. And that's how the workshop on the low vision and the World Sight Day program happened. So it was just one small single liner from me, which became into a proper symposium. And that's the vision she has. It's the leadership that she has. And I think she has a brilliant future, and I really wish her all the best. And we're looking very excitedly as to what she's going to do in IMA. And I hope to see her on the national platform very, very
deepest
soon.
number. Next deepest
number.
All
National platform.
Thank you, Sangeeta, for such
She has converted all the obstacles into opportunities. A person we have seen, I am working in the parallel organization, Medijain, we have Yeroda Doctors Association, we are absolutely given it as a free year. Nobody performed anything. So it is really commendable to come up with such good ideas and score much more than the physical programs.
I think we should let Gitanjali and Mukesh go for lunch now. Otherwise,
I think Mukesh is a man of few words, lot of action, and a brilliant smile always.
Now I'm going to tell this Mukesh.
Chocolate boy, poster boy.
No, Mukesh, now he can't hide his face. Let me just share this incident. I've already shared with many others. I don't remember exactly which Deepastamba, but for every Deepastamba, we used to have 2 or 3 preliminary meetings with the person, then with among ourselves. So in one meeting, we just finalized everything, and then we were deciding on what should be the dress code. So that Deepastamba said, अरे ड्रेस कोडचा काय विचार करता, आम्ही कोट घालू का काय घालू. तो डॉक्टर मुकेश आला की आम्ही सगळे त्याच्या पुढे फिके पडतो, तर तोच फक्त दिसतो. So that was the thing. He was the real face model, like so it was really nice to have, and I really appreciate Dr. Mukesh. He never says no to anything. With a smiling face, he would do everything properly.
Shaken but never stirred, yeah?
Yes.
Sachin is like the silent figure, less seen, but always there.
It is very prompt and a lot of presence of mind. Mukesh?
Yes, sir.
One of the greatest words.
Oh, yeah. Today was a big saver.
Yes, he realized that it should not be come live anymore.
Yeah.
That was very good of you.
Yes, that was really, really good.
Yes.
So you might need to backtrack and delete a bit. The first bit you might have to edit.
Absolute presence of mind, Dr. Mukesh. That was creditable.
So, great session. 2 o'clock. I think we start the corner session.
Yes, we can
Dr. Yogesh, all the speakers are here. I can see them. And Dr. Wagmam is already there. So, Dr. Yogesh, over to you.
Yeah, we'll start in 5 minutes.
Till the time, just check the screen share of the first speaker, please.
Yeah.
Yeah, we request all speakers to keep their screen share ready the moment the previous talk is over, because we had to compress the 1.5 hour symposium into 1 hour, and we want to do justice for each and every speaker. There might be a little change in the sequence. I think, Yogesh, if you can just tell everyone.
Yeah. So actually, there is a fixed timings for each speaker, and we are starting with Dr. Ritesh Kankrania, and then we have Dr. Suchi, then Dr. Shilpa Joshi, then myself, then Dr. Pranav Radkar is there, and then Dr. Srujna, she is there, and then Dr. Swapnil Bhalikar. So this is the sequence. Dr. Ritesh, Dr. Shilpa, Dr. Suchi, they have 8 minutes for the presentation, and the last 4 speakers have 5 minutes each for the interesting cases or the cases which we face in our routine OPD. So this is the program for 1 hour. We have discussion time also. So we'll make it as interesting as possible.
The topics that were chosen were with relevance to general practice, and we hope that there will be a take-home message where everybody can treat cornea patients to some level of expertise in their own clinics. And of course, we wanted our younger lot who are so dynamic and up at the forefront of science and on national forums to take the platform. So I think we can start, Yogesh.
Okay, shall we start? Okay, fine. So good afternoon, everyone. I welcome you all for the cornea session. I would like to invite Dr. Sangeeta Wagh as a chairman and co-chairman Dr. Chitra Sambare. We have moderator Dr. Sameer Datar and Dr. Pranav More. I'm just introducing our speakers. Just a minute. Yeah. So we have Dr. Ritesh Kankrania. He's a senior consultant and head of Department of Ophthalmology at Aditya Birla Hospital. He has finished his fellowship from LVPI in cornea. He's in charge of PCMC Aditya Jyot Eye Bank, and his field of interest is cornea, cataract, and ocular trauma. Then we have Dr. Suchi Smita. She's a consultant at Dinanath Hospital, and then she has her own clinic. She was appointed as an international scholar in ICO examinations for exceptional marks achieved in the ICO examination in 2003. She has received gold medal during her MS ophthalmology. Then we have Dr. Shilpa Joshi. She is a head of cornea and ocular surface department, and she is a medical director at HV Desai Eye Hospital. She has done entire range of corneal ocular surface procedures, including more than 1,200 corneal grafts, 3,000 ocular surface procedures, and more than 35,000 cataract surgeries. She also has many publications in national and international journals, and she is the recipient of prestigious V.K. Chitnis Oration Award at Maharashtra Ophthalmological Society. And myself, Dr. Yogesh, I am working as a senior consultant at NIO, and I have my own clinic at Pune. My fields of interest are lamellar keratoplasty and keratoconus. Then we have Dr. Pranav Radkar. He is a cataract fellow from Shankara Nethralaya, and he did his long-term corneal fellowship from Shankara Hospital, Shimoga. His area of interest is ocular trauma, keratoconus, and refractive surgery. We have Surgeon Captain Dr. Srujna Bhaskar from AFMC. She is Associate Professor at Department of Ophthalmology, AFMC. She is trained in long-term fellowship from RPC AIMS, and she has received Chief of Naval Staff Commendation in 2012. Her area of interest is endothelial keratoplasty, refractive cataract surgery, and complicated cataracts. And lastly, we have Dr. Swapnil Bhaleka. He is a fellow from LVPI, and he is a director at Vision Care Center's Super Specialty Eye Hospital, Shirur and Shikrapur. His area of special interests are ocular surface diseases, management of Stevens-Johnson syndrome, keratoprosthesis, stem cell transplantation, and salivary gland transplantation. I'm handing over this session to moderators, Dr. Samit Datar and Dr. Pranav More.
Okay, good afternoon, everyone. So I think we'll start off with the first talk by Dr. Ritesh about corneal ulcers. Ritesh, can you please start?
Yes. A warm good afternoon to everybody. Thank you, Wag Madam, for giving me this opportunity. Thank you, Yogesh, for coordinating this session. I'll be talking about the non-healing corneal ulcer. When do you call an ulcer a non-healing corneal ulcer? You call it when there is no response to treatment, when the patient is not improving symptomatically, the pain doesn't go, the redness doesn't go, and there is no decrease in terms of signs, like there is no decrease in epithelial defect, there is no decrease in size of infiltrate, there is no decrease in hypopyon, and there is absence of scarring. The time frame where you declare a corneal ulcer as recalcitrant depends upon the etiology. In cases of bacterial ulcer, it is less, but in cases of fungal corneal ulcer, you give at least 5 to 7 days before you label it as a recalcitrant corneal ulcer. But the most important rule to understand is you can only label an ulcer as recalcitrant if you have already done a complete microbiological workup. If you have not done it, there is no reason to label it as recalcitrant. Now, what are the etiologies? What leads to ulcer non-healing? It can be a wrong line of treatment, which can be either that the diagnosis is incorrect or the microbiological reports are incorrect. And second thing can be inadequate therapy, where the choice of drug, gram stain has been done, but the culture and sensitivity has not been done. You know that it is a gram-negative organism. You start with an antibiotic, but then later on you realize that it is resistant to that particular antibiotic because you've not done a sensitivity. Second part of this thing is the wrong, inadequate therapy. You need to give loading dose in cases of corneal ulcer, and the loading dose is so important in the first 72 to 96 hours. But if the loading dose is low and the duration of load therapy is less, then the ulcer would not respond and it is more likely to become recalcitrant. Third important thing is inadequate frequency of instillation. So loading dose and the duration, as I discussed. Fourth is non-compliance of the patient. Many times I've seen it myself. For a fungal corneal ulcer, netamycin was prescribed and hometropine was prescribed. Netamycin was in the dose of 1 hourly. Hometropine was twice a day. The patient was putting hometropine hourly and netamycin only twice a day. Sometimes you ask the patient to bring the bottle and you will realize that the bottle is contaminated. You ask the patient to put the drop and you would realize that the patient is putting the drop only on the eyelids. The drop doesn't go inside the eye. So in this way, non-compliance we think is not a very important treatment, but part of, I think the ulcers not behaving properly. I think it is a very important measure to realize and find out whether the compliance is there or not. The other reasons are drug resistance. Nowadays, MRSA, Pseudomonas is pretty common. Fungi not responding to conventional antifungals are common. You give everything, netamycin, amphotericin B, voriconazole and the fungus doesn't respond. And many a times you end up doing therapeutic keratoplasty to save the eye. One of the 4 most important things in cases of ulcers where you are giving fortified preparation is the drug toxicity itself. The drug toxicity itself can lead to delayed epithelialization. It can also cause stromal thinning and sometimes even corneal melt. Other factors are ocular surface inflammation. These can be divided into 2 conditions which can lead to an acute ocular surface inflammation, like conditions having acanthamoeba keratitis associated with conjunctival inflammation, or a pseudomonas ulcer where there is lot of inflammation on the ocular surface. Some chronic conditions can also cause non-healing corneal ulcers, like ulcers associated with OCP, ulcers associated with atopic keratoconjunctivitis. Then there is dry eye, exposure keratopathy, use of steroids, neurotrophy, misdirected cilia, impacted foreign body in the upper tarsal conjunctiva, raised intraocular pressure, dacryocystitis, and uncontrolled diabetes mellitus. So I'll be discussing few cases where how did we realize these are all referred cases and how we were able to identify the cause of non-healing ulcer and how the patient got benefited. All right. Now, this was a case which was having complaint of redness and prickiness in the eye for the last 12 to 15 days. This patient is of age of about 48 years, and this patient was given topical antibiotics and lubricants with no relief. When you look very clearly, you see that these are infiltrates which are slightly raised with stuck-on appearance, and they are discrete. They are everywhere on the cornea. So clinically, we could make out that it's probably, and this was probably in August or September last year. Last year, not last year. Last year, we had very few cases anyways. But this clinical diagnosis of microsporidia was made for this patient. There was no laboratory diagnosis. So what we did is clinically based on the diagnosis, we did total corneal scraping and send the scraped corneal epithelium for calcofluor white stain. The patient was prescribed lubricant. Eventually, the patient healed without any problem in the next 96 to 5 to 7 days. And the calcofluor white also confirmed the diagnosis as microsporidia keratitis. Now, this is a case of an ulcer which happened in a person who was a contact lens wearer. This is a large ulcer with soapy appearance, with an hypopyon, with severe corneal edema, as well as conjunctival inflammation. This obviously, clinically, everybody can make out that this is most likely a gram-negative infection due to Pseudomonas. The problem here is you treat Pseudomonas with conventional, with antibiotics, and you may get response, but many a times the Pseudomonas are multi-drug resistance, where you have to then prepare colistin, which is the only method right now to save certain eyes. During the treatment, when there is a response, you have to understand that the inflammation on the conjunctiva has to be controlled. So later half of the treatment, where the diagnosis is confirmed, where the culture and sensitive reports are with you, and the infection is going down, the size of infiltrate is decreasing, the scarring is starting. To help epithelium heal, you at a certain point of time need to start topical steroids.
Dr. Ritesh, we have 2 more minutes for your talk.
Yes, I understand, sir. Now, this was a diagnosed case of gram-positive cocci. The culture reports were not there, that organism was not identified. So we had to stop therapy for about 2 to 3 days, re-scrape, send it for microbiological examination. But the clinical appearance of a cracked windshield led us to a diagnosis of atypical mycobacteria. The culture eventually proved that, and this patient was eventually benefited. Now, this is a case of fungal corneal ulcer. In the reports, it was mentioned as an aseptate fungi, which eventually came out to be Pythium. And Pythium, not all Pythium would respond to linezolide, but this person responded to linezolide and became okay in the next about 2 to 3 weeks. It took very long for this Pythium to go away. This is a picture of a very well-defined ulcer. There is hardly any infiltrate. And this was a case of a neurotrophic keratitis. And by doing tarsorrhaphy for this patient, we were able to take care of the epithelial defect and save this eye from suffering from an infection. This itself is a very telltale sign. This non-healing corneal ulcer is because of exposure keratopathy. See the inferior scleral show, such a large area of inferior scleral show. And this again benefited from median and paramedian tarsorrhaphy. And the ulcer resolved in 48 to 72 hours, started resolving in 48 to 72 hours. And there was a scarring in the next 5 to 7 days. This again is a case where the microbiology reported it as slender gram-positive organism. And this was eventually a nocardia infection. It was a misdiagnosed case. The amikacin was the treatment, and this. So in conclusion, we have to ensure that there is a correct diagnosis. First of all, we have to check treatment. We have to rule out drug toxicity or associated persistent inflammation, which can lead to persistent epithelial defect in even corneal melt. We have to avoid multi-drug therapy, particularly if you are starting fortified preparation. And in case of non-responsive ulcers, we always have to rule out drug toxicity. These are methods of identifying and trying to treat an ulcer which is non-healing. Thank you so much for your patient hearing, ma'am.
Excellent. I think Ritesh has covered a lot of aspects with very well illustrated and documented cases. Just a couple of points I wanted to make is very often a non-healing ulcer is referred to you for an opinion and the patient comes in with a bandage contact lens. So a bandage contact lens is going to work like a tarsorrhaphy provided there are no other factors that are contributing. And what one tends to miss very often is either, like Dr. Ritesh said, under treatment, or there might be underlying disorders like a raised intraocular pressure, which is very often missed. So just a digital tonometry will tell you if the pressures are high, don't hesitate to start systemic and local anti-glaucoma agents because that will help. One of the slides that he showed had the typical classic rounded edges. Here again, just placing a lens is not going to help. You need to freshen those edges by scraping them to encourage the epithelium to slide. And the last point is the very undermined use of a pressure patch, where if a patient can be under your supervision, even today I do it, an extra tight patch kept for 48 hours. Of course, before you patch, you put the appropriate antimicrobial agents, and once the epithelium heals, you can put a bandage contact lens for about 4 to 6 weeks to maintain the epithelial integrity.
That was a great presentation by Ritesh. Nice cases, nicely discussed, and very nicely added points by Wag Madam. I think if anybody has any questions, they can either post it in the chat box so the panelists or the speakers can answer them. Because if we don't have time to ask, you can message them here. Now we'll go to the next speaker. That is Suchi Smita. She'll be talking on plugging the leak. Suchi, over to you, please.
Hello, everyone. Thank you, panel members, for this wonderful opportunity. I hope I'm audible.
Yes.
Yes. Okay. Congrats to POS on this beautiful webinar. And it's a great opportunity to be here. I'll just share my presentation. So we'll be talking about plugging the leak. That what are the simplest and best methods with whatever resources that we have. So this is either the corneal or the scleral or the corneoscleral leak, it can be. So based on the etiology, our approach will be different. If it is trauma or iatrogenic, say you're removing a foreign body and it happens, it's a one-time event and it's not going to progress more. But if it's an inflammation or a surgically induced necrotizing scleritis or an immune vasculitis, peripheral ulcerative keratitis, or even an infection, it's an ongoing event and we need to deal with other things and control the inflammation. Otherwise, the melt will recur or go on. And if there are healing issues like neurotrophic keratitis, severe dry eyes, and the exposure, again, there are a different set of things like tarsorrhaphy, preservative-free tears, and punctal cautery, which you need to do. And in degenerations like peripheral perforations in case of a PMCD or a Terriens, Here, visual aspects like controlling the astigmatism is also important, but you have more time over here. So now prevention is definitely better than cure. In a complicated case like this, for example, Stevens-Johnson syndrome, here you can see that the both eyes are having epithelial defects here, and this is not healing with preservative-free lubricants. The next thing would be add on autologous serum and then do an AMG. Within 1 day, we see that the melt which is happening over here is better. This looks like an infective infiltrate. Many times these infiltrates fool us. We can scrape them. If it's negative, we can go ahead with procedures to restore the epithelium like this. You can put a bandage form of amniotic membrane, which is used here as a patch, which will fall off eventually, but it will support the wound. Now this is PUK, lot of inflammation, and then this perforation can recur or it can spread. So we need to gear up for further systemic treatment alongside the local treatment, and also look into the other eye. Yes, now we are going through the second wave of corona. We need to look forward to second waves and third waves also in such inflamed eyes, because it will happen eventually in most cases. So systemic immunosuppression, steroids at the adequate dose, and even immunosuppressives at adequate dose and duration are important. Involve an immunologist. Topical steroids, preservative-free or lubricants, punctal plug or cautery, doxycycline, vitamin C, tarsoraffi, and AMG all come handy in various situations, case-to-case basis. Now, in trauma, when to anticipate a leak? A small agent, even like a pencil or a refill, can lead to a leaky wound because it is circular, and then it gapes the tissue, and sometimes your sutures cannot hold. So keep cyanoacrylate glue ready. That's the glue you usually use, but yes, you can use fibrin glue also sometimes, like this flimsy flap over here. It's a lamellar kind of flap which can tear when I take the suture. So a little bit of fibrin glue over there kind of nicely heals the tissue. Cyanoacrylate glue is a good agent because it has strength, tensile strength. But the problem is you cannot see what is going on underneath it, and then you shouldn't put too much, and also it induces vascularization like here and scarring. So wounds less than 2 mm, it's good agent to use alone, but if it is bigger than 2 mm, you will use it along with other agents. And how not to do it? Do not keep fluid on the surface, because the glue has a property to polymerize, and it expands once it polymerizes. So if you put excess, like here, if we are going to pour the glue on the surface, it becomes a big blob on when coming in touch with tears or aqueous through the fistulous opening. And when you put another blob, it becomes even more irregular and large. It irritates the patient, and BCL won't sit there properly. Plus the wound will be leaky. You need to redo this. So how to do? Put air in the anterior chamber. Put very little glue inside the crater first time, like in the gray is step 1. You put less than required, and there will be the remaining you can touch up later after this layer dries completely. And then after the second layer or third layer dries completely, you will be putting a BCL. BCL should not stick to the glue, otherwise it tears, and again it can come off, and it can dislodge the glue. You can use Mercel sponges to dry the surface. The back portion of this sponge can be, or the tip of plastic can be used to redo the glue in the second just touch-ups. So this is a trauma case where glue was put after suturing. This is again SJS, another infiltrate which is mimicking an infection and then ongoing melt. Glue can attract vascular vessels. You can see after 6 months it has cleared over there in the lower picture. This is again a small perforation seal. I'll go to a video. I won't play it fully. Now this is a traumatic cataract with a perforating wound. So we need to do the cataract surgery after closing the wound with sutures. Still the wound is leaky. So after the cataract surgery is done, I put the air bubble and then dry the surface with a Mercel sponge eventually, and then put a drop of glue over here and wait for it to dry. And the second application is done with the back side of the Mercel sponge like this. And so let it dry completely, then replace this air with fluid and check for leak, and then dry it and put the BCL in the end. Other techniques, when wounds more than 3 mm are there, you can use crisscross sutures like a scaffold in the deep area, then fill that with glue or amniotic membrane. Here you can use combination of fibrin glue along with AMG also. And this is another nice technique where a plastic drape has been cut with a punch using 3 mm punch, and a tip of it, the little bit of glue is put on one side, and it has been picked up with a Mercel sponge. And even at slit lamp, you can actually plug a melt like this. So you have an even surface with glue underneath in the crater. So amniotic membrane is another nice agent, but it is soft. It does not have tensile strength. So for larger wounds, you need to use along with other agents like suture and glue. The advantage, transparency is better. It limits vascularization, unlike glue. So for central wounds, it is good. But again, central cornea is thinner. So you need to think about the size of the wound and whether it will hold. This is a way to fill in deeper craters, multiple pieces of amniotic membrane or a roll of amniotic membrane, or stacking up layers with fibrin glue inside the crater, and then on top of it you will be putting an amniotic membrane patch or a graft based on the need. The patch will stay on top, let the underlying surface integrate. It can fall off eventually, the patch. This is a nice case done by Dr. Pratik Topiwala, where he has not used glue, he has used 2 layers of amniotic membrane as a graft here. He has denuded the surrounding epithelium and put the stromal side down. So the epithelium will grow over it and this will get integrated. In the previous case I showed, I have used it as a patch here. I have not denuded the epithelium. The epithelium will grow underneath it. Again, coming to Tennant's graft, a very nice technique in today's time, especially when the corneas are scanty. This is a nice case which was shared by Dr. Sangeeta Madam. And here she has done 2 layers of Tennant's for the perforation. And the top layer, she has sutured over the first layer. Advantage of Tennant's, again, you can stuff it into an irregular opening, but for larger wounds, it can balloon because it is soft. You need to use other agents. It does cause some amount of vascularization and opacity. Tennant's can be used with cyanoacrylate glue on top. It can be tucked into a lamellar pocket like this, and you can use overlay sutures on it to put down the Tennant's. And here overlay sutures are taken a little bit farther away over here like this and crisscrossed, or even put it to keep the Tennant's in place. A very nice article with series of 30 plus patients by Namrata Sharma Madam and team, where they have found that 87% of perforations could seal with Tennant's. They suggested it for smaller perforations, and tuck-in technique with cyanoacrylate glue or sutures was performed. This is again a nice case shared by Dr. Rishi Swaroop. This is a common scenario, post-cataract wound abscess. Now, this is a tunnel abscess where if you don't have patch graft, you can use Tennant's. He's taken Tennant's and then put it there and reinforced it with cyanoacrylate glue. Conjunctival hooding is also a good technique. If there's not a full thickness perforation, you don't have, you just aid the healing by putting a flap of conjunctiva in that area. This is a non-seeing eye which helped her. Now, patch grafts are done when the wounds are bigger, and these can be fashioned either manually or using punches, your dermatological punches, or even using your smallest trephines. What is important is you need to do peritomy, explore the area, remove only the necrotic tissue and the epithelium, but do not touch the healthy area. Basically, you keep it as lamellar as possible. You make it thin. The graft has to be thin enough so that it sits flush with the periphery. There should not be a ledge or a step where the healing is hampered, and again that can lead to a melt. So you take the graft slightly larger and trim it down to the required quantity size. Suppose you take a smaller graft to start with, then suppose you have to trim the surrounding necrosed area, then you get a gape. So it's important to take it of adequate this thing. This is rheumatoid arthritis with a peripheral crescent-shaped patch graft being done. So you take the 2 corner sutures first, and then you do the rest of the suturing. These are again.
Sorry to interrupt you, ma'am. How many slides are remaining?
I'll run through them.
Okay. Oh, fine.
So there are various shapes of grafts which are used, and shaping the grafts either using a stencil or keeping the graft in place and cutting it. So in sutures, generally it is full thickness whenever possible, and then use separate instruments for graft as well as the hose. Larger sutures have to be taken, and sclera can also be used. You have to thin it to at least 50%, cover it with AMG or with conjunctiva always. You can even tuck it inside a lamellar pocket and put glue. And again, finally, for large wounds where there is necrosis around, you can do a therapeutic keratoplasty. Again, preserve the limbus, which is healthy for the stem cells, and the trap mesh work also as much as possible, like in the superior aspect. This can go eccentric. And now this is dark being done for Terrians with near perforation here. Take it eccentric, or you can do it in 2 steps. You do a banana-shaped graft or crescentric graft, and later on do a dark. So that's how you would like to tailor how you treat. I hope that was useful. Thank you so much.
Dr. Chitra, would you like to?
Yeah, thank you, Suchi. Very nice presentation. You almost covered all the points which should be taken care of when we deal with the melt, and really enjoyed your illustrative diagrams. Very nice. Thank you.
Thank you. Thank you so much.
Yeah, excellent presentation. I think we can move on to the next talk.
Okay, can we call upon then Dr. Shilpa Joshi to present her next talk?
Is she having problems with the screen share? Dr. Shilpa?
Yeah, just a moment. I'm just trying to share it.
Till that time, I have one question. If we don't have cyanoacrylate glue, then is there any alternative for that?
Dr. Yogesh, yeah, we can use the help of overlay sutures. That is what I can think of. Just make a lamellar pocket in the stroma and then stuff in tenons or even sclera, or like you showed, but or even you can use a drape sheet also. That has also been told. And of course, if you don't have cyanoacrylate glue, you said, then you can use tenons, I guess, and then put overlay sutures.
Right, right.
Has anybody tried the standard craft Fevikwik?
Yeah.
I've
want
seen
to ask that only. Yes.
referred patients who've been managed pretty well for that emergency.
Yes.
It's Fevikwik. Only thing is, I think it's pretty exothermic.
Yes, but the content is same only.
Saves stitches, and it saves you from a major.
Fevikwik is more or less same as cyanoacrylate. So
Yes.
the medical grade is the cyanoacrylate.
Yes.
Yes.
So that is something, if you don't have glue and you really have a dire emergency, I'm sure you can always try a Fevikwik with all its dire consequences.
Right, sir,
but
right.
Saves you a tricky situation.
Right, sir.
Yeah.
Thank you, sir.
Dr. Shilpa, please
Yeah, I
continue.
think Dr. Shilpa is right.
I don't think you're able to see the PPT. I don't know what is happening.
No, you've got to just tap on the PPT.
PowerPoint.
Yeah, you proceed to the next slide, Shilpa. It's seen.
Or can I share, ma'am? If you have not made changes, then I'll share from my side.
Yeah, sure, please.
No, actually, we could see your screen. You just had to go to full screen and the next slide.
Okay, try that.
I'd request all speakers to be ready with their presentation open on the first slide.
There it is.
Very clear, ma'am.
Perfect. It's very good.
Is it visible now?
Yes.
Yes.
Yeah. So good afternoon and thank you POS for this opportunity. Thank you Dr. Sangeeta Wagh madam and Dr. Yogesh for coordinating the webinar. My topic is cataract surgery in corneal pathologies. The various corneal pathologies which may come across, which may have cataract, are the corneal scars post-infectious or post-trauma. Then fuchs endothelial dystrophy, of course, one of the important ones. Post-refractive surgery, post-graft scenarios or post-keratoplasty scenarios, and various other things in which the corneal visibility is hampered because of ocular surface diseases or autoimmune conditions like rheumatoid, etc. So the big question here is whether we do the cataract surgery alone or we do combine it with corneal transplant in the form of PK, DALK or DSEC. That would depend upon the type and the location of the opacity, surgeon factors, availability of donor tissue and visual requirement of the patient. So this is a nice algorithm given by the AIMS group of people in which cataract surgery alone would suffice in small opacities, partly or fully covering the visual axis, where it can be supplemented with optical BI if needed. Or combined procedures may be needed if there is greater depth of involvement or more extent of the cornea is involved, where it may be combined with anterior or posterior lamellar or full thickness PK. Now, IOL power calculation in this situation is a tricky thing. If the central 3 to 5 millimeter zone is clear, then manual keratometry can be used. But most of these patients, they have irregular cornea and poor tear film. So computerized VKG or topography is advised. And rather than Placido-based, Placido-based, the Pentacam or the OpScan is advised. If we are using pentacam, then using the EKR readings in the central 3 to 5 millimeter zone is often helpful for IOL power calculation. If nothing of this works, then it's a matter of, I guess, educated guess, where you use the standard 43 to 44 diopter K reading or the other eye K reading. Or in post-keratoplasty scenario, it is advisable to do the complete suture removal and to have a stable topography for 6 to 8 weeks before we plan the patient, take up the patient for cataract. Axial length measurement of an IOL master is not possible, so it is by vector B scan or immersion scan. Axial length measurements, they have better reproducibility than the keratometry. And the choice of the IOL power formula doesn't really matter, whether it's SRK2, T, or even holiday formula. It is not shown to affect the final IOL power prediction. And some people do use this age-old method of intraoperative retinoscopy after removal of the cataract to doubly be sure of the IOL power. So this is a video of phaco done in a hard cataract with a corneal scar. The choice of the incision can be superior or temporal, with the thought in mind that at least half of the cornea should be clear for your subsequent maneuvers. Lubricating the surface with a viscoelastic, it improves the visibility to a large extent, and some people refine a contact lens and fill it with visco and keep it on the cornea, which helps in the visibility. Trypan blue staining of the capsule is mandatory. Use of BSS is recommended. While we are doing Rexis, it's advisable to start in the quadrant opposite to the corneal opacity, so that the Rexis can be completed usually in 1 year. Then choice of viscoelastic, either people like to use the dispersive one, which coat the endothelium nicely, or a combination of cohesive and dispersive one in a soft shell technique. And what is most important is the nucleus management. So basically, whichever method we are using for dealing with the nucleus, either it's divide and conquer or phaco chop. In the bag, maneuvering is very important. It's important to avoid the shattering of the fragments. Also important to use as minimal energy as possible, minimize the ins and outs. And another important tip is, while as soon as we chop, it is better to eat the piece so that the glow keeps on improving and we are able to actually see what we are doing in such cases. And as far as the choice of the IOL goes, monofocal IOLs are recommended in these situations. And coming to cataract surgery in patients of rheumatoid arthritis, about 25 to 30% of the patients will have ocular manifestations, the commonest one being the dry eye. Others can present with scleritis, episcleritis, or corneal melts, or PUKs. And the medical management absolutely has to be done. Patients need to be on systemic agents or DHs before we take them up for cataract surgery. Otherwise, there can be some very disastrous complications. So generally, this is the pyramid that is followed by the rheumatologist. Steroids or NSAIDs are started as the short-term or bridge therapy, followed by the DMARDs, which can be predictional or which can be the biological agents. Corneal involvement can be in two forms. Either it can be sterile corneal melts in non-inflamed eyes with quiescent disease, in which the tear film deficiency is the cause, or it can present as a PUK in an inflamed eye and in active phase of the disease. So it's also, we should keep in mind that this may indicate systemic vasculitis, which can be life-threatening. So very aggressive treatment of the systemic as well as local condition is needed. This patient, for example, after 3 weeks of cataract surgery, she came with a peripheral corneal melt like this. She gave a vague history of arthritis. She was not on any treatment. So we did the glue BCL, started oral and topical steroids, and referred the patient for rheumatology opinion, where the DMARDs were started. And following few weeks of that, it resulted in nice corneal scarring and salvaging the eye. So when we are referring the patient for rheumatology consultation, two important points to be kept in mind are exactly what are the ocular findings that should be told to the person, and how sight threatening or vision threatening is the condition should also be known. Because in aggressive forms of the disease with vision threatening conditions, the rheumatologist would like to give IV methylprednisolone or even IV cyclophosphamide to control the disease systemically. So as far as the ocular management goes, stabilization of the surface before we take up the patients for cataract, by all of these things should be done. Punctal plugs are really helpful in stabilizing the surface and improving the tear film to some extent. So they can be temporary ones or the permanent ones. Tarsorrhaphy is recommended, especially in one-eyed patients. And if they present with a peripheral small melt, as discussed earlier, with a glue BCL, they can be managed, or sometimes they may present with large melts, in which case a patch graft or even a full tectonic keratoplasty might be needed. White cornea on day one. I think Dr. Yogesh is going to speak about this. Sometimes we come across this nightmare of unforgiving cornea, and cause sometimes is the missed Fuchs dystrophy. So especially if the patient is not symptomatic in the early stage and there is only presence of endothelial guttae, if meticulous examination has not been done, this thing can be easily missed. So needless to say, before posting the patient's a very basic techniques of slit lamp examination like specular reflection and also retroillumination in with a dilated fundus should be done to assess the status of the endothelium. And of course, specular microscopy is an important investigation tool in these cases, where it can give idea about the qualitative as well as the quantitative condition of the cornea or the endothelium. These are the high risk factors given by American Academy for post-operative.
To interrupt, we're almost nearing 8 minutes.
Okay. I will just run through the slides. That specular microscopy is not only recommended in Fuchs, but in all these other conditions with poor endothelial reserves. The technique of cataract surgery is more or less same, taking precaution of the endothelium. And we should keep in mind that although the intermediate term outcome may be good in such cases with low risk of decompensation, long-term outcome may not be that good with corneal decompensation happening a few years down the line, which needs a graft. HSV keratitis, the only difference from the other types of infectious keratitis or infectious keratitis scars is that there can be a reactivation in the post-operative period, which needs to be dealt with, first needs to be identified. So any undue inflammation, then you should be suspecting the recurrence and starting the appropriate acyclovir and intensive topical steroids. And just a word on the cataract surgery in post-graft patients, post-therapeutic or post-tectonic PK, the development of cataracts is often fast, and with multiple comorbidities like PAS present, poor view, hard cataract or non-dilating pupil. Surgically, these become challenging. Again, the aim is to minimize the trauma to the graft and to the endothelium as much as possible. And we must keep in mind that graft rejection is a very much a possibility which sooner or later will happen. And that has to be dealt with steroids. So with that, I come to the end of this presentation. I hope I have not exceeded my time too much. And thank you very much for the patient listening.
Dr. Bhatt, Dr. Sambre, any comments on the presentation?
Yes, thanks, Shilpa. Yeah, sorry. Go on, ma'am.
The only thing I wanted to point out is, if I'm operating on a patient with a corneal opacity or not a very healthy cornea, I often switch off the room lights, the OT lights, and use just the microscope. And with your forceps, before you start, you try and see which is your best view. Obviously, when you're trenching, you want an inferior quadrant, as in relation to the position of the tunnel, the clearest. So sometimes you might opt for a temporal, superiotemporal, or inferotemporal. And I also don't hesitate to use the light pipe. If I have problems, I would also stain the capsule a little longer than normal just to help the visualization. I'm not very good with SICS, but otherwise, for those who are adept with SICS, that might be in fact, the surgery of choice.
Yes, I was going to ask about the endo illuminator because they say if there is corneal opacity, the endo illuminator gives a really good view. I haven't used it myself, but maybe someone has experience of using it.
Oh, yeah, I use it whenever I'm struggling. I'll first switch off the OT lights. If I can't visualize, you put on the light pipe or the endo illuminator.
Thank you, ma'am. Thank you.
I think we can move on to the next talk. It's just that we have to accommodate all 7 talks in a short while.
Yogesh.
That was excellent, Shilpa.
Thank you. Thank you.
Good afternoon, everyone. I'll be speaking on a topic which no surgeon wants to dream about it. Before coming to the topic, this is like our routine operative day, having ideal case for the topical phaco. Obviously, these type of cases are rare in COVID times. I hope most of the surgeons are getting complicated cataracts during these days. I'm a left-handed surgeon, so that's why my incision is superionasal in right eye. The case went as per the plan, good rhexis, perfect chop, and at the end well-centered IOL. But the next day, sometimes we see this type of cornea having diffuse striate keratopathy, and patient has like a big question mark on his face, and you are in a state of shock that case was perfect. I've done everything all right, but still this cornea is like this and you are clueless. Obviously, first question is what to tell patients, and then you start retrospectively what went wrong. So these are the various risk factors which can lead to post-cataract surgery corneal edema, and these factors were beautifully described by Sharma et al. In their article which was published in 2017 in IJO. The highlighted ones are the intraoperative risk factors which can lead to corneal edema, like instrument touch or toxicity caused by the irrigating solutions or intracameral drugs, excessive use of phacopower while handling hard cataracts, and lastly, descemet membrane detachment. Keeping these factors in mind, I am showing a small video of descemet membrane detachment management. So this was an elderly lady referred to us for the management by the primary surgeon, who informed us that DMD was noted while inserting IOL, and before closure of the case, the full chamber air bubble was kept. For initially post-op days, for 3-4 days, cornea was clearer, but on 5th day, it was started again getting edema. Unfortunately, I don't have preoperative anti-segment OCT images, but we do have intra anti-segment OCT. So if you see, this is a planar DMD present in upper half of cornea involving pupillary zone. This is a surgeon's view and this is slit lamp view. So it's covering almost upper half of cornea. So side port was made 90 degree away from the DMD just to not damage detached DM. The stab incision was given to perform inferior PI to avoid pupillary blocks. So this was case come to us around after 20 days of surgery. So I have planned to inject non-expansile SF6. Small air bubble was injected just to assess the opposition between the two layers, and then full chamber was gas was injected. Since this was like 20-day old, I have preferred to give venting incisions in avoiding pupillary zone after removal of epithelium. It helps in dehydration. So I have waited for 15 minutes after injecting full chamber gas, and then again intra OCT performed. We see the DMD was very well opposed and cornea started clearing. Before ending surgery, 80% gas was maintained by doing air fluid exchange. She presented to us with a 2/60 vision, and on day 3 her vision improved to 612 with a small gas present into the. So these are the factors which can lead to testament membrane detachments. If we use blunt instruments, then intraoperatively there is a chance of instrument touch, then while inserting IOL like in this case, and then hydration of corneal wounds. If we inject BSS more posterior into the wound, then there is a high chance of getting DM detachment. So we have to keep all these factors in mind to prevent getting DMD, and obviously prevention is always better than cure. Even after that, if we take all these precautions, DMD doesn't get settled and cornea gets decompensated, we are the corneal surgeons are here to help you out by performing endothelial keratoplasty. Thank you for your kind attention.
Dr. Yogesh, thank you. You compensated for the extra time. Thank you so much. That was a crisp and short talk.
Thank you, sir. Thank you, sir.
Panelists, please. Any questions for him?
Yeah, so a word of caution to all corneal surgeons. There are some of the guidelines to prevent or avoid the occurrence of a DMD. I think, especially when you are hydrating the wounds, the side ports and the main tunnels, one needs to be very careful, especially elderly patients. And guidelines like if you have a very broad arcus, again, you know that the descendants is likely to be loose. So one needs to be careful. You also need to keep in mind issues like TAS. On day 1, if you have a white cornea, I'll just relate 2 incidents that happened right at the beginning of my practice. I had a hypermature white cataract, which used to be a surgeon's treat for doing an ECC IOL. And I remember I didn't have a scan, so I'd taken the patient to Dr. Pandit, madam. And she did the biometry and she said, "Oh, masta cataract hai, kai sopa jail," and all. And I operated like I was really pleased with the surgery, and we used to keep the patient overnight, and I opened the patch, and the next day the cornea looked like a sclera, and I thought I was going to faint and collapse. And at that point, I was sheer panic. I stopped eating. I was crying. My in-laws didn't know what was happening. And that's when my late husband, Dr. Sandeep, was in Arvind. And I thought that's the end of the practice. I'm not going to be able to practice anymore. But then I took courage and I took care of the patient as if he was my relative. I kept him staying with us for a week, fed him everything. And I was just keeping my fingers crossed that the cornea would clear. He did clear over next 2 to 3 months and reached about 618 vision, but he rapidly decompensated. But in those 3-4 months, what I did is I called up all my seniors, Dr. Haldipurkar, Dr. Rajesh Pawar, whoever was there. And then it seemed that there was a spate of TAS or corneal decompensation all over the state. And the first thing Dr. Haldipurkar asked me is, "How many surgeries did you do that day?" I said, "I've just started. I had only one." He said, "Well, my whole list went." So it was one of the irrigating fluids. I won't name the company. there was some mess up either in the pH or one of the components, and there was a huge number of cases of corneal decompensation. So that was one. And a second time was when I was operating at Ruby Hall. I think we just happened to avert this. Right next to our OT was the cardiac OT. And I always prepare the irrigating fluids myself. So I went to add the Genta adrenaline, and we used to use glass bottles. And as I held the bottle, I realized it was warm. And then I said to the sister, how come this is warm instead of chilled? She said, oh, वो cardiac nurse ने शायद microwave में गर्म करने को रखा. And, you know, I'm just so thankful I touched the bottle, because I can't imagine what would have happened to the cornea. So one has to be very watchful of all the components that we use. Like I use the least intracameral agents possible. Like I know moxifloxacin intracameral has been promoted, but I just keep my fingers crossed. And even post-op povidone iodine is something I try to avoid, and make sure all the ports are watertight, not just with a bud, but even with a Vexel. And in case of any doubt, I don't hesitate to put in a suture. So these are just my 2 pieces of advice and caution to everybody.
May I add something? So usually, fortunately, I don't know, it's God's grace or what, but corneal surgeons generally don't tend to have these kind of problems. They are usually getting referred patients, operated one eye, and they come with corneal edema post cataract. And then you look at the other contralateral eye, which is yet to be operated. And a lot of surgeons, anterior segment surgeons, tend to miss pukes. That's the commonest what I've noticed. And second thing that I've noticed, like what Dr. Bach said, the cardiac OT sister, this. So when you're operating in this is what I've noticed in multi-specialty hospitals, not in private ophthal centers, but in multi-specialty centers. I've had 3 patients referred from a multi-specialty hospital by a cataract surgeon. It happened thrice, and the sister by mistake gave methylene blue instead of trypin blue. So I've had this experience like a TAS, day 1, completely blown out cornea. And when the surgeon went back, what was it? Then he realized that it was methylene blue instead of trypan blue. They use methylene blue in multi-specialty OTs to mark skin while operating general surgery patients. So these things have happened quite commonly. And in the recent times, I'm not even saying way back, this is 2018, 19, 20 maybe. 19, I think, yes. So multi-specialty hospital operating surgeons should be a little bit having a checklist of their own, even if they know their sister has been working with them. It's mandatory that they have a small checklist that all the things that are on table are ophthal purpose and nothing else.
So I just had 2 more things to add, because I think this might be a benefit to everybody here. First thing is, don't panic if the cornea looks terrible day 1. The endothelium has a ability to recoup, and I would say a waiting time of 4 to 6 weeks is what one needs to give. Don't panic yourself, reassure the patient. And if the damage is not too much, it's very likely this endothelium will recover and the cornea is likely to improve. The second thing is, remember to check the intraocular pressure. Day 1, sometimes if you have a leaky wound, hypotony will give you very gross folds and a swollen cornea. I mean, it's happened to me as well. And my dictum is, if the cornea continues to stay edematous beyond day 8, then you need to take a look. Don't hesitate to do an OCT, because there might be a Descemet's separation which is there. And we know that in case of extensive corneal edema, sometimes you may get a spontaneous Descemet's detachment, which is not iatrogenic, but because of the pathology of the corneal edema. Again, just putting perhaps just a simple air bubble, not even an expandable gas, would help. In fact, an expandable gas, one needs to be very careful not to induce a pupillary block. So these are the 2 things. And if the patient doesn't improve by say 6th or 8th week, then you're looking at a decompensation and an early referral. And always include an expert opinion in the first 2 to 3 weeks, so that you're safeguarded, and the patient can't say that you didn't refer me in time for a specialist opinion.
Any role of rho kinase inhibitors?
Oh yes, so I have been using the locally available Ripatech for a lot of patients who, most of the patients I started out for are those who have been referred for corneal transplantation, EK or endothelial keratoplasty. And I would say at least 30 to 40% of my patients have stabilized on the Rho kinase inhibitors. Now, it's very hard to predict which one of them will and which one will not, but it's definitely worth a trial. And I'm encouraged to say that we can even try to start these drops in the early postoperative period. The only side effects that I've had patients coming in with is a lot of congestion and just a few of them with a bad contact dermatitis. So it's a very good drug to try, and there's absolutely no harm in starting it right in the beginning. The use of hypersol is plus minus. What it does is it prevents the epithelium from breaking down. Because if you have bully on the cornea and they do open up, then you're looking at the possibility of an infection. So in that instance, it helps to keep the cornea, at least the epithelium, in place. Don't hesitate to put a bandage contact lens, because again, you're preventing the epithelium from breaking down. A breakdown in the epithelium is going to make it increase the risk of infection, and the last thing you want is a corneal infiltrate in an edematous cornea.
Thank you. Thank you so much.
I agree with you, ma'am. I mean, very important point. I had an opportunity to use Rho kinase in one of the patients who was referred, who had injury to the endothelium due to the phacoprobe, and she really responded very well to the Rho kinase inhibitor. One point.
For how long we have to give the Rho kinase inhibitor?
I gave it for 8 weeks.
Okay.
Yeah, they recommend 8 to 12 weeks is what I said.
One point which I would like to stress is when one suspects Decimet's detachment on table, sometimes you can see that something is going wrong and you suspect the detachment. Please do not use any viscoelastic, because that would prevent adhesion of the Decimet's membrane. Just try to put air bubble in the place where there is no detachment, so that the air bubble rises up and reattaches the Decimet's membrane to the cornea.
Thank you, ma'am. Thank you for your input.
So the Rho kinase is recommended twice to 4 times a day. Dr. Savita has asked on the chat.
Can we have the next speaker ready for this talk, Dr. Radkar?
Yes.
Yeah.
So, hello all. I would like to. Am I audible?
Yes, yes.
Yes,
you are. Yes.
Yes.
Yes. Okay.
Just
I would
put
like to
power
thank
on, yeah.
POS and the Cornea colleagues for this opportunity. No financial interest. So I'll start with my topic. Why does the same eye get hurt every now and then? So this was a patient who had come with a young male, left eye sudden onset pain and watering with repeated episodes in the past, and had visited several ophthalmologists for the same issue.
Sorry to interrupt, Dr. Radkar. Just
Yes.
to put it PowerPoint presentation. Yeah. You have to put on the presentation mode. Yeah, yeah. Good. Yeah, fine.
So he had some history of some trivial trauma 1 or 2 years back, which he didn't remember, and actually told when I asked him. No other ocular complaints in the past and no systemic illness. His vision was fine and fundus was normal. So on examination, the areas were around the 7 and 9 o'clock hours, just paracentral to it. There were loose epithelium and irregularities in the epithelium. There was some mild congestion. Otherwise, the anterior segment was normal. So going by the history and the examination, there was sudden pain, there's loose epithelium, past trauma, and recurrent episodes. I made a diagnosis of recurrent corneal erosion. I started him on treatment of lubricants 4 times a day, eye ointment at night, and antibiotic eye drops around 3 times a day. So the first follow-up, third day, the epithelium was healing, but the symptoms were same. On the 7th day, the epithelium had healed itself, but the patient was also much better. And by the time the second week, the complete healing had taken place, and the patient was completely asymptomatic. So great, I was actually happy with it. Second week itself, the RC is gone, but then it only stayed for another 2 weeks where the bomb of recurrence occurred. With this failure in mind and a little bit of preparation, I went ahead with actually advising the patient for soft contact lenses and hypertonic sodium chloride solution after the epithelium had healed. The patient was coming for almost follow-up every 3 days, and finally the epithelium did heal and contact lens was removed post 2 weeks. The healing did stabilize for the next 4 weeks. Also, after 2 months of contact removal, for the last follow-up which he had, epithelium had healed well and there was absolutely no complaints. And since there was COVID, the patient did not come for follow-up for the next 2 months. But then we did have a talk with telephonically the staff with the staff, and the patient said he was not doing fine. So I guess I did okay. The RC was settled there. So coming down to the RC, recurrent corneal erosion basically happens because of the inadequate epithelial basement membrane adhesions. And typically in the fourth or the fifth decade. The two most common causes which need our attention is the trauma, which happens almost 45 to 64%, and the dystrophies, which are around 10 to 15%. The other important thing which considers is the past history of a surgery. There are degenerations, MGD, dry eyes, diabetes, and ocular rosacea. Now, the classical nocturnal correlation with the RC is that due to the dehydration of the tear film, there is an adhesion of the tarsal conjunctiva to the epithelium, which gets evulsed in the morning. And also a classical picture of EBMD, the negative staining should be looked for. The corneal sweep test designed by Dr. Brian King can also be used for the diagnosis of RCE. After a topical anesthesia has been applied, you can use a blunt instrument to glide from the peripheral cornea towards the center in all the 360 degrees. As you would understand that on manipulation, the loose epithelium will glide and move on. If you have a facility of ASOCT, it will also give you some epithelial changes and hyperreflectivity thickening from basement membrane complex. So now decision making in a case of an RCG, the first thing is for the correct diagnosis. Second would be to correctly identify the area affected because the treatment kind of depends on it. Selection of the proper treatment, also a proper follow-up, and maybe you have to modify the treatment if there is any recurrence. So the treatment can be majorly surgical or medical. Most of the cases will be managed medically. Very few will require probably surgical correction. You do have to think about the acute attack where primarily medical and surgical will be used, and the prophylaxis will stay on with medical treatment. Also, the identification, as I already told you, whether it is a central area involvement or a peripheral environment. So medical treatment majorly relies upon the preservative-free lubricating eye drops, antibiotic eye drops, nighttime lubricating eye drops, hypersaline ointments. The pain relief can happen with cycloplegic eye drops or oral analgesics and soft bandage contact lenses. Coming to the surgical, we primarily use it when there is a failed medical treatment. There are many options available with us. The anterior stromal puncture, epithelial debridement, alcohol delamination, diamond bar polishing, and photorefractive keratectomy. If the RC involves an off-axis, off-visual axis area, you can think of getting an anterior stromal puncture, or if there is involvement of a visual axis, then probably photorefractive keratectomy, diamond blur, and epithelial debridement can be used. Thank you very much.
Thank you, Dr. Prakash. Ma'am, any inputs on the topic, ma'am?
So the few tips which I do use is, the patient may have forgotten the history of trauma, and it almost always wakes them up in the morning. So I would extend the treatment for medical treatment up to 6 months. And what I suggest to the patient is, in the morning when they're waking up, just keep that eye closed, keep a bottle of artificial tears at hand, and mechanically or manually open the eye and put in the drop, lubricate the eye and open it. And this very often will help to reduce the incidence or frequency of the breakdown. The other thing is, one must keep in mind the possibility of differential. Dr. Pranav has mentioned the occurrence of EBMDs, but I'll just relate this incident of a small child who was brought to me, and he would have a painful eye, and I would stain and find an erosion. We'd patch him, he'd heal up, and few days later he would come again and the erosion would be at some other point. So it's very important to map diagrammatically the area of the breakdown. And for a recurrent corneal erosion, it must always be the same spot. Otherwise, you're looking at some other etiology. Eventually, I took this child in the OT under sedation, and we everted the upper eyelid, and there were a whole lot of caterpillar hairs. So what I had missed was that there was some physical reason for this breakdown. And that's why mapping that area of breakdown is important for two reasons: the area that you're going to treat, and also to conclude that it is a recurrent erosion in the very same spot.
Is there any role for
Dr.
steroids
Samir?
in recurrent corneal erosion?
In fact, I would prefer to avoid it because you don't want a secondary infection to take place. Unless there is a ocular surface disorder, like a patient of dry eye with a recurrent erosion, then you would use a very low dose steroid just to tide over till the immunosuppressive like cyclosporin working. Samir, would you have anything to say?
I have been doing alcohol delamination for recurrent corneal erosion. It's a very cost-effective method. Very nice results that we are getting, because PTK sometimes can be expensive. Diamond burr pollution can be expensive, but alcohol, I've been doing it for now past 8 to 10 years. So it's really helpful. I think it's a good way.
So can you just explain the steps? I mean, how does one dilute the alcohol? What do you do? Do you put a bandage lens? Just in brief, just for
70
everybody.
to 20% of dilution of absolute alcohol. Meaning you take 0.2 cc in a tuberculin syringe and rest of it is normal saline. You soak the cotton bud with it, or you take a small little sponge piece, circular, and then the area of the recurrent erosion is properly soaked. The epithelium will easily get debrided. The idea is, the problem is where the epithelium attaches to the stroma. That area is filled with debris, and that is the reason why the epithelium is not attaching. So if you clear that with alcohol, or even PTK does the same thing, and then just put a bandage contact lens for at least 10 to 15 days minimum, and then put him on antibiotics. At times I do use steroids if the patient is having good follow-up, and just look for no infiltrate in that area. That serves very nice.
And of course, if we do a PTK, one needs to give the post-op steroids.
Yeah.
So definitely.
Maybe sometime in the future we would have the Bowman's membrane transplants.
So I think we are running short of time, so we'll call the next one now.
Dr. Sujna, over to you.
Yeah, am I audible?
Yes, yes.
Yes.
Let me first share my PPT. Yeah, greetings from Armed Forces Medical College. Good afternoon, esteemed panelists and audience. So from corneal erosions, let me take you to another end of the spectrum, and I'm going to present you a case of eye syndrome with corneal decompensation and my efforts to break it. So briefly, eye syndrome, we all are aware, it's a unilateral ocular condition, sporadic in nature, typically seen in adults, more in females. Basic pathology being abnormalities of corneal endothelium, which starts proliferating and causes obliteration of the angle and causes iris anomalies, and all causing secondary glaucoma as well as corneal decompensation. Now, eye syndrome has got these three clinical entities. So we had a case of 52-year-old lady who was fitting into the first entity, and that is essential iris atrophy. So she presented to us with a progressive diminution of vision since 17 with episodes of pain, redness, and photophobia. On evaluation, BCVA was found to be counting fingers close to face, and cornea showed a lot of microcystic and stromal edema with few bullae. With a corneal thickness of 640 to 760 microns on ASOCT. Anterior chamber was shallow, especially nasally, where iris was adherent to the periphery, to the cornea in the periphery from 6 to 9 o'clock position. And there was chorectopia and ectropia and uvea. Nuclear sclerosis of grade 1 was seen in the lens. And with this clinical picture, we planned for a DSEC triple procedure. ILPAR was calculated with the other eye keratometry readings, and we kept a residual refraction of minus 0.75 diopters. So we started with this manual dissection of donor cornea. A decent endothelial count of 2100 we could get. It was mounted on artificial anterior chamber, center and periphery marked, and periphery incision given with a fixed depth blade. And then dissection was started in the posterior stroma, initially with straight lamellar dissectors. Thereafter, it was completed with curved lamellar dissector, ensuring complete dissection of the donor cornea. Thereafter, as usual, it is mounted on Teflon block. And 8 millimeter corneal trephine was used. We found a Y to Y diameter of 11 millimeters in the host cornea. So in the end, we could get a decent donor lenticule thickness of about 160 microns, which was measured on day 1 post-op on ASOCT. Shifting to the host cornea, after debridement of the edematous epithelium, we could get a good visualization and good retro. Initially, after forming with Vislon, I did do the anterior syneculisis, especially in the nasal quadrants, and thereafter capsule was stained and capsular excess and a normal phacoemulsification was done. Initial nucleus was removed. Thereafter, a good cortical cleanup I tried to do. And implantation of foldable intraocular lens was done in the capsular bag. Thereafter, AC was formed with Helon, and we started with the decimeter rexus with the reverse Sinski hook under Helon. Now, despite the initial synoviculitis, I found this descemet membrane to be really attached, especially in the nasal quadrants. And while removing it, I could see the adhesions even at the temporal quadrants. So that's the basic pathology of eye syndrome. So you could see those adhesions with the descemet membrane. So once those were removed and Helon was nicely cleaned from the AC, and thereafter, donor lenticule was loaded onto the Busen glide, engaged into the phaco slightly enlarged. And then donor lenticule was brought into the AC with ILM forceps, and the apposition was of donor lenticule was ensured with intracameral air, and all the ports were nicely secured. This is the day 1 post-op with a small air bubble still remaining. And at 2 months post-op, she had a visual acuity of 6/9 unaided, and ASOCT revealed a donor lenticule thickness of 138 microns and host of 465 microns. So this was how we managed, and like to discuss some challenges. Technical, what were the technical challenges? Anterior synechiae, of course, shallow anterior chamber. Now PI to do or not to do, in this case, we got away by not doing it. And graft position in the presence of iris abnormalities, I placed the graft exactly in the center. Fortunately, till now the correctopia is only such that the graft is exactly opposite the pupillary area. Now, graft dislocation requiring rebubbling, it was not encountered in our case, although there was reported incidences of 22% rebubbling rates in these cases. The other challenges being rise in IOP. Apart from that initial rise because of the air bubble and all, which was managed with Dimox, this the IOP started slowly rising at about 3 months post-op, and presently it is being controlled with 3 drugs. Rejection episode we did not see, at least till now. Corneal clarity and visual acuity and an endothelial count of about 1400 is being maintained at the end of our 15 months follow-up. So to conclude, EK offers rapid visual recovery with minimal refractive changes, especially in this case of eye syndrome with corneal decompensation. However, close follow-up for secondary glaucoma is very important for both optic nerve function as well as endothelial cells, as secondary graft failure is found to be the most common cause of DSEC failure in these cases. So I finish. Thank you all, and thank you, POS and Dr. Yogesh, for giving me this opportunity. I'm happy to take any queries, suggestions from seniors as well as colleagues in managing this case.
I think that was an excellent demonstration of, a very skilled surgery in a complicated situation. And the only few questions I had to Dr. Srijana is a couple of patients of eyes that I have treated in my own practice. Glaucoma is a common association, right? So one needs to keep that in mind. And, in case of any doubt, I would even go ahead with a trabeculectomy with a syneculizer primary surgery and then followed up with DSEC. The age-old teaching used to be that a full thickness corneal transplant might be more would survive more than an endothelial graft, but there are mixed reports, and we need to have more data on this to know which of the two grafts would have a longer survival.
Absolutely.
But any inputs from anybody, the speakers, panelists?
I have a doubt. So in eye syndrome, usually they come back with synechiae after some time.
Absolutely.
And then the graft fails. So does it make sense to do pupilloplasty or put the so that the iris will stay in place? Does it really help?
Dr. Suchi, the problem here is abnormality in the corneal endothelium. Like at 15 months, again, anti-cyanic have started forming. So even if you do a pupilloplasty, the basic pathology remains and it starts proliferating, whatever remaining cells which have obliterated the angle and all. So this is what is my experience. At 15 months, I could see those cyanic just coming. Presently, it has stopped short of the donor lenticle edge.
Surjana, would you think of sizing the graft smaller than usual in ICE syndrome?
Yes, we have to keep a balance between both your donor endothelial count as well as whether it's going to touch or go towards the angle. So keeping that in mind, I kept to the basic teaching of about reducing it by about 3 millimeters from your wide to wide. Because in these cases, secondary graft failure due to endothelial cell loss over a period of time is bound to be the cause of DSEC failure. So I thought there should be a balance between the two.
So all said and done, it seemed to be a very nice session. Thanks to all the speakers, panelists, chairman, co-chairman. I think we have exceeded the time by some extent. So I thank POS and all the panelists and speakers for the same. Thank you. Over to you, Rajita.
Thank
you all. It was an excellent session. Very good practical tips. So Dr. Sangeeta Madam, Dr. Chitra Ma'am, everybody, thank you very much. And all the faculty.
Thank you. Thank you.
Yeah. So now we are going to start the most attractive session, women in ophthalmology. So I request all men also to stay to listen to women. At least today you should listen to what women are saying. So I request Dr. Devdar Madam to chair the session, Dr. Bagli Madam to co-chair the session, and moderators are Dr. Pranjali, Dr. Rujuta. Are you there?
Yes,
you can start.
Welcome everyone. Let's have a blast. Well-deserved entertainment.
Can you hear me? Yes. Okay. नमस्कार श्रोते हो. आतापर्यंत आपण खूप छान शैक्षणिक प्रोग्राम पाहिला 2 दिवस. आता थोडासा हटके प्रोग्राम, सगळ्यात शेवटचा आणि एकदम आगळा वेगळा असा एक बघूया. थोडा मनाला बुद्धीला चालना देणारा, थोडासा मनाला विरंगुळा देणारा आणि काहीसा थोडा वेगळा विचार करायला लावणारा असा हा प्रोग्राम. सो वेलकम टू द सेशन ऑफ विमेन इन ऑफ्थॅल्मॉलॉजी. I invite the chairman, Dr. Vaijayanti Devdar Madam, and co-chairman, Dr. Meenakshi Bagli Madam. Dr. Pranjali, please.
Yes, thank you, Dr. Rujuta. Welcome all the faculties and all the beautiful ladies out there. Let's enjoy this session. I would like to introduce all the faculties for this session. Next, please. Dr. Rujuta Matswe, our own Joint Secretary, POS 2020-2021. She's Director of Matswe Hospital and Consulting Ophthalmologist at Dr. Tarabai Limio Hospital and Atharva Netralaya. Next, please. Welcome, Dr. Vandana Mani, our beautiful faculty. She's running her own lab named High Tech Pathology. She's working as a private pathologist and she was ex-lecturer in Department of Pathology at BJMC. Welcome, Dr. Tejaswini Prasad Vadimbe ma'am, a very versatile person. She is fellow in glaucoma and medical retina. She's been faculty at state national level conferences, and she has published a book in Marathi that is Pahu Anande on her experience in clinical practice. Then she has participated in many anti-glaucoma drug trials. Ma'am is versatile. I mean to say she's an excellent surgeon. Then she's a poet. She writes and she's a painter too. Dr. Seema Khere, she is our joint treasurer. She's director at KK Hospital. Then she has completed, she has done more than 10,000 eye surgeries. She has taken an initiative by starting a YouTube channel, that is KK Hospital 111, that is to educate common man in eye and other health issues. She has also launched online eye checkup program. She is a very tech-savvy person, I must say. Whatever technical glitches you have, you can contact her anytime, and she is ready with the answers. Then welcome to our own POS President, Dr. Gitanjali Sharma ma'am. She's done her fellowship from Israel, France. Then she has various presentations at national, international level. Then her social work for leprosy patient is also appreciated. And she is not only a poet, a Kathak dancer, writer, and she has started a very unique program, WhatsApp messages, good morning WhatsApp messages, which are very inspirative. She's mother of 2 daughters. Ma'am is a true leader. She's always motivating and inspiring. In this hard COVID time, she has proved that where there is a will, there is not only a way, but there is a wave. Welcome, ma'am. Welcome all the delegates and the faculties. With due permission with due permission, can I start the session?
Yes, sir.
Dr. Meenakshi Bagli, ma'am, Dr. Vaijayanti Devdar, ma'am.
Yes, please go
Yeah,
ahead.
first session, the opening of the session, Dr. Rujuta, she will start with challenges as women ophthalmologists during COVID times.
Is my screen visible?
You can start.
Oh, Rujita, you'll have to upload your PPT.
Is it seen?
No.
No?
Your screen is seen, but not your presentation is getting uploaded. We can see the presentation over there, challenges as women in ophthalm. But what you have to do is first open it, then minimize it, and then do it.
Yeah, I've done that actually. Is it seen now?
No.
No, we can just see your desktop with all those different presentations, but your own presentation is not opening.
I think you can double click on this.
And what she's supposed to do is stop share, open the presentation, minimize, and then start sharing.
Correct. That's what I told. That's what I told. She has to stop share this. Then you open your presentation, minimize it, and then
Start sharing.
Okay.
Yeah, I've already actually minimized it actually.
I hope this is not a problem faced by women in ophthalmology during COVID times. We start with a bang.
Seema, can you help her, please?
Mukesh. Ever reliable Mukesh, where is he?
Let him take some rest during women in ophthalm session.
You have to
He'll
open
come
your
in men and
presentation.
ophthalmology, I think, session.
Rujita, open your presentation.
Help them.
Straight will like Rujita just mail me this thing. I'll run from my side.
Actually, I've mailed it to Mukesh actually for this decision.
Mukesh is resting.
Mukesh has taken a break from women in ophthalmology.
Yes.
He's back. He's back. Mukesh, you have to open the presentation.
Mukesh, the savior.
The savior.
Of title.
Challenges as a woman of
Rujita, you please stop share this.
शुरुआती वुमेन ने ऐसा कर दिया.
Dr. Taswala, you can take a tea break.
अरे मेरे को कमेंट करने दो यार.
Mukesh, man, help them out.
मेरा हो गया टी ब्रेक, खाना भी हो गया.
2 minutes.
Sponsored tea break for Dr. Taswala.
Just give me exactly 2 minutes, sir. Please.
This is at work now.
सुवर्णा भेज रही है चाह.
हाँ भेज दिया. पी लो अभी. ब्रेक ले लो पहले.
वर्चुअल.
हाँ वर्चुअल.
मेल से भेज दिया.
I have written, Mukesh, man, help the woman in ophthalm.
There he is.
Done, sir. Starting now.
Yeah.
Starting, it's done.
Sorry, Dr. Mukesh. Now you'll
No,
have
एक
here.
वो एक patient का phone आ गया था इसलिए हाँ.
No, it's okay. I'm just joking.
Yes, ma'am. Ready.
Yes, Dr. Rujita, please start.
Dedicate this talk to Dr. Mukesh.
Yes.
Thank you so much.
Yeah, next slide, please.
Good one.
So you must be wondering what I am showing on the screen. Is it a kind of a POS entertainment quiz? No, not at all. You can see the common factor in this is eyes. And you all know that the eyes have motivated so many of Bollywood songs and the poets.
Rujita,
It
louder.
forms a very,
I can't hear you properly. Speak louder.
and it forms a very important part of our life. Can you hear me?
Yes.
Yes, please.
Yeah. Next slide, please. So it's a very exciting and inviting career for female ophthalmologist. And I'm going to narrate a story of a enthusiastic young female ophthalmologist who turned out to be a very chaotic and stressed out woman during the pandemic. All thanks to this pandemic guru of COVID, with associated so many kind of jokes in the WhatsApp library like this. Next slide, please. Thank you, Dr. Gitanjali and Dr. Mukesh and POS team for giving me this opportunity to open my mind in front of this august audience. The challenges a woman ophthalmologist is facing in COVID era. If I have to describe this in just one sentence, you can say kabhi naram naram, kabhi garam garam. Next. 2020 started with a bang, a new era in ophthalmology with tremendous advances, so that we thought that the dream of Vision 2020 would really come true. But alas, it shifted to the new era of COVID-19 pandemic and the whole chaos started. Next slide, please. So a conflict between a woman, a doctor, and an ophthalmologist started, which thought would never end. The first responsibility started with the house chores. As if I really, like this picture, I thought I would have had at least 4 to 8 hands to do all the house chores. Being in a joint family, there was a lot of work which was just brushed off to the maid so many times, and the whole responsibility came to us. What to do, how to manage. More than a physical stress, there was a mental stress of management, how to manage the hospital, and at the same time, how to manage the house chore. The second responsibility was taking care of senior citizens. Senior citizens are very happy taking the morning and evening walks, going to their peers, chit-chatting, having chai at the tapri. And it was really difficult to manage. And their condition was really pathetic. Taking care of them was a mental challenge rather than anything else. And once the lockdown was over, we were relieved, yes, that all the maids are back home. But then a new kind of, challenge started to take care of the maid hygienes. Once I came home to see that 2 maids were chit-chatting very loudly without wearing any mask, without washing hands and doing all sorts of things. And then I realized, no, I need a SOP at home also, the way I had a SOP in my hospital. And as a doctor, as all of us know, there was a scarcity of revenue, 80 to 90% less patients, and at the same time, there was increased expenses due to so many consequent purchases, and nobody knew what thing to buy, which brand to buy, and how many to buy, because there was scarcity of all kind of stocks. Next slide, please. Yeah, in hospital administration, there were so many things to take care of, like what clothes staff has to wear, which kind of mask, because except for the sisters, the receptionist, admin are not, they are not used to wear any kind of mask. So which mask to wear, N95, 3-ply mask or a cotton mask. So many conflicts, so many SOPs kept on changing in my hospital. Then regarding the staff duties, there was a debate. Then staff transport was a real hassle. 2 to 3 times we had to contact police because the spouse of our sisters were bitten, even though they were having authority letter. Then sanitizers, EMIs of the hospital instruments, and checking the stocks was a real chaos, at least for 2 months. Staff counseling, I'm thankful to God that I have got such a great cooperative staff that not much time was needed for staff counseling. The time was needed for counseling of their families, just to reassure them that yes, we would take good care of your family members. And staff training, yes. As I told you, we had so many SOPs regarding staff training, and I used to take a kind of a mock rehearsal for everybody. Ask them questions and ask them to give answers. Because after 2 months, we thought that 2 to 3 months, after 2 to 3 months, the patients would come and pour inside. And that time we had to be really prepared. During patient education and counseling also, I'm really lucky to have good patients who were wearing all sorts of proper masks. But while signing the COVID declaration form, there was a kind of a hassle which we could take care of like properly. During this period, I released a YouTube video regarding eye care in COVID, and you can just go through that YouTube video. As an ophthalmologist, we all know that it was a professional hazard due to close contact, and we could avoid urgent patients like ocular foreign body, sudden loss of vision, intravitreal injection follow. Severe ocular congestion was a problem. There was a very much frightening situation in the patients regarding COVID conjunctivitis. And even with slightest conjunctivitis, they wanted us to see them. And we never knew whether it was conjunctivitis, uveitis, and what, and we had to attend all the patients. And during COVID, I realized that refractive error can be a semi-emergency because the screen timing was increasing so much, 10 hours, 12 hours, sometimes 18 hours. And then it was a real emergency as the optician shops were not open. Then other aspects like tackling internet issues. I shouldn't say anything much about webinar pandemics, we all know. And tech savviness, yes, I'm still struggling. You can see that. Next slide, please. But in all this chaos and stress, there were some blessings in disguise. There were some definite stress busters in my life, like my green corner. There was a joke on WhatsApp that when you're very close to your garden and plants, you start talking to the plants. But if the plants start talking to you, you should consult a psychiatrist. And I thought, now there is a need for me to consult a psychiatrist. But thank God it never happened. Next slide, please. Next slide. Yeah. And as I told you, thanks to Gitanjali for giving me opportunity to draw lots of sketching and painting. After 35 years, I took paintbrushes in my hand, and it was a real fun and a stress buster. A lot of stress, but a lot of percentage of stress buster was because of the sketching and paintings. Thanks to Gitanjali. And yes, then there came LBO Super Dancer Contest, in which I could participate, and I could go up to the finals. And the icing on the cake was that the Terence Lewis was choreographer, was our judge. And my daughter especially was excited so much that Terence could see me dancing and he could appreciate my dance. So it was real fun video shooting with my daughter and all the family members. It was real fun, not just the dancing, but the rest. And then came POS MasterChef. And again, we had a lot of literally chaos in our house during doing shootings, naming the dish and plating the dish properly. So it was like a feel of having a master chef in our house. Next slide, please. So yes, there are some cons as well as pros of this COVID era. But yes, we got a time to revert back and peep inside our minds and to know a new you. And then we realized this, we can do it. Thank you so much.
Very nice, Sujita. You made really good use of your free time, which you got so easily during the lockdown.
Thank you, ma'am.
Dr. Geetanjali, ma'am, would you like to add something?
It was nice talk. It was nice talk, Rujita.
Thank you.
Good, you took the challenge properly. COVID times was a real challenge for women, mostly for the doctors, because we were working in hospital, we were working at home, there were no maids, as you mentioned. Everything we were doing on our own. So,
Can I ask a question?
Yes, you can.
Do you all love your husbands more or maids more?
It's a
We
$1 million
take the fifth
question.
on this. Mukesh, we take the fifth
It's a
on
$1
this.
million question. Yes, we can have
We
a
are not going to
seminar on
answer.
this, right?
We take the fifth on this.
Husband
Top
made is
secret.
accepted.
If the
Depends on
husbands
time,
are contributing equal to the maids, then that's
Yes.
fine.
Okay, during
Then they get enough of it.
We praised you a lot, but we are not
times,
going to answer this question.
Mukesh,
Mukesh,
what does your
Yes.
wife say?
no, just start washing the utensils and you will realize whom the wife loves more.
नहीं यार कोविड टाइम्स में हस्बैंड नॉन कोविड टाइम्स मेड
I agree, sir.
I would just like to share my experience. See, I'm most of the times out of my house and I hardly know anybody staying around me. But during this lockdown time, in the month of, after the 17th of March, at the end of April, I was at home. And that time I came to know my neighbors. And just because knitting is my hobby, I started knitting. My neighbors saw and they all started coming. They said, let's do co-quarantine. Huh? So I said, okay. And then one of my neighbors, she said, I want to learn knitting. And this poor lady, I had to teach her how to hold this needles. I had to teach her how to cast the stitches. Every day she would say, Vaijanti, please, can you help me? And she would do something and I had to rip out everything and teach her over again. So almost for one whole month I did that. And now I think she has become expert.
She's learned now.
She's learned now. So I came to know my neighbors.
Yes.
And
that's a big plus point.
Because the maids were not coming, some of them would say की तू एकटी काय स्वयंपाक करणार आम्ही पाठवतो. So almost every day I used to get some new dish. Somebody would give me idli sambar, somebody would give me nice parothas and so on.
That's what I was going to say, that having good neighbors is really very important, and you learn their importance during these stressful times because they can be really stress busters for you.
Really.
Doctor, let's now go to our guest speaker, Dr. Vandana Mane.
Yes.
Yeah.
Yeah. Welcome, Dr. Vandana Mane.
Yeah, thank you so much.
Dr. Vandana is very famous on Facebook for her saris.
I love the your topic. Sari swag.
She's also my classmate and neighbor in Koregaon Park. And I was really happy to see her here. Welcome, Vandana.
Thank you so much. Can you hear me?
Yes.
Yeah. So we begin our talk today. First of all, I would like to thank Dr. Gitanjali Sharma, who is the president of Pune Ophthalmological Society, for giving me this opportunity to speak on my favorite topic, that is sari. Many of us complain that sari draping takes a lot of time. But if there is a will, there is a way. Why sari? Sari is forever and it suits everybody. The budget can be from few hundreds to few thousands to few lakhs. There is enormous variety in sari, accessory as well as blouse. Blouse can be stylish or depending on the occasion, it can be simple. Sari covers the right amount and it exposes the right amount. And then today we will be dividing our talk in 5 different categories. Saris for daily wear, saris for family wedding, saris for special occasions like birthday parties, baby shower, naming ceremony, etc. Saris for conference and semi-formal saris. So we begin with the first category, saris for daily wear. Many people ask which material is best for daily wear. It depends on the season and taste. But cotton is durable, natural and breathable. So it has become a very popular choice for daily wear saris. All of us are from Pune. So let's begin with Pune cotton saris. Usually the body is plain or with stripes or with checks with contrast border. Now let me clarify one thing. Most of the photographs you see here, I have mismatched the sari and the blouse. Gone are those days where we used to have matching according to the body or according to the border of the sari. So here I have paired with purple khand blouse. Next sari is very soft cotton multicolored sari. Again mix and match blouse. If you see carefully, the blouse which I am wearing today is in this sari. The next third one is Bengal tant with Ganga Jamna border, and next variety is Kota sari. Kota is a variety of cotton in which small checkered pattern is woven in the fabric, making it very easy breezy. So these are the best choice to beat the scorching sun of Rajasthan and Gujarat. Both the saris here are having floral pattern. Again, mix and match blouses. Now we come to our age-old Georgette, very lightweight. The red sari here is very simple, but combined with a mirror work blouse, and this sea green sari with shibori pattern is combined with a crop top. The floral pattern pink sari is combined with a gray blouse and mix and match again. And magenta pink sari with geometrical pattern is draped by my daughter in her college function once. Because it is geometrical pattern, it becomes popular in the youngsters. Now we come to the next category, saris for family wedding. All the heavy saris are chosen here for family wedding. All of us are from Maharashtra. So we begin with pride of Maharashtra, that is Paithani. All of you know that these saris have derived their names Paithani from the town of Paithani, where they were woven in the olden times. Now they are woven even in Nasik or Yavla, etc. It used to be called as Mahavastra because only the ladies from royal families used to drape it. The middle one is my daughter-in-law, who has draped a 9 yards Paithani. The Paithanis can be in 9 yards or 6 yards. So the first one where I am sitting reminds me of the famous Marathi song, Padaravarti Zarataricha Mor Nachara Hava Ai Mala Nesav Shalu Nava. If you can see carefully, this 9 yard Paithani, pink Paithani in the center has small bird motifs in the border all over, even in the palla. So it is called as Raghu Paithani. The last one you can't see clearly. It is parrot green Paithani, 6 yards, and because of the color, it is known as Raghu Paithani. Now, the exquisite silk saris are Kanjivaram silk saris or Kanchipuram Pattu. It has derived its name from the town of Kanchipuram, where they are woven. It is at a distance of 1 hour from Chennai. Pattu in South India means silk. There are various types again. First one is the brocade Kanjivaram. One in the middle is floral pattern Kanjivaram. Next variety, the subtle elegance of North, that is Banarasi saris. Again derived the name from the town of Banaras or holy city, Varanasi, which is the constituency of our Honorable Prime Minister Modi ji. He had said, भारत में शायद ही ऐसी कोई महिला होगी जिसके पास बनारसी साड़ी ना हो. There are again various types in Banarasi saris depending on the material. So if organza is used, it is called as Kora Banarasi. If silk is used, it is called Katan Banarasi. Here all the 3 snaps are of Katan Banarasi. This red one I was tempted to buy after seeing Anushka Sharma's wedding snaps in red silk Banarasi sari. The middle one is with geometrical pattern, and the last one, pink, is with contrast blue border, and here you can see the running blouse. Now, embroidered saris. There are various types of embroidery, and embroidery makes it look very elegant. I have chosen only 3 snaps. The first one is Georgette embroidery sari with brocade jal embroidery. The middle one is navy blue sari with Kashmiri embroidery showing paisley pattern. And the third one is black net sari with kotapatti flowers and pearl embroidery. All 3 saris here are with the running blouses, no mix and match here. Now we come to some other varieties which can be worn for family wedding. The first one, magenta pink, has a certain chic quotient. It is called as jute silk. They are very durable saris. It is a mixture of jute and silk, mainly manufactured in West Bengal. One in the center is called Khaddi Georgette. Khaddi in UP means handloom, and this has a dual tone. Again, mix and match blouse. And the third one is, any guesses here? Third one, very famous sari.
Patola?
Yeah, Patan Patola. Patan Patola has derived its name from the town of Patan, which is in Gujarat. It's a handloom heritage of Gujarat. The full sari is hand woven. That's why it is the costliest sari. Now, saris for special occasions, like I said earlier, small occasions like birthday party or engagements or naming ceremony, etc. We begin with Khand sari here. Khand is a very culturally significant material in Maharashtra as well as Karnataka. Classic purple and reddish border can be seen. To give a traditional look, I have trimmed it here with traditional pearl jewelry, chinsapeti, traditional neck piece of Maharashtra, and bugadi in my pinna. Kopaddam soft silk is very popular in Andhra Pradesh as well as Telangana. The name soft silk, it becomes soft because it is a combination of 75% of silk with 25% of cotton. Very soft and very comfortable. You can drape it for the whole day. Now comes the sari, Kasuti or Karnataki Kashida. Again reminding me of the famous Marathi song, or Lavani you can say. रेशमाच्या रेगांनी लाल काळ्या धाग्यांनी कर्नाटकी कशिदा मी काढीला हात नगाला ओ माझ्या साडीला. So Karnataki Kashida is a very light traditional folk embroidery of Karnataka, and it uses the geometrical pattern which are derived from the temple design. Here it's a dual tone sari, and again mix and match blouse. Both the blouses, you can't see this side, but the maroon blouse as well as this orange, both are not from the sari but from some other saris. Now we come to Chanderi ki Nazakat. As the name indicates, Chanderi is a small town in Madhya Pradesh. That's why these saris have got GI, Geographical Indication Mark, from Government of India. There are again various varieties and various materials. Chanderi can be woven only in cotton, a combination of cotton and silk, or only in silk. And pattern wise, it can be plain sari with golden butta, or the last, you can't see the picture here, red and white sari is with block print. So this block print gives rise to full printed sari. A special mention has to be there about the maintenance of this Chanderi saris, what care needs to be taken. After folding this sari, you have to put it on the hanger. Never use hot iron or iron with water. Only dry cleaning is recommended. Otherwise, these saris may tear apart. Now coming to the queen of silks, known as Tussar silk. Talam Tussar, very soft sari, mainly produced in Jharkhand, West Bengal, Bihar, etc. And this yellow sari is with queen stitch embroidery. The pink one is a variety of Tussar. It is known as Kosa silk. Very soft sari, and it is derived from the silk, which is produced from the cocoons, which have not been put in the boiling water. Means the adult moth has left the cocoon and then the silk thread is derived. That's why it is also known as Ahimsa silk, and it is highly exported. So it is exclusively produced in India only. Now saris for conferences. First sari you see on the left side with white crop top is butter silk. As the name indicates, soft like butter with pestle pattern. And the next two varieties are Mysore crepe silk, wherein the silk is combined with polyester. The one in the middle is with brocade pallu, and the last one, only half the portion is seen. It is a floral print sari, which I had combined with a hand painted purple contrast blouse. Now coming to ikat, enchanting ikat. Ikat is an Indonesian word which means to bind. The characteristic pattern of ikat is the borders are very hazy. In first sari, maroon and black combination, you see diamond shaped hazy motifs with pestle pattern in the pallu, And the next variety is Pochampalli. Pochampalli is mainly manufactured in Andhra Pradesh and Telangana. Here, whole body is having small checkered pattern, and the border and the pallu has small diamond shaped hazy motifs. Now we come to Jamdani saris. Jamdani is a Persian word. Jam means flowers and Dani means pot. So Jamdani is a flower pot. So both the saris, you can see enchanting motifs of leaves and flowers are woven either in cotton like Chanderi, 3 patterns, cotton or combination of cotton and silk or only silk. A high quality cotton known as muslin is used, and the embroidery is done with a thicker thread. So these motifs appear to float on the surface of the base. Very elegant look. Now some other saris, tussar silk with kantha work. Highly popular in West Bengal. It uses the simple stitch, that is running stitch, and various motifs like trees, birds, that is owls, peacocks, etc. are used in this kantha embroidery. The next one, black and turquoise blue sari, is Assam silk. The state of Assam is very popular for its silk, various handloom silks. Various silks are popular there: Eri silk, Muga silk, Pat silk, etc. Only the half portion of the last picture is seen, Pashmina silk. As the name indicates, it is a combination of Pashmina wool with silk. So it is very popular in Kashmir to beat the chilling winters of Kashmir. The fabric becomes warm because it is mixed with the wool. Now we come to formal to semi-formal saris. Sometimes we have to attend some programs straight from our workplace. We don't have time to go back home and get ready. In such cases, we can carry the accessories in a pouch and drape the sari while leaving the house. So for such functions, we have cotton paitani, very easy breezy and very comfortable sari. This pink cotton paitani has lotus motifs in the palla. The next variety is called as supernet. It is a pista green color supernet sari with embroidery all over it. It is a combination of silk and cotton again. Looks very elegant, and the time you use is you can easily drape for 9 to 5 your working hours. Now, this is khadi silk, 50% khadi cotton with 50% silk, the first slide, and it requires only dry cleaning. The one in the center is satin silk, as the name indicates. It's a combination of satin with silk. And the last variety is a traditional Maharashtrian sari called as Narayan Pethi. It has a contrast zari border with Rudraksha motifs in it. And it is woven in Solapur district of Maharashtra as well as Telangana and Andhra Pradesh. So I thank all of you for your patient hearing and hope all of you will drape more and more saris in future.
Yes, definitely. I will start from tomorrow. one day I was
Dr. Vandana madam.
and I will wear these sarees. खूप असं मला आलं होतं की म्हणजे आधी खूप लहानपणी साड्या नव्हत्या म्हणून टेन्शन, आणि आता इतक्या आहेत आणि त्या केव्हा नेसायचे हे म्हणून टेन्शन.
Correct.
Definitely.
So we can always say that east or west, sari is the best, isn't it?
Yeah. Very, very true. I agree with you.
And whatever fashion may come in the international market, sari is here to stay till eternity.
Yeah, that's what I said. Saris forever.
They suit all figure types also.
Dr. Monica has written there are many other saris. Yes, Dr. Monica, we planned to keep Dr. Vandana's lecture for actually 2 hours, but we had to reduce it because of the time constraints. She has so much of material. I gave her these 5 categories. You speak on this.
I've not covered even 50% of my saris.
Yes.
Organza.
Dr. Rujita, you can remember for next year.
It's 3:55, ma'am.
Yes.
May I invite the next speaker, Dr. Tejaswini Vayumbe?
Yes.
For her one-act play.
Am I audible?
You are
Yes.
audible, but you have to share your screen.
Yeah. Yes.
Or is it live?
Yeah, it is live. So, Mukesh, can you do it full screen?
So Vandana, you have to stop the screen share.
Okay. Okay.
Yeah. And Dr. Tejaswini, you will be speaking live, if I'm not wrong.
Yeah,
I'm
yeah.
also ready as a backup.
Okay, no, but I'm speaking live only, so I want a full screen video.
Yeah, yeah. Once he stops the screen share, it will be full screen.
Yeah.
Dr. Vandana, can you just press stop screen share? Thank you, ma'am. Yes, ma'am. Dr. Tejaswini, you are there. Yeah.
Yeah, good afternoon. POS प्रेसिडेंट जादूगार डॉक्टर गीतांजली शर्मा ज्यांच्या जादुई पोतडीतून रोज सकाळी लेखक, पेंटर, समाजसेवक, सिंगर, डान्सर असे मोती आणि हिरे बाहेर निघत असतात. आणि आपला एन्थुझियास्टिक चॉकलेट हिरो डॉक्टर मुकेश पर्यानी, फेको मास्टर डॉक्टर सलीम पठाण आणि POS चे तत्वज्ञ आणि लेखक काबरा सर आणि संतूर सुकन्या रुजुता माचवे, POS संतूर सुकन्या आणि ग्रेट डान्सर आणि विविधता में एकता हा संदेश देणारी डॉक्टर हिमश्री, या सगळ्यांमुळे ही कॉन्फरन्स छान सक्सेसफुल झाली आहे. आणि बाकी सुद्धा कार्यक्षम सगळ्या POS कमिटीचे सदस्य आणि प्रेक्षक. आता पुढच्या 5-7 मिनिटात तुम्हाला थोडंसं हसायचंय. म्हणजे जरी हसायला आलं नाही तरी पण हसून घ्या, कारण कसं आहे, कोविड प्रिव्हेन्शनचं ते एक टॉनिक. माझ्या मराठीचे बोलू कवतुके, जरी अमृतातेही पैजा जिंके, अशी आपली ही मराठी मायबोली. आणि असं म्हणतात की दर 10 मैलांनी मराठी बोलीभाषा बदलते. आणि त्यातही आता कसं इंग्रजी हिंदी मिसळलेली, इंग्रजाळलेली आणि हिंदाळलेली मराठी ठेचकाळत कानावर येऊन आदळते, तेव्हा शुद्ध मराठीचा अभिमान असणाऱ्यांच्या दिलांचे तुकडे तुकडे होतात. आणि या भाषेतनं खूप गमती जमती घडतात. आता आपल्या डोळ्याच्याच क्लिनिकमध्ये बघा ना, कुणाचा डोळा लाल होतो, कुणाचा आग ओकतो, तर कुणाचा चावतो. आता डोळ्याला चिकट पाणी येणं हे सिम्पटम पेशंट कसे सांगतात. कुणाच्या डोळ्याला घाण येते, कुणाच्या डोळ्याला चिपड येतात, कुणाच्या डोळ्याला शेंबूड येतो, कुणाचा डोळा गळतो. आता तुम्ही म्हणाल का नळ आहे गळायला, पण गळतो, डोळा गळतो. एवढाच काय डोळा हाकतो सुद्धा. आणि आपल्याला कसं डॉक्टरला कम्युनिकेशन स्किल चांगलं असलं पाहिजे, म्हणजे पेशंटच्या भाषेत बोलता यायला पाहिजे. आता एक बबडे आला होता त्याच्या मम्मी सोबत डोळे तपासायला. मी म्हंटल, बेटा उजव्या डोळ्यावर हात ठेव आणि वाच बरं बेटा, आरशात काय दिसतंय ते. बबड्या पाहतो टकामका, एकदा मम्मीकडे, एकदा माझ्याकडे, एकदा मम्मीकडे, एकदा माझ्याकडे. मग बबड्याची मम्मी, डॉक्टर तुम्ही थोडं सोप्या मराठीत बोला ना, म्हणजे कसं इंग्लिश मिडियम मध्ये जातो ना तो, त्याला नाही कळत उजवंडावं. बेटा क्लोज युअर राईट आय अँड रीड, कॅन यू रीड लास्ट लाईन. म्हटलं तर खरं असं, पण राग असा आला होता, मेलेला उजवंडावं नाही समजत. पण आपल्याला कसं भाषा बदलावं लागतं. म्हणजे सदाशिव पेटी पेशंट आला म्हणजे कसं शुद्ध अस्खलित मराठी. थोडस प्रभात रोड, कर्वे रोड तिकडे तिकडे गेलं की मग मराठीला लावायचा इंग्रजीचा तडका. आणि तिकडे कोरेगाव पार्कचा पेशंट आला की काय करायचं, इंग्रजीला लावायचा मराठीचा तडका. नाही तर आपण जर एखाद्या कोरेगावच्या पेशंटला म्हंटल, ठणका मारते का डोळा, ती बाई कशी पाहते, व्हॉट डिस्गस्टिंग, सो डिस्गस्टिंग. काही बाई डॉक्टरची भाषा. पण आता कधी कधी अंदाज चुकतात. म्हणजे एखादा देशपांडे नावाचा पेशंट बघून आपण जर मराठी सुरू केलं तर बाई इंग्रजी झाडते. आणि एखादा पठाण, गुप्ता वगैरे अशा नावाचे पेशंट आले ना, तर आपण काय म्हणतो, पुणेरी हिंदी सुरू करतो. डावी आपको कम दिसता है क्या, पेशंट एकदम शुद्ध मराठीत बोलतो. आता या पुणेरी हिंदीवरून मला आठवलं, माझा नवरा एकदा ऑपरेशन थिएटर मध्ये पेशंटला म्हणाला, पहिले आपको भूल देंगे और फिर ऑपरेशन करेंगे. पेशंट काय म्हणतो, डॉक्टर साहब कुछ भूल हो गई क्या. काय समजे ना. म्हणलं, अरे भूल भूल म्हणजे मिस्टेक. हा अनेस्थेशिया देंगे. या अनेस्थेशियावरून एक आठवलं मला की विदर्भातल्या ग्रामीण भागात अनेस्थेशियाला सुंगणी शब्द, सुंगणी या शब्दाची उत्पत्ती कुठून झाली माहिती नाही, तर ते अनेस्थेशियामध्ये ते देतात ना सुंगायला, त्याच्यावरून झाली असेल, नाही तर आग सून करणे हिंदी शब्द आहे त्याच्यावरून झाली असेल. पण अनेस्थेशियाला सुंगणी म्हणतात आणि अनेस्थेटिसला सुंगणीचं डॉक्टर म्हणतात.
आमच्या पुणेरी डॉक्टर मित्रांनी हा शब्द ऐकला आणि त्यांना काही हसू आवरलं नाही. जेव्हा मी नागपूरहून पुण्याला आली ना पहिल्यांदा, तर तेव्हा एक डॉक्टर मला म्हणाले, तुम्ही विदर्भातले म्हणजे ते 2 क्रियापदांची भाषा बोलणारे का? म्हणलं हो हो, म्हणजे ते जाऊन राहिली, करून राहिली, करत आहे, जात आहे, वगैरे वगैरे. आता या 2 क्रियापदांच्या भाषेची एक गंमत झाली. एकदा माझी बहीण गेली होती कोथरूडच्या देवळात आणि गुरुजींना म्हणाली, गुरुजी देवाला फुलं वाहून द्या. गुरुजी काय करतात? देवाला फुलं वाहिले आणि आणून दिले परत. नका हो गुरुजी, फुलं का वापस दिले? मग तुम्हीच म्हणाला ना फुले वाहून द्या म्हणून, वाहिली आणि दिली, मग फुले वाहा असे म्हणावे. हा बरोबर आहे, बरोबर आहे. म्हणजे कसं पुणेरी लोकांचं व्याकरण बरोबरच असतं ना, मग बरोबरच म्हणायचं. तर एक जण मला म्हणाला, तुम्ही ते नागपूरचे म्हणजे बेबे म्हणणारे का? काय करून राहिला बे? हो, आम्ही बेबे म्हणणारे, तुम्ही किती म्हणणारे, जाऊ की, करू की, असं सगळं. आता एकदा काय झालं, आमच्या इथे कोकणातली सिस्टर जॉईन झाली. मॅडम मॅडम मी तुम्हाला सांगतो, ते रिसेप्शनिस्ट ना मला हसतात. आता तुम्हीच सांगा काय चुकीचं बोललो मी? आप्पा बलवंत चौ, काय चुकीचं बोललो? काहीच नाही, काय चुकीचं बोललो तू? आप्पा बलवंत चौ. जाऊ दे, लक्ष नको देऊ म्हणलं. आणि एकदा असं म्हणजे वेगवेगळ्या ठिकाणचे येतात आमच्या क्लिनिकमध्ये लोक, मराठवाड्यातली ऑप्टोमेट्रिस्ट. असं केबिन बाहेर पेशंट उभा, तर कशी म्हणते, काका इथे काय उभारले, काय करायले इथे? मध्ये या, मध्ये या, मध्ये या ना काका. काका आपले उघडी हो. म्हटलं काका आत या. मराठवाडी भाषेत ना आतला मध्ये म्हणतात. तर अशी गंमत होत. एकदा मेडिकल रिप्रेझेंटेटिव्ह आली एक मुलगी, मॅडम तुमचा 5 मिनिटं टाइम भेटेल का? म्हटलं 5 मिनिटं काय 10 मिनिटं भेटेल, बस बस. मग सगळं झाल्यावर तिला जाताना मी सांगितलं, बाजूला जाशील ना सरांच्या केबिन मध्ये तर 5 मिनिटं वेळ मिळू शकेल का, असं म्हण. हे भाषेत फार अडकतात लोक. हो हो मॅडम तुमचं बरोबर आहे, आता ना मी माझी भाषा दुरुस्तच करणार आहे. अगं दुरुस्तच आहे तुझी भाषा, थोडं पॉलिश गिलिश मारलं की झालं. आता असं वेगवेगळी बोली भाषा, सातारची अजून वेगळी. म्हणजे ते कसं म्हणतात, जावा राहावा करावा खावा. एकदा आमच्या सातारच्या मामे सासूबाई आल्या आणि आमच्या सासूबाईंना म्हणाल्या, प्रभाती तुम्ही जरा पडा ना जेवण झाल्यावर. म्हणजे प्रभाती त्यांना म्हणतात, वहिनी तुम्ही पडा ना. म्हटलं काय बे एकमेकांना पडायचा आग्रह करतात, फ्रॅक्चर पिक्चर होईल ना. तर तेव्हा मला पहिल्यांदाच कळलं ना पडा म्हणजे झोपा. आता ते मुंबईचं अजूनच वेगळं आहे. हा त्याचं गुजराती इंग्लिश मिश्रित आणि ते पाठी काय म्हणतात, पाठीमागे काय चिकटलं नाही, पाठीमागे असं. आता मी कसं नागपूरला राहिली, मुंबईला राहिली, पुण्यात राहिली, पण आता बराच काळ माझं पुण्यात वास्तव्य आहे म्हणून मी स्वतःला पुणेकर समजते. तर आता पुणे नागपूर प्रवास हा फार गंमतशीर असतो. म्हणजे विदर्भ, खानदेश, मराठवाडा, वेगवेगळ्या भाषेची घेल म्हणजे उच्चारण्याची पद्धत, आणि आलूबोंडा, दही भात, वडा भात, थालीपीठ, वेगवेगळे सुवास दरवळत असतात. एकदा मी अशी चालली होती, तर माझ्या डब्यामध्ये एक विदर्भातलं ग्रामीण भागातले कुटुंब होतं. म्हणजे एक सासू सून आणि एक भ्रात्य मुलगा. आता पोट्ट म्हणा नाही तर कार्ट म्हणा होतंय. आणि बाजूच्या डब्यात होते पुणेरी जोडपं. तर ते पोट्ट काय करत होतं माहितीये का, सारखं थोड्या वेळाने बाजूच्या डब्यात जायचं यायचं, बाजूच्या डब्यात जायचं यायचं परत, जसं सर्कशीतला वाघ बसला बाजूच्या डब्यात. मग त्याची आई म्हणाली, काहून असं फैताडावानी करून राहिला रे, सारखा बस. आणि ते सासूला पण म्हणत होती, काय इबलीस पोट्ट आहे पहा ना. आणि ते बाई पाहते ना घाले डोळे मोठे मोठे करून, पुण्याची आहे ना ते, पाहिले पाहिजे भांडण तंटा. असं सगळं चालू होतं. त्या पुणेरी काकू जातात जळजळीत कटाक्ष टाकून अशा बाजूनी, आणि तिकडे बसले होते भाऊ आपले नागपूरचे बटाटे हे खात होते, आलू बोंडे. आणि ते आलू बोंडे खाता खाता त्यांनी आपले टिंगल टवाळी सुरू होते. ते पुण्यात असते ना ते लग्नात मिनी बटाटे वडे छोटे छोटे असते वडे, त्याची टिंगल टवाळी. आणि त्या या गदारोळात एक तरुण बसला होता आपला लॅपटॉप नजर रोखून बसला होता. मी असं पाहिलं त्याच्या लॅपटॉपच्या स्क्रीनवर. तसं कोणाच्या लॅपटॉपच्या स्क्रीनवर बघू नये, सभ्यपणाचं लक्षण नाही ते. पण बघितलं आपलं काय चालू, चायनीज आहे का तसं कानातलं काढून. काय काकू, नाही चायनीज आहे का, म्हणजे कसं आपल्याला सगळे चपटे चायनीजच दिसतात ना म्हणून विचारलं. नाही काकू ते कसं आहे ना, कोरियन सिरियल आहे ती, आणि होमनेम का काहीतरी नाव सांगितलं त्याने. तुम्ही जर पुणे नागपूर कधी आगगाडीचा प्रवास केला असेल ना, तर पुण्याला शिक्षणाच्या किंवा नोकरीच्या निमित्ताने आलेले तरुण तरुणी तुम्हाला हमखास दिसतील. हे तरुण काय करतात, कायम तसे कानात इयरफोन, हातात मोबाईल नाही तर टॅबलेट मध्ये व्यग्र. गाडी सुरू झाली की वरच्या बर्थवर जाऊन बसतात. स्टेशन यायच्या 10 मिनिटं आधी खाली येतात, आपलं सामान घेऊन पसार. असाच तो तरुण होता, कोरियन सिरियल बघत होता तेवढ्या, आणि कुठला होता, मूळचा अकोल्याचा. तेवढ्या शेगावाला, शेगावची कचोरी आली. मला म्हणतो, काकू तुमच्या पुण्यात कसं वडापाव फेमस आहे ना, तसं इथे शेगावला कचोरी आहे, खाऊन बघा ना. म्हटलं, अरे माहिती आहे रे, मी विदर्भातलीच आहे. कोरियन सिरियलचा आनंद लुटणारा, अमेरिकन कंपनीत काम करणारा आणि शेगावच्या कचोरीवर प्रेम करणारा, हे विश्वची माझे घर, असं खरं आयुष्य जगणारे हे तरुण तरुणी पाहिले की वाटतं, पुणेकर, नागपूरकर, मुंबईकर हा वाद किती व्यर्थ आहे नाही का. प्रत्येकाच्या मनात आपल्या गावच्या मातीचा एक सुगंध असतो, तसाच गावच्या बोलीभाषेचाही सुगंध दडलेला असतो. मग शुद्ध आणि अशुद्ध भाषेचा प्रश्न उद्भवतो का? नाही ना. धन्यवाद.
अमेझिंग, अमेझिंग.
खरंच छान. सगळ्यांनी म्यूट केलं होतं म्हणून बरं आहे, नाहीतर सगळ्यांच्या हसण्यामध्ये तुमचं बोलणं परत थांबून.
खूपच छान तेजस्विनी. Excellent. Yes, excellent. If there are any seniors here, we have one talk left. Special GBM is at 4 o'clock. So can we request for special GBM after 10 minutes, please? Can we do that?
Okay.
Is it possible?
Hello. May I say one thing? Actually, you can announce about special GBM, adjourn it. In between, you can have that talk, and then you can again start with the special GBM, so that adjourning thing can be done.
Okay, Dr. Mukesh,
10 minutes.
wait then.
Yeah, so we would like to have a special GBM. I think lack of quorum, and also we'll adjourn it for 10 minutes so that we can rejoin in 10 minutes and have the GBM again.
That's fine.
Okay, Dr. Seema, you start, and moderators, I just request you to cancel my talk. Okay, thank you.
You all know with freedom comes a great responsibility. And yes, when we are independent women, we have to know not just a little bit, but much more in finances. And here there is Dr. Seema Khere, our tech-savvy joint treasurer, to give her talk. Welcome, Dr. Seema.
Thank you, Dr. Rujita. Good afternoon, all. At the outset, I would like to thank Dr. Gitanjali Sharma, the most innovative president of POS I know till date, for giving me the opportunity to have a conversation with all of you today afternoon. See, इतकं सुंदर साड्यांचं पाहिल्यानंतर, कोविडमधल्या चॅलेंज पाहिल्यानंतर, आपल्याला मनसोक्त हसवल्यानंतर तेजस्विनी मॅडमनी आपल्याला जर जीवनातला खरा आनंद हवा असेल, शांतता हवा असेल, मनशांती हवी असेल, तर येस, तुमची बँक एकदम सिक्युअर पाहिजे. So I'll be talking about the finance, which is a very simple subject. Believe me, much simpler than doing a FACO. So next question is, why do we need a financial planning? So very obviously for carrying out of various responsibilities, maybe education, maybe medical emergency, and so on and so forth. You all can see a statement written on the screen. COVID lockdown had no financial impact at all on me. So I just want to know how many of you agree with the statement. Those who agree, please write yes. Why? And those who don't, please write N in the chat box. I'll give you 10 seconds. Few more questions. I want to know how many attendees, especially women practitioner, know their net profit over last 3 years. Right? Yes. Why if it's yes, and N if it's not known. Few more seconds to write your answers. Another question, how many attendees have some kind of loan availed and even now they're paying EMI? Few seconds, because of the time constraint, I'm not giving much time to answer. And last question, do you get passive income? If yes, write Y, and no, write no. See, what is a passive income? That is, even if you are not going to a clinic or hospital, your EMIs and your salary and other all headaches are paid by somebody else, by your passive income. Thank you, audience, for your valuable inputs. Now we all know our situations. So let's begin. Okay. What is financial freedom? When your passive income is more than your active income and you have both your time and money. This is a financial freedom. म्हणजे काय? समजा तुम्हाला कुठे फिरायला जायचंय तर जाताना किती दिवसांची सुट्टी हे टेन्शन नको. छानपैकी तुम्हाला पिकनिक एन्जॉय करता आली पाहिजे. तुम्हाला आल्यानंतर EMIचं सॅलरीचं प्रेशर नको. मनशांती आणि आनंद जगता आला पाहिजे. So how you can achieve? So your investment or business planning should be done in such a way that, for example, 10 years, say 10 years or 15 years, you have income from your business or investments to make you financial free from financial burdens. So it doesn't mean that you practice only for 10 years or 15 years, but you should be financially not burdened for new ventures, opportunities, and innovations. So you all know when we start our practice, how we get what is our income source is from the OPD and IPD, and expenses are you are all familiar that EMI, salary, so on and so forth. So our financial graph should go such a way that your passive income, like maybe from real estate, gold, mutual fund, shares, and other investment, should be more than what you earn through your OPD and IPD. So how? So I'm going to share my experiences. So real estate, it is more liked by doctors and many people. So in real estate, mainly you get a rent. Maybe your commercial property, maybe your flat. The rent is a main revenue generation thing. So here I want to tell, whenever you are getting a rent, that should be greater than interest you are paying. For example, you buy a shop and you have to pay XYZ amount interest on that as your loan for that particular shop. When you are taking a rent, it should be little more than that. But remind, like let me tell you, like when you buy for the first time, the interest paid is more, and rent is going to have a increase increments. So take your call. See, real estate is a very proven good method for wealth creation, but profit is when you are buying, especially when you want to sell some your real estate, maybe your house, maybe flat which is not owned by you, or you have done it for your investment. You have to quote less than the market price. Agent charges are there. So real estate is a gold standard, but when it comes to liquidity, it has less points. Gold, uh, very intimate thing about the woman. Gold, it's very liquid cash is very easy, but remember, there is a capital gain tax, which is approximately 20% all your gold income. The risk of robbery is there, so buying a gold bond for your investment is safe. However, the rise in the wealth generation is little less, but still it is a good option. See, thirdly, I'm talking about the mutual fund. It is very secured and most popular among in the India, because there is no active time required. So you do the SIP, and from the bank, the funds are directly directed towards the mutual fund. But profit is around 3%. And if the agent is involved, he takes 1%. And see, suppose you are getting a 10% increase in mutual fund, 1% of agent, and 6% cumulative taxes. So 7% are to be deducted from 10 minus 7. So 3% average growth is possible with the mutual fund. Let me talk about the shares. Shares is a very good option for the investment, and profit is compulsory. Let me repeat, profit is compulsory, but only if you know how and where to invest. You should need to read books and understand and then go ahead. सी वेनेवर जेव्हा जेव्हा शेअर मार्केट इंडेक्स याबद्दल बोललं तर खूप मोठा फोबिया किंवा सट्टा असं काहीतरी एक निगेटिव्ह फिलिंग आहे. जस्ट बिकॉज आपल्या त्यातलं नॉलेज नाही. समजा आपल्याला काही कारणासाठी सोनं घ्यायचंय, तर सोनं घेताना आपण काय करतो, अरे मला हे 3-4 गोष्टी माहिती आहेत की इट शुड बी फ्रॉम PNG और Tanishq और Ranka. का? Because they are proven in the purity and quality. So similarly, if you know, you have a basic knowledge about the shares and good companies, the profit is compulsory. So let me give you some tips regarding share, or whatever I do in my investments. So whenever you are choosing a company to invest, the company should have more than 10,000 crore market capitalization. Second point, you should look that its debt should be less than 0.1, and it should have an increasing trend of sales, dividend, and tax paid. And very importantly, the share of the owner. This particular thing was shared to me by Dr. Sachin Kabra, our own treasurer. See, if a company has a share of the owner, even if the company is in loss, he'll make all the efforts to bring that company into the profit. So his money as well as our money is safe. Then now we know where we can invest. Now, how much money we should invest? So whatever revenue you take, 20% of that should go in your investment and 80% for your expenses. All expenses we know, EMI, salary, taxation, etc. See, when it comes to financial management, the loans are inevitable because loans are required at some point or the other. But one, you should know which are loans to can be which are good or can be taken and which should not be taken or avoided. So one should avoid personal loan, car loan, credit card loan. So if anybody has this particular loan, try to close them early. And housing loan, business loan, or instrument loan are okay because you are going to grow or have a increase in your finances with this particular loans. See, these are all my personal experiences and my study things. So I recommend to have an expert opinion, and others can have a different opinions. So coming towards the end of my presentation, I would like to end my presentation with a quote. Life does not provide warranties and guarantees. It only provides possibilities and opportunities. Don't miss them. Make best of it. Thank you very much for your patient hearing. And I wish you all good luck in your financial ventures. I hope this presentation has given some insight and you will all start financial planning very confidently and achieve the goal. Thank you very much.
Thank you, Seema.
Yeah, thank you.
Most of us are financially illiterate, I feel, planning. So all of us need to learn from you and by reading. And I hope everyone would be inspired by your.
Gitanjali, I would like to add, I'm coming up with a program on investment and financial planning on 25th of April. That is for the South Ophthalmological Society, which will cover all this: real estate, mutual funds, share markets, tax planning, everything. So make it a point for everybody to attend. Everybody will be financially literate then.
Yeah, sure.
Thanks.
Dr. Marathe sir, can we start the special?
Ma'am, officially conclude the conference, ma'am.
Yes.
Please, we'll conclude the conference and then this thing. Ma'am, can we conclude the conference? Can we have the vote of thanks with Dr. Sachin, sir?
Yes, if he is there.
Yes, ma'am.
Hello, am I audible?
Yes, sir. Yes, sir. Please go ahead, sir.
Hello.
Yes, sir. You're audible.
Yes, one minute. Yeah, on the behalf of Pune, our President, Dr. Gitanjali Sharma ma'am, and Secretary Dr. Mukesh, all management committee members, and Team POS, wish to thank all of you for joining for this conference. A special thanks to our chief guest, Rubal Agarwal and Dr. Ganga Khedkar for gracing today's occasion. Special thanks to our patrons, Dr. Kekar sir, Dr. Zamwar sir, Deshpande sir, all past presidents of POS, MOS, and various dignitaries of AOS who joined us today for this conference. A special thanks to Dr. Sanjay Patil, who has been our MMC observer for this. And we are happy to announce that we are getting almost 4 MMC points for the conference. Special thanks to our awardees, Dr. Vajanti Devdar ma'am, Dr. Sanjay Shah sir, all other awardees, and the sponsors of awards, Dr. Kekar sir, Zamwar sir, and Prabhu Desai ma'am and sir. Thanks to Dr. Ramesh Murthy for making the excellent souvenir and the poster for the POS conference. Thank you all PG teachers, all MC members, especially Dr. Himashri, Dr. Tarkude for making beautiful presentations. I wish also to thank our previous team of Dr. Saruna Joshi ma'am, Dr. Baban Royce, Dr. Kulte, and our also gesture of gratitude to our next team, Dr. Tekavade, Dr. Rujuta, and Dr. Seema I hope they will take the POS to higher level. Special thanks to our digital partner DigiShield and our pharma support from Bayer and Sun Pharma. And more importantly, thank you all of us for joining this for a wonderful conference and making great success. Special thanks to our team leader, Dr. Gitanjali ma'am, for leading us all the way and putting the program in perspective. And a very big round of applause for none other than our secretary, the main batsman, Dr. Mukesh, for single-handedly managing all the sessions so well. Thank you one and all for joining us today. And sorry if I missed out anybody. Thank you for them also.
Yeah, I would like to thank Agarwal Group for sponsoring this time's souvenir. And I would also like to thank Dr. Vijay Jathar sir for the award for free paper. He could not attend today morning's program, but if he is here, sir, I would like to thank you. Your award has been given to Dr. Harshita Sharma for the best free paper. Thank you. Dr. Mukesh, anybody?
Yeah, no, thank you, DigiShield, and thank you, Piyush. I would first tell Piyush to now stop the webinar recording live on YouTube.
Okay.
Once it is done, then I want you to start recording again and have a separate YouTube link which you're